Check, check, one, two. Yes, we can. Check, 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 check.
Sorry, hello. Hello. Hello, Rahul. Hello.
Hello.
हाँ, आवाज आ रहा है राहुल?
हाँ आ रहा है।
आ रहा ना? ठीक है, करेक्ट।
ये हेलो।
हाँ हाँ।
हमारा वॉइस क्लियर आ रहा है, हमिंग कुछ नहीं आ रहा है ना?
नो हमें।
हाँ। ओके। चेक 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 1 2 हेलो चेक अरे
ಹೇಳಿ ನಾ ಸ್ಟಾರ್ಟ್ ಮಾಡ್ತೇನೆ.
Okay, camera on. Sachin. Ready? Stop. Ready.
check, 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 check.
Hello, good morning. Who is helping us? Who is the host for this virtual thing? Sir, good morning.
Good morning, sir.
Sir, good morning. You are muted, sir. You are on mute. Dr. Rajat, I think you are on mute. Who all are coming virtual? Dr. Rajat, very good morning. My voice is audible?
Yes, sir, it's audible.
Pardon?
Yes, it is audible. It's clear.
Yeah. How to coordinate with the physical thing? Actually, like we were doing completely virtual or completely physical. So in the hybrid mode, I think some of the faculty will be physical, no?
Yeah, some of them. I think they will connect this room to the main conference. I think I can hear some sounds in the calls which they're making.
Okay.
I think once that is our turn, I think they will connect us to that.
Hello.
Good morning.
Hello, Dr. Sai. Hi. Good morning.
So you are also joining virtually only?
Yes, sir. Yes, sir. I'm also virtually only, sir. In the hospital only.
Oh, okay.
Hi, Dr. Rajat.
Morning. This is the first session of the day, I think. Maybe they've not all gathered together.
No, in fact, I
At
was
the
there
venue.
physically yesterday. The
Were you?
8:30 session started at 10 o'clock only because
Oh God.
they have to commute a lot to host from Bangalore. They have to take a
Yeah,
bus
yeah.
and go to Hoskote.
Okay.
So the organizers have told that, sir, we'll start by 10 only because a lot of people are still on the way.
Oh dear. Okay. But that was for workshop.
Yeah. But that was the first day. So everybody's staying there. Whoever's come from out of station, no, they are staying
I
there.
get it.
So today should be on track.
Yeah, today it should have been started in that time only.
Yeah, true. Fingers crossed because all our commitments beyond 10, we have put our commitments now.
Yeah. That's what. I actually went to the hospital and came back. That's fine. I think we can hold the fort till.
Yeah,
Anyone from Neocon admin, can you just give us an update of any kind of time scale? Probably they also don't know. Usually the first session and the last session is a pain.
True.
The national conference also, I think it's the same venue.
Yeah, surprisingly. But yesterday there was a consensus about is it okay or how is it going to be? Because initially the Whitefield Sheraton, they were talking.
Okay, there was some discussion.
Then how is this one is what
Correct. Yeah.
Dinagar was asking the feedback.
Okay. So it's not decided yet. Okay.
Not hopefully.
Yeah.
How are the workshops yesterday?
Workshops, no, it is quite a lot. So what happened was a few workshops, no, only 2 people, 3 people, delegates turned up. No, hypothermia, only 2 students, delegates were there. Faculty were about 10 people. So that was 2. Then TPN workshop was only 2. Ventilation, because of the fascination, probably 20 people were there.
For NRP, I think
NRP 90 people were there. NRP always, I think they have to have the certificate at least once for the exam. So I think there was a huge crowd there.
No, I can see the
Venue.
live screen.
Venue.
Usually they'll have a backstage, so hopefully they're not relaying what we are actually saying. If we are, then I think we'll mute ourselves. Usually, you know what happens? There is a backstage where it's not still live streamed, but it says live on YouTube. So,
Okay. So it's continuously being projected.
I think so. So I'm just going to mute myself for some time.
Sure, sir. I mean, it's same thing here. So once people are, we are starting, no, we think we can get to join again. We
can start at the time probably after a few minutes.
Yeah, definitely, sir. In fact, yesterday,
I think like we have only 45 minutes time now. So initial introductions will take some 5 minutes or so. So let's be brief and crisp.
Definitely, sir. That's more important.
Possible. Yeah, I will try to finish off in time rather than
exactly
the things.
Definitely. That's everybody's plan. So we'll go on time, definitely, hopefully.
So first 4 or 5 questions are like simple questions. So we can give 1 minute answers. And subsequently, like probably a couple of minutes we can take for subsequent questions.
Definitely, sir. Definitely. Fine.
Okay. A very good morning to one and all who are present here. We are so honored to have all of you with us this morning. And we are all part of the NNF family. And I would like to welcome all of you to the annual 2021 South Neocon Conference. Well, after a lot of hurdles and a lot of struggles and a lot of contemplation, it's so good that we have this conference physically finally with us. But there are glitches where we don't have everybody with us today physically. And this panel, especially, we have so many of us virtually, but virtual or physical, the world now, everything is so connected. So we are so happy to have all of you with us. So this morning, we're going to have a set of panels of almost 8 panels throughout the day, and so many people coming and giving their input via the net or even over here. And we are so excited for these 2 days because we are students, and I'm sure all of us acknowledge that all of us are students in some way, and we are going to learn a lot and a lot and a lot of things in the next 2 days to come, and that is our hope. And today, just a few ground rules before we start. We have sanitizer desks outside. We are moving into the endemic zone from the pandemic zone. And I would like to request everybody to keep your masks up while you are in. If you want to breathe fresh air, you can walk out and come back in anytime, except the panelists and the moderator during that session. And you can use the sanitizers whenever you feel free. The washrooms are right here. And let's, without any further ado, move on to the panel. So each panel today will be for about 45 minutes. And the end of 30 minutes, 15 minutes before, we will ring a bell so that you are aware of how much time is left to continue. And we hope everything goes on smoothly today. Well, there is an English proverb, I'm sure all of us know, and we've all used it, at least in WhatsApp statuses, which says, no pain, no gain. Today, a different setup of it. We are here to gain knowledge about pain. So let's move on to the first talk, that is management of pain in neonates. Over to you, Mihika and Vinisha, to take over the session.
Thank you all. We are very happy to have you here. So without further ado, I would like to start off with the first panel, the topic being management of pain in neonates. And we have a chairperson here, Dr. Malla Venkateshwara Rao, who's a consultant neonatologist at from AP. And thank you so much, sir, for being here. Dr. Vijay Kulkarni, sir, who's professor in HOD from Dharwad, Dr. Krishnappa, who's from Kolar, and Dr. Jalil Coimbatore, and Dr. Suresh Vishwanath from Salem. So Dr. Malla Venkateshwara Rao, can you please introduce our moderator for today, Dr. Sai Sunil Kishore. Thank you, sir.
Good morning, all the panelists. Sai Sunil Kishore is both MD and DM from the PJ Chandigarh, and he is the chief neonatologist from the Medicover Visakhapatnam. He had so many publications, nearly 35 publications. 16 are international, mainly on the ventilation, nutrition, and the vaccine transmission and sepsis screening. And national is almost 19. His areas of interest are non-invasive ventilation and point of care ultrasound. Thank you.
I would like Dr. Sai Sunil Kishore to introduce our panelists for today's talk. Thank you, sir.
Yeah, let me share the screen. It's coming host disabled participant screen sharing. Can you look?
Just a minute, sir. We are identifying the problem. So are you able to share the slide now?
Just give me a minute.
Sure, sir.
Yeah, are you able to see my screen?
Yes, sir. We can
And
see, sir.
my voice is audible? Is my audio and video are fine?
Yes, sir.
Yeah. Thank you, sir. Thank you very much for that kind introduction, and very good morning to you all. And I thank South Neocon organizers for giving me this wonderful opportunity to interact with you all today here on this Saturday morning. So without wasting much time, let's move on to the topic, management of pain in neonates. As healthcare professionals, we still tend to think that actually newborns are too little to feel pain. And most of us, even doctors, nurses, everybody, they have myths that they won't feel pain, they will forget. Even if they feel pain, actually there are no problems subsequently. And now actually there are evidence as well as literature is very clear that actually newborns, they feel pain. And because of that, actually they will have short-term and long-term problems. And definitely we can help them out, and we can help them in alleviating the pain and reducing the pain. So in this panel discussion, let's see how we can manage and how we can help these tiny babies to reduce their pain. So to discuss this topic, we have total 6 panelists. My slides are moving now. So Dr. Saravanan, who is a consultant at Rainbow Children's Hospital, Bangalore. He has done DM from Madras Medical College, ICH.
Sir, just a clarification, your screen is still being shared, so we are not able to start off the slides from here. So will you be sharing the slides, or can we start sharing the slides from here?
Yeah, I have already shared, so I'll do again. Just
okay, sir. Thank you. We will just share the screen from here, sir. We'll do it from here.
Just a minute. Is it okay now?
Yes, sir. That's perfect, sir.
Yeah, thank you. So to discuss this topic, we have total 6 panelists with me who want to share their knowledge and wisdom. So first panelist, Dr. Saravanan, he is consultant at Rainbow Children's Hospital, Bangalore. He has done DM from Madras Medical College, ICH. And second panelist, Dr. Rajat sir. He is lead consultant neonatologist at Kaveri Hospitals, Bangalore. He has special interest in neonatal transport as well as simulation. Third panelist, Dr. Venugopal. He has done DM from AIIMS and currently working as associate in Department of Pediatrics, Shimoga Institute of Medical Sciences, Karnataka. And Dr. Srihari, who is a senior consultant at SNR Hospital, Kolar, and earlier worked as professor and HOD at Oxford Medical College. And Dr. Abhishek, who is again consultant neonatologist at Indian Hospital, Mangalore. And he has achieved a gold medal in IAP Neonatology Fellowship National Level Exit Exam. And Dr. Narendra, who is working as assistant professor at Sri Devaraj URS Medical College, Kolar. So we have almost like 6 panelists with plethora of knowledge and wisdom. So I welcome all the panelists and thank you for joining us. So let's move on to the topic. Let me ask Dr. Saravanan, do newborn babies, do they perceive pain, and is it different in preterm babies and term babies, and does it vary according to the gestation?
Yeah. Hello, sir. Good morning. Thanks a lot for the opportunity. Well, the answer to the first question is, do newborn babies perceive pain? Definitely, it's a big yes. Now, how this emotion goes through. First is what is the function? I mean, how the baby is going to perceive pain and how it reacts to that. Now, if you go through the gestation age, by about 7 to 8 weeks itself, newborn babies do, I mean, the fetus itself has the free nerve endings. And by 8 to 10 weeks, that the spinothalamic tract matures that a baby can perceive pain. By 18 weeks, in fact, the hormonal changes you can see. By 24 to 26 weeks, the mechanisms to perceive pain are mature. Now, here there is a catch. That is, what is the difference in preterm versus term baby? So, fortunately or unfortunately, what happens is the mature pain, the pain perception mechanism or the network first matures. Okay, so a baby perceives pain, but what happens is then next comes the maturity of the descending neural pathways. So a baby can perceive pain, then how it responds to pain is what next matures. So what happens, a premature baby sometimes perceives the pain, but due to immaturity of the descending neural pathways, the pain modulation may be a little less. So sadly, a premature baby has greater pain and it takes a longer duration of pain because of the immaturity of the inhibiting pathway. So more and more a baby is premature, is going to perceive more pain, but the inhibition is lesser so that the pain lasts longer. So these are the main differences which we have to understand as neonatologists when we are thinking about pain.
So thank you, Dr. Saronan. So what Dr. Saronan is saying is, even in preterm babies, both them as well as preterm babies, they do feel pain. Even in preterms also, by 24 to 25 weeks, the pain pathways are mature. But the pain modulation, the descending pathways are relatively ineffective. So hence the magnitude of pain is more in preterms as compared to even term babies. So thank you, Dr. Saronan. So may I ask Dr. Rajat, sir, what are the effects of inadequately treated pain if you don't address at that point in NSU? So what are the problems we are going to face?
Sure, thank you. It's a very important question. So when we look at pain, there is pain and there is pain. So what I would like to draw the attention is that if you're just looking at acute pain, then you are looking at mainly the kind of cardiorespiratory events, increase in heart rate, blood pressure, and intracranial pressure. The one thing to remember is, especially in newborn babies, more so in sick term babies, and definitely in preterm babies, the cerebral perfusion is pressure passive. So whatever happens to the systemic circulation is immediately reflected. So there is a high risk of neuronal damage, either from bleeding or from white matter suffering ischemia because of these things. And obviously, we notice that the saturation comes down. And when we look at repetitive pain leads to a lot of physiological instability, baby not handling well, a lot of DSATs, a lot of BRADIes. And paradoxically, what we then do is do more tests and handle the baby more, and it becomes a vicious cycle for the baby that we're looking after. And also, we know that in a developing brain, especially the preterm brain, there are alteration in the immature nervous system. So these are structural alterations that we see, and this kind of can result in poor adaptive behavior, decreased pain threshold, and reacting as though there is pain to non-painful stimulus. So the noxious stimulus, the whole thing is modified. And then if I can look at the next slide. So what also we see is long-term. So we're thinking more and more, and there is a lot of evidence both in human models and in human studies and animal models. And especially our preterm babies are suffering a double hit phenomenon, because first of all, they're at risk of some neurodevelopmental sequelae, and pain is thought to be now, pushing into that kind of domain and causing effects. So as I said, cognition, behavior, pain processing, and ultimately the overall health, not only the mental health, but the physical health also we are looking at, because the neurodevelopmental pathways and immune pathways and metabolic response pathways are all very much interconnected. There is evidence. I mean, this will be a talk on its own. There are excellent review articles which we can look at. But if you do look at MRIs and functional MRIs, definitely the limbic system and subcortical systems, there are changes that can be seen. Thank you.
Thank you, sir. Wonderful message. So basically, what can happen is, like, if the baby is subjected to pain, especially repetitive pain, there can be a temporary as well as permanent changes in the brain, and subsequently which can lead to maladaptive behavior and long-term problems. Thank you, sir. So, Dr. Abhishek, what are the pain mechanisms in neonatal period? Just a brief 1 minute answer.
Yeah, thank you, Dr. Sai. So, like in any condition in neonatology, it is very important to understand the underlying.
Dr. Abhishek, we lost your voice.
And then one higher, that is at the spinal cord processing level, referred to as transmission and modulation. And then at the supraspinal level, that's at the level of the central nervous system, which is mainly the integration and perception of the pain. So this is just a chart describing all the processes together. So whenever the newborn is exposed to noxious stimuli, again, even in the older age group, there is a primary efferent nociceptor, which results in transduction and then transmission of the signal. Following this, the modulation and various structures within the central nervous system, like thalamus, cortex, all these play a very important role in the perception of pain. So we should remember that the neuroanatomical component in the neuroendocrine systems are sufficiently developed to allow transmission of painful stimulus in a neonate. And generally, they have a lower pain threshold. And it is very important for us to recognize that the newborn is in pain. So the neurotransmitter signals are upregulated, and the normal development of the pain system occurs even in the absence of noxious stimuli. Thank you.
Thank you, Dr. Abhishek. May I ask Dr. Venugopal now? Can you comment on the perception, the knowledge, awareness regarding neonatal pain among healthcare professionals? Dr. Venugopal, please. Just a quick answer.
Am I audible now? Yeah.
Yeah, you are audible now. Yeah.
Yes, sir. Thank you. Thank you very much. Thank you for the questions. And it's a very important question where the knowledge and awareness, whether it is aware of the and health workers or the treating doctors are aware of neonatal pain. Almost around 90% of the people are not aware of the pain until and unless they are going through in depth of the neonatal pain. They think that pain is neonate won't perceive pain, or it perceive very little pain, or the neuronal development has not yet occurred in such a way that they perceive a proper pain, or pain is not been transmitted because myelination is not there, or they will forget about the pain itself, even the perception of pain is there. So these are the different ways of perception. Even if you give any analgesics, the chances of addiction to that in the future will be there. And people also think that neonate can tolerate pain, or it will forget the pain in the future, nothing will happen. So these are the different way of thinking in the healthcare workers that has to be made aware for each and every health workers, so that we can tackle this one in the future. Thank you, sir.
So what Dr. Venugopal is saying is there is a lot of gap in the knowledge and practice, and there are a lot of myths regarding neonatal pain. There are many tools are available, but many units they won't use, and there is a gap in knowledge and practice. So thank you, Dr. Venugopal. Now, may I ask Dr. Saravanan, what are the manifestations of pain in neonates?
Yeah.
How do they manifest? What are the changes?
So this is a very pertinent question in terms of clinical behavior and clinically picking up. So usually we divide it into physiological, behavioral, and the biochemical manifestations. Physiological is what Dr. Rajat had already stressed on. I'm not going to detail. Basically, it's about changes in heart rate, respiratory rate, where along with the saturation dips and breathing pattern changes, along with PAMA, sweating, and facial pallor. Now, along with that, you'll also have a changes in the behavior in the baby, where a baby will show a facial grimace, crying. And what I want to stress here is something called as the increased body movements. Now, why I want to stress on in this era of virtual, for all you know, there would be a virtual NICU where 24/7 you're going to see a NICU on a computer. So for all you know, a few clues of the body movements will tell you that, okay, this could be just because of pain. One of the important thing in that is, in fact, they've done a lot of studies from the NIDCAP cohort. Now, this is a developmental cap program for which they analyzed babies in terms of stressed babies and stable babies. In that, the stressed symptoms or features which indicate pain, they found that a baby with a lot of extension of the extremities and splayed fingers. So these motor indicators of body movements, they found that nearly it's 80% correlates with pain rather than just stress alone. So all the neonatologists should be aware of a few body or motor movements which would correlate with pain, which would help us to pick it up a little earlier. Along with that, fussiness and sleeplessness also is an important indicator of pain also. Now, here I want to stress upon the gestational age-based differences in the clinical manifestation. For example, if you're doing a heel prick in a 27-weeker, for all you know, you may just find a changes in the heart rate, whereas the body activity, which I told now, may not be that apparent. Similarly, the facial changes would change over the gestational age. So it is a gamut of changes which gradually you have to get experience. So the most important thing here is the entire team and the sisters, everybody being on the same page in awareness. I'm not going too much into the biochemical changes. For example, you may find a increase in the cortisol levels and the epinephrine levels. I'm not stressing on that. So the behavioral and the physiological changes is what we have to stress on. Hope I answered your question.
Yeah. Thank you, Dr. Saravanan. So basically what Dr. Saravanan is saying is, like whenever you are handling babies in your neonatal ICUs, so there are some organized behaviors and some disorganized behaviors which indicate pain and stress of the baby. So if you see this slide, like first two things like flexed posture, smooth movements, they indicate organized behavior, whereas salute, extended posture, fingers play, they tell babies in pain. Similarly, disorganized behavior like hyper alert state, staring, grimace. So these are all the things actually which tell the baby is in pain. Irregular breathing, coughing, change in vital parameters. So all of them. So this is a gist of what Dr. Saravanan was trying to say. Now, may I ask Dr. Srihari, what are the procedures and events that cause pain and discomfort? A quick answer, 1 minute answer.
Thank you, sir. So whatever is painful for us should be painful for the child. It's only, as Dr. Saravanan has already told, that the intensity of pain might vary from a preterm baby or a term baby or maybe an adult who can tolerate it a little better. So most of the procedures which are done in the NICU or in the hospital are like your surgeries, the pain because of the stretching of the skin during the incision, or stretching of the organs, or any swellings where the tissue gets stretched up can cause the pain sensation. And common procedures like IV cannulas or drawing some blood for investigations, all these are painful procedures. Any swellings, infections also can lead to pain because of the tissue damage. And soreness because of continuously lying down on the bed. And nowadays, because of too many tubes coming onto the baby and going out of the baby, this excessive amount of tubes can cause pain. Any skin abrasions or birth injuries, even a simple diaper rashes, all these things can lead to pain.
Yeah, thank you, Dr. Srihari. So most of the procedures, they can cause pain. So we'll discuss that a little bit. So Dr. Narendra, can you classify the procedures based on the intensity of the pain? Like there are some procedures which cause severe pain, some moderate, some mild, and some chronic. So can you classify, Dr. Narendra, please?
Hello.
Hello, Dr. Narendra. Are you?
Yeah. Good morning. We can classify into stressful procedures or mild to moderate pain which can occur, or chronic pain we can decide. So stressful procedures, we are unaware that we are handling a newborn baby on an average. We are based on various studies. We will be on an average handling about 40 to 50 times a baby per day. Maybe for routine care, diaper changing, weight recording, BP recording, removal of adhesions, bladder compression, washing, stimulating messages, or all these procedures which cause mild pain for the newborns. We don't understand that they are experiencing this pain. These are some of the routine care that we take in the newborn NICUs. The moderate to severe pains are
routinely what we follow is IV cannulation while cannulating the baby or removing the IV cannulas, ventilating or extubation, venipunctures, arterial punctures, CPAP or HFNC or oxygen administration, nasal aspirations or tracheal aspirations. These are some of the procedures where we have experienced acute or moderate to severe pain. Chronic pain is persisting pain due to various infections like NEC or prolonged ventilation due to various reasons, any pediatric surgeries that has been done, or any chest drain which has been indwelling. It will be for a longer time. So the child will be, the neonate will be experiencing pain for a longer duration of time. So we classify as mild, moderate to severe, and chronic pain.
Yeah, thank you, Dr. Narendra. So what Dr. Narendra is saying is like we can classify based on the severity, and most of the proper procedures we do, they cause moderate pain like endotracheal suctioning as well as your intubation, ROP. So these are all the things, and routine handling. So and heel prick, so they cause mild pain. Now, may I ask Dr. Rajat sir, what are the techniques and tools available for objective assessment of neonatal pain? So till now we were discussing the symptoms, manifestations, as well as the severity. So what are the objective tools that are available?
Thank you. So obviously the tool is only as good as we use it. So there are lots of tools out there. I would have, had we had the chance to interact, we could have had a show of hand. A, whether people are, how many people are using pain scores, and B, what kind of different pain scores they've used. So before even assessing, I think we should probably get better at anticipating and identifying sources of pain. Some of the points that have already been raised. So pain is real, pain is felt. It's just that it's not happening to us when we are not aware of it. So identify actual or potential sources of pain and irritability. So what we should certainly have is a pain analgesia sedation protocol or a policy for a particular unit. So you can modify and please involve all your stakeholders. And the stakeholders, the most important person is the nurse at the bedside. So they should be involved in drawing up this policy with you. Yeah, so pain, so use a pain assessment tool. I'll just outline. So what we also say is that pain is probably the fifth vital sign. So if you remember TPR and SpO2 and pain as the fifth vital sign, that will not get missed. So, and another point I wanted to make is, especially in preterm, and if there is a prolonged noxious stimulus, the behavioral and facial grimace and other things might go off and the baby might just shut down. So it becomes extremely quiet and flaccid, and you might be conned to think that the baby is extremely comfortable. It's just a baby that has given up on you for not having identified that the baby is in pain. You will have to depend on the cardiorespiratory events. So there are various tools. The commonest ones are the pain assessment tool or the PAT, and there is a modified PAT or an MPAT, and the neonatal pain agitation and sedation scale or NPAS, and NIPS or neonatal infant pain scale, and premature infant pain profile, which I think we'll elaborate a little bit. So as we have been talking about, there's autonomic phenomenon. Next slide, please. Behavior, facial expressions then to be. So apologies for a very busy slide, and I've highlighted. So we need to be aware in the neonatal units, two things. One is whether it is applicable across various gestational ages. Here, I think two of them, like NPAS and PIPP, actually tick those boxes. And if you are ventilating and post-surgery sedation and other things are going on, NPAS might be more useful, because you will be assessing sedation as well as pain scores as such. So I'll let you summarize that, Dr. Sai.
Yeah. So basically, like we have a different pain scales. So some of them they include only physiological parameters. Some of them they include behavioral parameters. some of them, they are very useful because they incorporate the gestation age as well as whether you are using sedation or not. So it will adjust for the gestation age and nature of the pain, like whether it's a procedural pain, or post-operative pain, acute pain, chronic pain. So based on the different scales are there, but at least like we should know one or two important scales, and we should bring into our practice in our NSUs. So now, may I ask Dr. Narendra, because this is one of the common pain scale which is popular and which is being used more. So, Dr. Narendra, how will you assess by PIPP? Dr. Narendra, please.
There are basically 7 multidimensional composite measures that we use in PIPP. 3 are behavioral, that is facial actions like brow bulging, eye squeezing, and nasolabial furrow. So these are the 3 behavioral things that we have to observe while seeing for pain response. 2 physiological, one is change in heart rate and oxygen saturation, and 2 conceptual, that is gestational age and behavioral status. As it was spoken by the earlier speaker, that based on the gestational age, the behavior or response to the pain will be differing. So based on these indicators, we have the scoring system for all the 7 parameters, 0 to 3. So there are 4 categories. So in heart rate, if the change of heart rate is 0 to 4, before starting the recording of PIP, any painful procedure that we are doing, we have to observe the child for about 10 to 15 seconds, see the basic parameters before starting the procedure, record the indicators, and based on that, what is the score that is there. So after recording the initial records, then we have to do the procedure, and again we have to record within 30 seconds after the procedure and to assess. So can you go back to the previous slide, sir? Yeah. Here we see that earlier we had a different PIP, but now it has been revised so that there, instead of having a few changes have been made so that the scoring will be more convenient and accurate. The heart rate is change of 0 to 4 is taken as 0, 5 to 14, and 15 to 24, and more than 24. So in the same way, oxygen saturation, if it is in varying, and brow bulging, how long is it persisting, whether it is less than 3 seconds, 3 to 10, 11 to 20, or more than 20. Eye squeezing, again in the same way, the duration of these actions that has been response given by the babies. Then based on the gestational age, we have got more than 36 weeks, 32 to 35 weeks, 6 days, 28 days to 31 weeks plus 6 days, and less than 28 weeks. So again, we have got whether the baseline behavior, whether the baby is active and awake or quiet and awake, active and asleep, and quiet and asleep. So based on the state of the alertness, we can again have the score. Scores between 0 to 6, there is no need to take any action. If there is between 7 to 12, we can generally indicate slight to moderate pain and institute comfort measures. That is non-pharmacological measures. If it is more than 12, may indicate severe pain, and pharmacological intervention may be required.
Yeah, thank you, Dr. Narendra. So what Dr. Narendra is saying, actually, like this is one of the common scale which is being used in most of the NICUs for the routine assessment, and it has to be assessed at least once per shift, and after the procedure also. So it has got 3 dimensions. One is behavior, gestational age, as well as facial parameters, as well as your vital parameter change. So more than 12, you need to use pharmacological measures. 7 to 12, you can use actually non-pharmacological measures. Thank you. So these are some of the changes what we are trying to say.
A pictorial
yeah.
depiction.
So basically, like 2 important messages are like PIPP is used for acute pain, and it also adjusts for gestational age, and NPAS is used for prolonged pain, and if the baby is under sedation and analgesia infusions. So now may I ask Dr. Abhishek, so how to manage this pain? Like we have different methods. Some are non-pharmacological and some are pharmacological. So now let's, in the first 2 to 3 minutes, we'll discuss the non-pharmacological methods. May I ask Dr. Abhishek, what is the role of kangaroo mother care, non-nutritive sucking and music in alleviating this pain for these newborns?
Yeah, I'm sure all of us agree that developmentally supportive care plays a big role in terms of pain management. First of all, coming to kangaroo mother care, there is enough evidence to show that at least 10 to 15 minutes of KMC reduces crying, grimacing, reduces the heart rate during heel prick procedure in a full-term baby. KMC is also thought to provide an analgesic effect by enhancing the endogenous opioid activity. And of course, it's a very safe and effective method of reducing pain associated with any single painful procedure. So when it comes to non-nutritive suckling, definitely yes, especially in the age group of say something like 30 to 34 weeks at least, NNS reduce the time of crying and the heart rate increase during the procedure. So NNS for even 1 to 3 minutes before a painful procedure had caused significant difference in terms of pain in a newborn. So it's mainly thought to stimulate orotactile and mechanoreceptors in the neonate's mouth, causing the modulation of nociceptive transmission of endogenous non-opioid mechanisms. So evidence of its effect in reducing the immediate reaction to pain and of its calming effect on neonates and older infants during a heel prick. So definitely NNS is very, very effective. And music therapy, I do not think we need any evidence for that. Historically, Indian moms have been singing lullabies since time immemorial. So definitely it is going to help in the NAC also. Maybe some light Indian Carnatic music or the classical music definitely will have a soothing effect, not only on the newborns, but also on the treating doctors and the nurses. So it helps in stabilizing the newborn's breathing, improves feeding, and reduces pain. But yeah, by contrast, the environmental sound, the noise that exists with or without controls for volume, like the monitor sounds, ventilator beeps, can have an adverse reaction and it can be perceived as noise.
What Dr. Abhishek is saying is like your developmental supportive care measures as well as pain relief measures, they go hand in hand. So you can't separate one from others because kangaroo mother care, non-nutritive sucking are part and parcel of your developmental supportive care also. And KMC is an excellent tool and it has to be started around 15 minutes before the procedure. Non-nutritive sucking definitely useful, like sucking an empty breast. And other methods are like sucking a gauze piece, which is dipped in either sucrose or mother, like that. So it is a combination effect. Like it has got synergistic effect. We will come to that. So, but apart from suckling an empty breast, we don't promote other pacifiers, especially in India, because of risk of infection and it may hamper breastfeeding. So suckling empty breast, like in a relatively late preterm and term baby, is of course definitely useful. So thank you, Dr. Abhishek. Dr. Venugopal, let's discuss other non-pharmacological methods. Like there are methods called facilitated tucking, swaddling, positioning, multisensory stimulation. Can you throw some light on that?
Thank you, sir. Facilitated tucking is the where the baby is put in a flex position, universal flex position, and it is held firmly, so that pain will be received by the baby very less. As well as swaddling is the thing where the baby is wrapped with the clothes in almost in a firm way, so that baby will be in a comfortable position. In this position, where the baby receives or it perceives less amount of pain, or in the positioning where we are going to keep it in a comfortable position, the left lateral or right lateral position, and holding it firmly also decreases the pain. And another main important point is multisensory stimulation. Multisensory stimulation is a thing where we keep stimulating in a multiple ways with all the senses, 5 senses, like olfactory, visual, hearing, as well as sensory, touch sensory, where the mother will keep talking to the baby with a closed, very close to the face, or she'll be keep on speaking in a firmly way, or tackle the face massaging, or backside massage is done, or olfactory stimulation by the breast milk. By these are the ways where the multi-stimulation causes decrease sensory inputs to the brain, cortical brain, sensory part of the brain cortex, that decreases the pain. It is one of the another way of decreasing the brain stimulation. Thank you.
So thank you, Dr. Venugopal. So whenever we are doing these things, actually facilitated tucking, swaddling, there is a definite way to do it. So for example, facilitated tucking means like you need to keep the baby in a side-lying position, slightly flex the neck, and slightly flex at elbows, as well as hold the baby, and flexion at the level of hip as well as knee. So this is how you need to do that. So there is a specific way to do that. And similarly swaddling. So thank you very much, Dr. Venugopal. So basically this tucking can be used for 25 to 36 weeks babies, even for different painful procedures, including endotracheal suctioning also. And swaddling is beneficial, especially more for term babies. This is according to the evidence. Now may I ask Dr. Narendra?
Just 1 minute. The last 5 minutes, because already the time is 9:50 now.
Yeah.
So started 5-10 minutes late, but try to finish it by 5 minutes.
Yeah. So we are going to finish that. So how to manage pain in neonates utilizing pharmacological methods? We have discussed non-pharmacological. So now we'll move on to pharmacological for the next 3 to 4 minutes. Dr. Narendra.
Yeah, as we have, as per the PIPP scaling, we have got based on the severity of the pain, we may have to go from non-pharmacological to pharmacological. Here is a transitional phase where the child is having mild or moderate pain. In these stages, we can just add on sucrose, which is easily available at the strength of 24 to 25% dextrose, which has an effect on reducing the pain by releasing the endotrophin opioids like beta endorphins and analgesic, which lasts for about 5 to 8 minutes. If it is associated with non-pharmacological methods, a maximum benefit can be attained, and the side effects encountered with this is very less, and it is easily administrable. So it is at a dose of 0.1 to 0.2 ml for babies who are NPO. For preterm babies, 0.1 to 0.5 ml can be given. For late preterm and term babies, 0.2 to 1 ml it can be given. The sucrose solution is given orally by syringe 2 to 3 minutes before the procedure. If the pain persists or if the child is discomfortable, this can be repeated once in 2 to 3 minutes, but the effect will last up to 5 to 8 minutes. By having both the non-pharmacological and sucrose, the results are well attained, and instead of going for the analgesics, this can be easily controlled. The pain can be controlled.
Yeah, thank you, Dr. Narendra. So the sucrose is different, and the routine dextrose, which we use in our NSUs, is different. So it comes with a special preparation. So it has to be kept at the anterior part of the tongue, because 90% of the taste buds will be there. So it has to be kept 2 minutes before the procedure, and maximum dose is like 0.2 to 0.5 ml per kg, and combined with other methods like non-nutritive sucking. And our routine dextrose solutions, 10% dextrose, 25% dextrose, so they can be used like if you don't have sucrose, but they are less effective as compared to your 24% sucrose. So Dr. Srihari, can you discuss other pharmacological methods like paracetamol, NSAIDs, opioids?
I think it is relatively easy to give the pharmacological medications, because these are all just drugs which are available in our hands compared to whatever the other panelists have been discussing. The commonest is the paracetamol drops, which can be used. It's a time-tested medication, 15 milligram per kg per dose for any kind of pain. Apart from this, we can try and use some local analgesias just before doing the procedures to minimize the pain. And for severe pains where we can go for some opioids like morphine or fentanyl. If you're using morphine, the dose is 0.1 to 0.2 milligram per kg per dose subcutaneous, or can be given as an infusion of 0.01 to 0.02 milligram per kg per hour. For fentanyl, it is 1 to 5 micrograms per kg per dose. Apart from these, some sedatives can also be added along with these, like benzodiazepines are one of the best sources.
So the message is like the pharmacological methods, they are to be used only if it's really required. So paracetamol, the frequency depends on gestation. For very tiny babies, you can use every 12th hourly, and for late preterms, every 8th hourly, and term every 6th hourly, like that. And for local anesthetics, like we need to use during ROP strain, isn't it? So there's a preparation called proparacaine, so 0.5%. So that will be used as a local anesthetic during ROP screening. So opioids, especially like morphine and fentanyl, are popular now with the availability of fentanyl actually and a less side effect profile as compared to morphine. So we are preferring fentanyl as compared to morphine, especially in ventilated babies. The dose is 1 to 2 microgram per kg per hour. And try to avoid sedatives, especially midazolam, as much as possible, because it will cause hypotension and there is increased risk of IVH, intraventricular hemorrhage, in these tiny babies. So I think we'll come to the last part of it. So Dr. Rajit, what are the methods of analgesia for common procedures? Can you highlight common procedures and the methods that can be used? You are mute, sir.
Yeah, so some of this has already been covered, so I will not risk repetition. What I want to stress is what I've underlined. Please do not mistake sedation for analgesia. So I see this as a common practice that a lot of midazolam or benzodiazepines are used without analgesia. They just sedate. Can I just go back to the previous slide? Just one more point to make. So we have gone through all of this. And please do think of pre-medication for intubation. I know this is again not well widely practiced in India, but there are studies looking at sudden raise in intracranial pressure and deleterious effects on intubating reasonably conscious babies. Next slide, please. So as we have seen, the most important procedures to think of is heel pricks, line placements, catheterizations, PICC lines, ROP, and chest drain, and other things. So I would probably go with non-pharmacological measures for most of these things. So breast milk or swaddling and other things. Do not hesitate to use opioid, but we have gone away from using opioids routinely for all ventilated babies. So we again go by pain scores and assessments, and then fentanyl, as doctor mentioned, was that it wears off reasonably quickly as well. And if you're having to use long-term, as in more than 4 or 5 days of opioid analgesia, you risk withdrawal. So you must be monitoring these babies with a withdrawal score, like a modified Finnegan score or something along those lines. So anticipate pain. Use methods which do not need to escalation of pain medications, and do not hesitate to use medications as well if it is indicated. And I would also advise that using a combination probably works well. So if you have swaddled the baby before given NNS, used a topical analgesia for ROP, and also thought of assessing the pain after the procedure and giving some paracetamol and quietening the environment, for example, just to illustrate, I think that is a good pain management. Thank you.
Thank you, sir. Thank you, Dr. Rajit, for that wonderful discussion and bringing out those points. So basically, try to use non-pharmacological measures and use drugs when it's really required. And definitely pre-medication for intubation also to be considered. So predominantly non-pharmacological and sucrose. In mechanical ventilated babies, fentanyl or morphine with sedation holidays. So at least like for a few hours, you need to stop the fentanyl infusion for some time. I think we'll skip this because of want of time. So after each question, actually we try to make some take-home messages of that, and to wind up the session. So we should try to bridge the gap between knowledge and practice. So we know that neonates, they do feel pain, and it has got long-term problems. So how to bridge the gap between knowledge and practice and attitude? So by keeping posters in our routine NICUs, and doing some QA initiatives. So now actually quality improvement is more popular, and by doing small projects, so you can definitely improve the attitude of the healthcare professionals as well as the outcomes. And assessment of the pain, it has to be incorporated in the routine monitoring at least once per shift, and it has to be considered as a vital sign. And together we can help these babies to alleviate pain. So thank you very much. I thank all the panelists for sharing their knowledge and wisdom. And I thank South Neocon for giving me this wonderful opportunity to interact with you all. We can take up any queries if we have time. Thank you.
Any queries?
We finished in time, 45 minutes exactly.
Thank you so much, sir. That was a very informative session. Thomas Alva Edison, Nikola Tesla, Benjamin Franklin, Steve Jobs. What do they all have in common? Any guesses? They were all the greatest innovators of all time. Regardless of the sectors we play in, we all are relentlessly focused on solving problems and creating a better world than the world that exists today. So here we are with panel number 2, that is newer neonatal innovations. I am pleased to invite Dr. Sarat Chandra, the moderator for this panel, and I request Dr. Malla Venkateshwar Rao to introduce the moderator. Over to you, sir. So thank you, sir. I thank all the panelists of the previous session. Thank you, sir.
Thank you. Bye.
Welcome to the next session. Now, today's moderator is Dr. G. Sarachandra. He is a MD Pediatrics and DM Neonatology from the SRMC Chennai. He is the Director and the Chief of Child Health Center for Reproductive Assistance and the Neonatal Emergency, popularly known as the Crane Hospital in Vijayawada. He is the winner of Indian 500 Startup Awards, the Crane Healthcare Private Limited in the year 2019. In 2019, again, Dubai, he is the winner of International Forum for Advancement in Healthcare for Best NIC Design and LOMT Integration, Crane Vijayawada. He is a core faculty for the Neonatal Ventilation Workshop at Ramchandra University, Chennai. His areas of focus is NICU planning and establishment, neonatal transports, peritoneal dialysis in less than 1 kg neonates, and HFOV usage as a primary support for the extreme preterms. With this introduction, I am introducing Sri Sarat Chandra, popular neonatologist from Vijayawada, to the second panel session. Thank you.
Thank you, sir, for your kind words. So before we go into the neonatal innovations, the thing about neonatal innovations, everybody is an innovator in neonatology, because neonatology is a very nascent field, and you find a problem, you automatically find a solution. That means you are an innovator. So even the smallest of things can become a huge innovation and decrease your success rate, as well as your ease of use. So when we look at the problems in the NICU, the major problem is your OPEX, that is operative costs. So your CapEx would be very little, because once you invest, you have nothing more to invest in. But your operative costs are huge, because every month you need to keep paying from your pocket. So if you can cut down on your operative costs, automatically you'll probably reap profits with lower cost to the patients. So with these, there are innovations that we are going to talk today, right from paperless ICUs to Internet of Things in medical field, to newer innovations that have been coming, like wearable devices and rest of the things, with vaccination cards that can be put up online or in an app, and they can be carried till 18 years of age without destroying your records. So these are 3 major innovations that we are going to go ahead with today. And if there are any doubts, you can directly talk with the innovators themselves, and they'll be happy to answer. So we'll start with Dr. Prashant from St. John's. he's going to talk about the team who have innovated different things like wearable devices for neonates and how to decrease monitoring costs for the babies. That is basically cutting down on your nursing staff. Over to Dr. Prashant.
Thank you, sir. While the slides are being set up, so I may just confess that I don't belong to the traditional innovator person, but what I thought was I will just take you through the innovations which has been done in our institute over the last decade, and also how our institute has been able to support different innovations so that it can actually reach the needy. Sorry about the technical glitch. Can you all see my slides virtually? We can see the slides very well. Can they hear? Okay. So as I said, I'm just going to take you through the innovations which has been conceptualized. Some of them has been studied in our unit. So can just minimize that. Okay. So starting off, so you actually can see the picture. All of us know about her. There's no need of introduction. So this is Dr. Suman Rao. She's been involved in many innovations in about kangaroo mother care. So starting from the initial KMC binder, probably where she was involved in studying. She was also involved in looking at the different KMC binders. So which looked at the comfort of use and also helping the babies to get more KMC. So this KMC binder trial was done at St. John's. So where we actually studied the normal, the traditional KMC bag and Care Plus as well as the Momo pad. So, and the other thing which Dr. Suman Rao was involved in the conceptualization as well as looking at the remote biomonitoring devices. So where a wearable device which could be placed on the baby's abdomen could remotely sense the temperature of the baby and can give a feedback to the mobile device, which can be with a healthcare professional or to the parents themselves, for them to pick up the danger signs. If the baby is going to hypothermia, that something needs to be done. So this was the initial conceptualized device, which you can see over here, which was further refined. Lights are not moving. And the final version looks something like this, where a temperature could be measured from both the ends. So this will be the wearable device which the baby has, as you can see in this, the third picture. So where the temperature of the baby could be so the temperature of the baby as well as the person who is doing KMC could be actually recorded, And the same data could be could be recorded onto a mobile device, or it could be captured on this device, so that we can analyze the number of episodes of hypothermia the baby was going through, the number of hours the baby would be in kangaroo mother care, and also probably look at the danger signs. And the data, if we were to analyze, this is how it would look. The blue lines would indicate the temperature of the baby side, and the orange ones looks at the mother's temperature. So if you can see, the areas where it has touched around 37 degrees are the times where the baby has actually received kangaroo mother care. This could be used both as a device to look into the danger signs, that is hypothermia, as well as to monitor the kangaroo mother care hours. And the other thing which was with St. John's was involved in was in the looking at a trial which include embrace bags. So the embrace bags was basically innovated by Stanford University, and St. John's was a part of multicentric study which looked at the efficacy, and also it actually looked at the efficacy of this conductive thermal map test in maintaining the temperature of the babies. And this subsequently has been recognized by WHO as one of the standard methods to keep the babies warm. Another one which we were involved was the SANS, which is a portable CPAP, which was innovated by these two gentlemen over here. So this is a device which has power backup. It can be manually inflated to create a compressed gas source, where it could give a measured, the standardized pressure at the baby's end. So it's a pretty simple device, so which actually can give CPAP to the preterm babies, so which could be used even in transport also. So we were involved in looking at the safety, efficacy, and usability of this SANS device, and we found the results encouraging. So another one which we were involved is was in looking at the apnea of prematurity. So this is a picture of Dr. Sodamini Nesagi, who is an assistant professor in our institute. So she was involved in the conceptualization of this device called apnea boot, so which would pick up the baby's apnea episodes by feedback from the pulse oximeter. That's a certain certain level of desaturation and certain level of bradycardia it would pick up, and there would be feedback vibration which would be transmitted to the baby's food. And as you can see, it's just one interface over there, which also acts as a pulse oximeter as well as a surface which would stimulate the baby, thus helping the baby come out of apnea. So the RCT was done in our institute. The results are awaited in this. So I'm sure that this would be an encouraging thing. So once the results come out. Other big chunk belongs to this man called Dr. Ramesh. He works as professor in ENT department. He is involved in many innovations, especially pertinent to hearing screening and speech for newborns as well as infants. And he also is the head of innovation cell at St. John's Research Institute, which actually helps young innovators to conceptualize their ideas and probably help in executing them. So this was one of his innovations, where it's called St. John's Rattle. So this was recognized recently by the government of India too. So where this simple device looking like this could be used as newborn hearing screen at community level by the health workers. And this was subsequently validated with this study, where we looked at this calibrated mechanical noise maker for hearing screening in neonate, and the results were encouraging. And there are many other innovations which has been part of pertinent to newborns. As you can see, there are many over here. So he has invented St. John's Rattle. He is involved in creating low-cost ear modules, and he's also involved in establishing a mobile unit, which is also an innovation by itself to reach out to the community for hearing screening. And two other products which has been studied in our unit was the alarms which which actually would buzz off if there is more noise in NICU, and also a noise cancellation device, which could be kept beside the baby so that the baby won't listen to much noise. So which actually helps in developmental supportive care of babies. Next slide. So he's also involved in other innovation that would involve the process of screening the newborns and in the community, as well as referral and also the rehabilitation, and also looking at the rehabilitation of the same. And this one app, which has been created by St. John's under Dr. Ramesh, so which is called Research Genie, which is there in App Store as well as Android, which would help in help to guide the innovators to take through their innovation up till execution. So these are some of the innovations which, as a part of St. John's Medical College in the Department of Neonatology, I was able to see this getting from conception to the execution. So I would like to acknowledge Dr. Ramesh, Dr. Suman Rao, and Dr. Saudapani Nesargi for their inputs. Thank you.
Thank you, Dr. Prashant. Two questions for you. One, how do we get this to people?
I think I'm not the best person, sir. I think Dr. Ramkrishna sir and Srinath sir, those as innovators themselves, I think they should be able to do it well. So if you were to ask my experience, so in the sense that, when I was speaking to Dr. Ramesh, that's what he was actually saying. So the most important thing is most of us have plans, and that has to go to this, and probably the channel like these, where we can have a chat with the innovators themselves, people who actually have got patents and also the marketing would probably be helpful. And it's not one person's job. Probably the conceptualization, designing, and can all be done by one person, but to reach it to people, it will require this one. That's why the whole point of that app, which actually guides you and takes you through this. And just for your information, St. John's Research Institute has its own innovation cell. They can contact Dr. Ramesh. So he should be able to put us on to different engineers, as well as the other innovators who probably could help us in getting across to people.
The second one would be, how effective would it be to utilize all these innovations into our NICU? Say you would have used this in St. John's, so probably that would be.
Yes, so that's exactly the point, though. So every innovations, as you said, one should help people, and also the safety, and probably how it definitely help our newborns is what we need to look at. So that's why once the innovation is done, so we should be involved also in looking at the safety and efficacy of any innovation by probably conducting trials, maybe multi-centric trials, to look at if it really been helpful. So that's why all the innovations which I just mentioned, so all of them have actually gone through this. So innovation, design, execution, as well as looking at the efficacy at the field level. So not many of them have been put to use yet. So from our side, we have actually given feedback through these trials.
Thank you, Doctor. Next call upon Dr. Srinath. Dr. Srinath is a chief neonatologist consultant from Sagar Chandamama Hospital, Bangalore, and we'll take next. I'll take. Sure, sir. I invite Dr. Ramakrishna, chief consultant from Salem. He's an innovator by himself. He has started Internet of Things for medical devices, as well as a paperless NICU that he has designed himself. So probably all these devices could be also integrated into IOMT, and all these devices can definitely carry forward with ease of use. And I call upon Dr. Ramakrishna to take over.
Thank you very much, sir. Thank you, NNF Karnataka, for having given me a chance to speak in front of you. Thank you very much. I will connect now. 1 second. Can you hear my voice? Sorry, I'm asking to the Zoom. I have to mute mine. Sorry. I have to.
Yes, sir. You have to mute yourself, sir.
Okay. So my screen, can you see? Yeah, it's coming there. Okay. So, so I am from SKS Hospital in Salem, and I think the internet connectivity. So my talk is on IOMT and paperless NICU, right? So first I'll go through a little bit about paper records. There is a lag, yeah. So this is when I started at Salem. You know, we have been using the handwritten notes, which sometimes I find my own handwriting difficult to understand nowadays. And the second thing is the information retrieval becomes very difficult. Information analysis is difficult, and also safety measures like patient safety mechanisms and drug error prevention mechanisms and other things are difficult to implement. I think there is a lag between my screen and not only that, the storage cost increases over time. So that is another problem with paper records. And paper records are stored nowadays for medical legal purposes. You need to store them for 6-7 years, and in the Western countries for 21 years. And the cost of storing paper records goes up over time. So that we should bear in mind, right? Now, I think the screen is frozen. One second. I think there is the network is slow. So the next slide is not moving faster. Okay. Network is slow. So this is how sorry, what's happened? Something else is coming there. Can I connect my laptop there and network is this? See, what's happening is it takes a long time to come to the screen. Okay. So this is how, when I started, the prescription were all handwritten on all the blood reports and other things, and the nurses' observation sheets were all handwritten. But with this, we were unable to do anything great. So basically, all these paper, soon after the honeymoon is over, then lots of problems happens in any married life, and like couples not talking to each other for some time. Warning systems cannot be implemented on paper records. Clinical decision support, drug errors, and patient safety checklists cannot be implemented, right? So how to overcome this? Definitely electronic medical records and electronic health records. But the moment you say electronic medical records, this is the doctor's response, because none of the doctor, they don't want to enter data. They're not data entry operators. And doctors and nurses don't like the idea of entering loads and loads of data onto the computer. So what is the alternative? So automation is the way forward. So what do I mean by automation? Basically, everything from all the devices come automatically into your software, and this reduces data entry and saves professional time, right? Now, this is achieved by something called Internet of Medical Things. So what is Internet of Medical Things? In technical terms, it is an amalgamation of devices, medical devices, healthcare software, and information technology systems that are connected together and networked together. So in simple terms, IOMT, Internet of Medical Things, makes all the devices communicate with each other. So I'll just, why do we need IOMT in the NICU? So number one, like, many of you would have heard about remote monitoring. So for that, you need IOMT. The second thing is to access big data. So if you get every second data from every baby, that's a huge amount of data, and you can do lots and lots of research and analysis with that data. And you can allow the machine to learn this data, and that process is called machine learning or artificial intelligence. And you can create predictive algorithms, right? How likely is this baby to get septic in the next 2 to 3 days based on today's heart rate, blood pressure, and other parameters? And this helps in better diagnosis and treatment. Probably you all heard about Hero monitoring system, where the heart rate variability characteristics is used to predict neonatal sepsis. And that is one of the use with these sort of data. And the next one is the reduced medical errors that you see, improved patient care, and reduced costs for hospitals and patients, right? Now, how did we achieve this? Is the sharing gone again? No, it's there. Okay. So how did we achieve this? So this is the baby. We all know the baby is connected to the monitor, the ventilator, the pumps, and you have the blood gas machine, and you have the lab equipments, and you have the doctor's notes, electronic doctor's notes, and nurse's notes. Now, currently, they're all separate. They don't talk to each other. But now the process of putting all these things together and gathering all the information through that black box, that is the IOMT box, which our team designed. And basically, that gets all the information. And we also devised the software to collect all the information and display, which I'll show you next. So this is the IOMT device. And this one is a small device. It's not very expensive. It can be made at our Salem IT office. And this has connectivity, the network connectivity and power supply cable. That's it. And all you need is this box, and you need the barcode scanner and barcode generator. That's it. So with this, you can see that this particular IOMT, this is the SLE 6000 ventilator, and this IOMT device is connected to the bottom of the ventilator, and you can see that it is placed there. And this collects all the data from the ventilator. So that is one thing. And the next thing is the other gadgets. What do you do with the other gadgets? So this is the monitor. So from the monitor, you can enter the patient's MRN, and once this is connected to the network, the data from the monitor comes every second to the computer. And from this computer, it is presented beautifully onto our software, right? And the next one is the syringe pumps. Now, these syringe pumps, the main piece of the syringe pump is the top bit, which we call as a dock. So when we prescribe our electronic prescription, the information goes to this dock, and from there, that is communicated to all of the pumps. So basically, this is the brain of all these brains, basically, right? So this is the syringe pump and the infusion pump and the dock system that we are using to connect. Now, this is an example of the prescription management system at SKS Hospital that we are doing. So what we do is we do an electronic prescription. So we select the medicine, and in this case, we are putting dobutamine, and that's prescribed at 250 milligram, 0.1 ml. And once that is prescribed, you get a 2D barcode. So dobutamine, the amount that is prescribed, and that is taken off from that and then attached to the syringe. So the nurse prepares the dobutamine and attaches the barcode and then places and scans it with the infrared scanner. So the moment it's scanned, the pump recognizes it and starts sending data to our system, and then it's allocated to the appropriate pump, right? So this one minimizes drug error significantly. And then all they have to do is to check the dose and then start. Once it starts, it says that the dopamine is running and it comes to the system. So I'll just show you some live data from our so this is the integrated version that we have. So you just log into this system and you see the dashboard, and from the nurses hourly center, I've obtained permission. This is live data. So I've spoken to this mother and she is happy for the data to be discussed among the educated team. So this is how the data comes from this baby, right? So from all the monitors, so this nursing sheet, so from the monitor, the heart rate, the blood pressure, the saturation, everything comes automatically live every hour, right? And even so, the nurse, they don't need to make any entry at all. Everything it comes, and the nurse has to verify it and then just say yes, that's it, right? And and this one is from the drugs and infusion pumps. If you look at this one, the each ml. The clarity is not that good through the Zoom conference, but on live, the clarity is very good. So you can see that the intralipids, amino acids, everything hour by hour, how many ml it's going, and you also get your running total and your total input and output automatically calculated. So this is the nurses chart, and the next one is the prescription chart. Again, this is a live prescription where you also capture your electronic signature of the nurses, right? And if you look here, so this is the medications that were given for this baby, and all those signed, so the moment you enter the prescription on, medication on this, and then directly give it through this. So it goes to the pump and then gets automatically documented here. So that is the advantage with the system. And also it also gives you a graphical representation of all the data. So for example, if you want to look at the heart rate, it tells you, we have done the median, first quartile, third quartile, the highest and the lowest. So you can see, the graphical representation of all the data since admission, the baby, every second data is coming here, and you can zoom it to see any specific period so that, it's more clearer, right? So this is the amount of data that we are getting from this system, and all your lab results, the blood tests, everything is in one page. The moment the lab starts to enter the value, it automatically comes here. So everything is integrated. Blood gas data, the moment the nurse does the blood gas, it automatically comes into the software. So this is the lab blood. The next one is it will show up on the screen. So this is the blood test that you are seeing from this baby directly, right? So coming back to the presentation. So previously we used to have the notes, baby's notes to look at the data, but now this is displayed in front of each baby. So what are the baby's problems? What are the current medications? So from the data that is captured from the monitors and devices, automatically this is displayed. So you don't have to use any paper notes at all, and you get all the information at one go. Right? So these are the advantages. Basically, the IOMT and integrating all the data allows automation, which minimizes manual entry, automatically calculates the day of life, corrected gestation, automatically calculates input, output, nutrition, instant discharge summaries, because all the data is there. All you need to do is to program the computer to say how many days the patient was ventilated, what mode of ventilation, what is the maximum oxygen requirement. Everything comes at the touch of the button. You don't need to sit and type your summaries. Annual reports, you select the from date and the to date, and annual reports are generated instantly. And quality indicators. So all these things are possible. And this baby profile from the IP admission are carried over to the OP admission and the readmissions, so that duplication of data is prevented. And they're all ICD diagnostic coded, so that you can compare your diagnosis with other peers who also use ICD diagnostic coding. So this is these are some of the screenshots that I've taken. So this is how the nurses make the entry, and this is the summary which is generated automatically. And this is the annual report, which comes like your bank statement. You press the from date and the to date, and you get your annual report instantly. And the quality indicators are all filled in automatically. So IOMT automation and paperless NICU is the way forward. And I would like to thank the SKS Hospital Management and Dr. Suresh Vishwanathan, who's the medical director, managing director of the hospital. He is there in the panel. He's a chairperson today to take any technical questions or any cost-related questions, and also the excellent software team. Thank you very much. Any questions?
Thank you, Dr. Ramakrishna. Okay. What would be the learning curve for the nursing staff? Very steep, or what would be the learning curve for the nursing staff?
See, initially I thought, that's a good question, sir. Initially I thought it would be difficult to train the nurses because, but because it's all fully automated, all they have to do to switch on the IOMT device and scan the baby. That's it. And the data automatically goes in. Similarly, the doctors do the prescription, which is like any other normal prescription. Dopamine 5 mics per kilogram per minute. So they select electronically. It's a touch-based thing. And once that's done, it goes to the system. So it's all automatic. Whereas the manual entry, which we were previously using, the learning curve was steep. But with automation, it is so fast. And all they need to do is to take the barcode scanner and scan it. It's like in a department store, you buy an item and they scan it and put the price. So if those guys are able to do that, our staff nurses will definitely do a better job.
Thank you. And one more question, sir. So what would be the integrational feasibility for the devices for an existing NICU?
Existing NICU. See, the thing is, you need RS-232 port. If you have an older device, it may be a bit difficult because the current technology, most of the devices have RS-232. So wherever there is RS-232 port and there is data coming out, integration is easy. But the only thing currently, the device manufacturers are getting cleverer. So what they're trying to do is, when they send out the data, they are sending out the data in a format which nobody can understand. So to understand that data, you need to buy their software so that we can understand. So then the manufacturers of these devices are trying to be tricky to increase their sales. So that is the thing what we try to do is, so that's why we have tied up with the SLE 6000. I went directly to London, spoke to SLE 6000 company, and then they are happy to share the data. So like that, if you go to the top level, and then speak to them. This is mainly useful for the babies and those sort of things. Many of them are willing to share the data, but we have to take the next step forward in doing that.
Last question, sir. How safe is the data? Because that's a major concern now. The privacy has become a huge hue and cry. So how safe is the data?
Yeah, so that's again a good question. So similar to all our bank statements, or we keep lots and lots of like your Aadhaar card. They collect all sorts of data. I think data is the way forward, but currently there are industry standards. The Indian information technology industry has given standards how to secure the data, and we follow all those data standards, data security standards, and it's all encrypted in the sense that even if it leaks out, it cannot be read easily, and it has to be decrypted, encrypted, that process. So I think if we follow the current government guidelines on data and safety, if we follow that and we develop this software, it will be safe. Like any industry standard, like bank statements, Aadhaar card, I think, that sort of safety will be there.
Entry of, for example, dosage, if they done wrong,
yeah,
that also causes the legal problems in the future.
No.
It will give printout and everything will be stored.
No, this is similar to, see, the changes that you can make. We have thought about that. See, although it comes automatically from the machine, there is a middleman involved, in the sense the nurse or the doctor has to authorize that data. It's not like the blind data going in. Say, for example, 1 hour's data for that particular baby will come and wait for approval. The nurse has to look at that data and say that, okay, the heart rate is fine, the dopamine has gone 0.5 ml now. So they will say, and then they will press OK. Only when they press OK, it will come and it's like double checking. It's like when they're entering, you think 0.5 ml or 50 ml. If it's 0.5 ml, you don't put 50 ml. Even if they put 50 ml by mistake, they cancel it and then they can overwrite it. So even in the software, we have made those provisions in case if some data is coming erratic, the nurse has the right to change that because they are more knowledgeable than the computer. And then we will see why it is coming erratic and then try to fix the original problem. So there are safety mechanisms, but they are very relevant questions, sir. Thank you.
Thank you, Dr. Ramakrishna, for insightful paperless NICU. Probably most of them would adapt to paperless NICU. This will definitely decrease medication errors as well as legal problems. Probably that should be the way forward for next generation coming.
Thank you, sir. Thank you. Thank you.
So, and invite next panelist, Dr. Srinath. He's the Chief Consultant Neonatologist at Sagar Chandamama Hospital, Bangalore. And he did his neonatology from UK. And he's the instrumental person in setting up the human milk bank in Karnataka, Amara. And he has started off a vaccination card, a paperless vaccination card, and he's one of the main sponsors for the South Neocon. Thank you, sir, and welcome.
Thank you, Dr. Chandra, for generous introduction. So good morning, everyone. And we heard about paperless NICU and how we can prevent medication errors in NICU from Dr. Ramakrishnan, and also how this data can be stored permanently. And data is very, very important, as we know in these days. Similarly, we have invented a digital vaccination record, which serves the same purpose of keeping this vaccination, important vaccination data, which is very authentic and which is secure in the clouds and for up to the age until the child reaches 18 years of age. And also it has to be user friendly. It should be available at the fingertips of the parents. So there is a saying, every adversity brings it with an equivalent or greater opportunities or benefits. That is one of my favorite sayings from Napoleon Hill. Similarly, when the pandemic struck in, there are a lot of opportunities for us to invent new things. For example, when the pandemic struck in, we had a lot of challenges of getting the consultations with the pediatricians. Now, what has happened? So online platforms have come in, online consultations have come in, which are fairly safe if you follow the guidelines. So similarly, there have been home vaccinations, and we day-to-day come across paper cards, and majority of them, either some of them fail to bring the paper card when they come for the vaccinations. And especially during COVID pandemic, a lot of vaccinations have been postponed, and a lot of catch-up vaccinations to do. And if they don't have a proper vaccination card, it is difficult for the pediatrician to decide which vaccination to give. So that is the problem we wanted to solve. And myself and my partner Mukund, who is sitting over there, so we created this company called mHealthy Technology Private Limited. And main objective is, this is one of our products, what we have created. We are planning to come up with a few more products to improve the healthcare. And the first product is the digital vaccination card. First, I would show you a video, which is meant for the doctors. And please watch the video, and after that, I will do my presentation. So if you can play the doctor's video first, please. So day to day, when the babies do come, we see the problems. Most of the paper cards are not very legible, and there would be overwriting, and some of the stickers have already faded away. They will have multiple cards from multiple clinics. Okay, and parents, if they have 2-3 children, they have to bring multiple cards of each children. So our digital vaccination app solves all the problems, and everything will be kept in one app where mother can receive her influenza vaccines or HPV vaccines, and her children, 2-3 children can be registered in the same app, and each and every child can get the vaccinations and record it separately. And those are permanent records with all the authenticity of batch numbers, expiry date, and everything will be there. We are going to play a video. Please watch. Volume, please. Volume. Sound is not coming. Sorry, there is a technical glitch. They are going to play the video. In 1 minute video, it will cover most of the aspects of this digital vaccination card.
We are in the age of rapid medical evolution, where doctors and healthcare providers struggle each day to maneuver through a scattered cloud of data and inputs, helping them keep up with the ever-changing dynamics of the vaccination needs is VaxiTrack from mHealthy. The highly credible vaccination card is fast, smart, secure, and available to patients and doctors anytime, anywhere on their mobiles. Powered by a robust blockchain framework, VaxiTrack's smart technology helps doctors update vaccination cards with just 3 to 4 clicks. Get instant access to patients' cards through OTP or QR code. Get notified by inbuilt controls. View patients' vaccination history. Transcribe patients' past vaccine records. Get alerts about upcoming vaccines. With VaxiTrack, patients can easily manage vaccination cards of multiple children through one login. Get data security and information on the card. Get timely reminders. It's time to reimagine vaccination. Think vaccine. Think VaxiTrack. Think vaccine. Think VaxiTrack.
The video which is meant for the doctors. Now we are going to play another video which is actually focused for the patients, so that they can actually watch and see what are the advantages they have in taking this digital vaccination card. Can you play the next video, please? Yeah. And it's a completely developed product, which I have been using in my clinic for more than 3 months, and I have sold more than 100 cards. And it is very, very easy to use, just 3 to 4 clicks, and it immediately appears in the patient app with all the details. And so far we have 2 hospitals and 6 clinics using it in Bangalore. And we would like to spread this across. And my vision is to see this vaccination card in the hands of every parent in India. That will definitely revolutionize the way the vaccinations are recorded all over India. And there are so many advantages of doing that. I will come to that in the presentation.
Parenting is a life-changing experience, and as parents, you always want to be extra careful about your child's vaccination needs, ensuring you never miss out on vital dates or records. Digital technologies have revolutionized these healthcare concerns by developing VaxiTrack, your go-to digital vaccination card. All that you have to do is register your child on the web application, visit the hospital vaccination date, code in the app, purchase its VaxiTrack at the hospital or clinic, share your access. Finally, get and your digital card accidental duplicate vaccination.
Putting the PPT, yeah. So thank you for your patience. We're going to quickly run through a few slides, which will tell you about the product. So we are going to briefly talk about the VaxiTrack, which is a digital vaccination card from mHealthy. So I'm an executive director and co-founder of this company, and Mr. Mukund is a CEO and MD. Mukund has a background on technology and banking, and we both came together and started this product. Next slide. So objective of this innovation is using the technology and business model innovation to come up with the child and adult vaccination card, which is safe and secure on the digital platform, and embed this in the digital vaccination ecosystem so that benefits of participants of the ecosystem who are a network of users, doctors, pharmaceutical companies, governments, and organizations like WHO, UNICEF. So everyone can actually get benefited. We can see how we can do that. Next slide, please. So there are various advantages. Currently, what are the problems that we are facing with the users? The users are using the paper card and they get torn, they get damaged, and over a period of time, some of them they get lost. And each child will have multiple cards from multiple clinics, and they have multiple children, and it is difficult to keep all of them in one place. And sometimes they won't even plan the vaccination. They'll come for shopping and then they end up coming to your clinic without any vaccination record. And they expect you to do the right vaccination for them. And they would not turn up for 3-4 months for the vaccination. They say that because of the COVID, they could not come. But they don't bring the card and they don't have a proper authentic record and just have to guess which is the next vaccination to give. These are the problems with the users and with the doctors. So creating proper record takes time. So you have to peel each and every sticker from the vaccination, and you have to peel it in such a way that the batch number expiry date should not get damaged. And then it all takes time, and you need to put the patient there, and then you need to record, and it all takes time, consulting time, and it's prone for errors. sometimes you do the vaccination. It has happened to me myself. We have given a 15-month vaccination. My nurse did not paste the stickers and did not document that the vaccination was given. And the child comes after another 3 months, okay? And when we ask them why this vaccination was not done, she says because of the COVID, she could not come. Then we thought that probably she didn't have the 15 months vaccination, and we gave again the MMR and chickenpox. But later on, we realized that this child has got the same doses twice. Fortunately for us, it was a 3-month gap. Then after that, we could, with the data, and we could actually convince her that anyway, there is a 3-month gap and it acts as a booster dose. Then the child doesn't require any booster dose for varicella when the child reaches 4 to 5. So these are the problems that the doctors do face. Okay. So these are the duplication of vaccinations can be prevented using this digital technology. And what are the other the problems for the manufacturers? It is prone for counterfeits. And if we have a proper record, it prevents the counterfeits of the vaccines. And also there is a supply chain gap and traceability. Currently, any manufacturer can trace only the vaccines up to the distributor. After that, they don't have any idea where it is going. So that is one of the things that we can actually want to fill the gaps. And there are multiple schedules, and IAP schedule, we have national immunization schedule. So the doctor can easily actually choose which schedule they can follow in our app. Next. Next. Previous slide, please. Previous slide. Yeah, fine. So in we are in the process of patenting. We have applied for patent of our app. And what exactly is this technology? Is basically we come up with a digitized vaccination card with a personal data control, with user getting the timely reminders of all the vaccinations, and it is at the fingertips of the patients, and it is completely secure. It is secured on a blockchain technology, and it is at the hands of the patients. They have to give the consent in the form of a 3-digit OTP for the doctor to access this record. And only approved medical records will be created using the login credentials of a user who is approved, who is either a doctor or a nurse. So doctors can get automatically registered in our platform through the credentials of their the medical registration number and the year of registration. And only authentic doctors and nurses are able to apply this vaccine. And it is powered by blockchain technology, which is very secure in the cloud, and you can share the data on demand wherever and achieve the last mile tracing. Next slide. And back, please. So it is the only product in the world currently which is based on the blockchain technology, especially the vaccination record, and which makes it very, very secure and hack proof. And only a healthcare professional, doctor or nurse who's registered, can actually record the vaccination. And parents can only view access. There's only view access for the parents. There is no option to actually modify the records. So it makes the vaccine track the most credible vaccination card. And patients and users will have only view access, as I said, and they get the timely reminders. And patients will have complete data privacy and can give access to anybody. For example, if they want to give the data to the school, all they have to do is they have to share a 3-digit PIN to the school. School can go to our website and put the 3-digit PIN, and then their vaccination card will pop up. Or if they have to give it to immigration authorities, they can do the same. It is so easy. And doctors' credentials are approved automatically without any subjectivity involved. Any doctor can just register, going to a website, putting their details. Automatically, these data will be taken to National Medical Council and get verified automatically by our servers. And they get immediately approved. But they will ask for a paper record later on, but immediately will approve. Similarly, we are planning to do it for the nurses as well. Next slide. Next. Next. Okay, so see, this is a comparison of a paper card where the record is not very visible, okay, and not legible. And you can see how it appears in our digital vaccination card. So these are the vaccinations in green which are given. This is the red. Probably we don't have enough the batch number of the OPV. So that's why we didn't actually transcribe that one. Because most of the hospitals, when they give the birth vaccinations, BCG, hepatitis B, and OPV, they put the stickers only for BCG and hepatitis B. They don't put the batch number for the OPV because OPV is used for multiple children. Similarly, when this child came to us, we transcribed the previous records. It is showing as green, but it is red because we don't have the record, so we can't just enter that. So remaining vaccinations, when it appears like that, green. So if you click an individual thing, this is a record that will show. It will show exactly which vaccine was given. So is it taken the picture of the vaccine? So batch number, the day, the expiry date, and who has given it? What is the registration number? When was it given? Everything is recorded very, very accurately. Next slide. And for a live demo, please visit our stall. So we have a stall VaxiTrack, and please visit and experience live demo. You can act as doctors as well as the patients, and you can actually try multiple times and then get used to it. It's very easy. Just do 3-4 times, you will master at it. And currently, I take just less than 1 minute to apply a vaccine. When patients come into my clinic, they give me 3-digit PIN, and I just enter the 3-digit PIN and then select the vaccine and then click a picture and then apply. Immediately within next 2 seconds, it will display in the patient vaccination card. Both doctor and the patient can see actually what exactly it is. And it is secure and it is permanent record, which is there until 18 years of age. It gives timely reminders. Whole family can have in the same vaccine. Adults as well as children can have it in the same app. And coming to the commercials, we are making it actually very, very affordable. Our vision is to have this vaccination app in the hands of every parent in India. It will solve a lot of problems because especially if you have a proper data to track. For example, if the batch numbers are actually tracked to the patient, if any adverse reaction happens with the vaccine, we can easily track which are the other babies who have received similar the batch number, same batch number, and we can even prevent further doses of that. And there are a lot of advantages. Actually, government can get a lot of data about how many children have been vaccinated, how many children have not missed the vaccination, and they get the timely reminders. So currently there are a few apps which gives timely reminders, not more than that. And there are some apps in the Apple Store or in Google Store where parents can actually do the records, but the authenticity is actually questionable because parents themselves are doing it. Here only a qualified medical professional who is authorized only can apply. So parents can only view. Okay. And there is an option of transcribing the previous cards. If a child is 6 months old and comes to us, if proper records are there previously, there's an option of transcribing. Okay, thank you so much for your time. And I would be happy to take the questions.
Yes. Thank you, Dr. Ramakrishna. Srinath, sorry, sir. It's a wonderful presentation. Due to shortage of time, you can meet him anywhere in the lawn and even at his stall to ask him questions. Thank you once again.
Thank you for that wonderful time of panel discussion we have had. Because of shortage of time, we'll be moving on to the next panel discussion, which is on high frequency ventilation and volume guarantee non-invasive high flow oxygen. The moderator for the day is Dr. V.C. Manoj. We would like to welcome you, sir. Sir has come all the way from Kerala. Sir is coming inside. Meanwhile, can we just have a check of everybody who's with us online today? We have our chairperson, Dr. Malla Venkateshwara Rao, sir. Very good morning. And we have another chairperson with us, Dr. TV Ravi, sir. So are you online with us right now?
Yes, yes. Good morning.
And we have our panelists joining us virtually, Dr. Nelby, Dr. Murali, and Dr. Sri Kantima. A warm welcome to you. We just want to check if you are with us online for this panel discussion right now.
Yes, thank you. Thank you. I'm Nelby. Thank you.
Dr. Apur, thank you.
Yeah, I'm Dr. Sangamitra. Good morning, everyone. Thank you.
We would like to give up the mic to Dr. VC Manoj. Thank you, sir, for coming all the way from Kerala in these difficult times, just for our sake and to impart knowledge to us. A warm welcome to you, sir. And I would like to ask Dr. Malla to introduce our moderator for this session.
Welcome to the third panel discussion. Today we had a very good jumbo dance under the guidance of Dr. VC Manoj. Dr. VC Manoj is a MD, MSc Neo Medicine, Cardiff University, UK, FRCPH UK, and is professor and head of the Department of Neonatology, Jubilee Mission Medical College and Research Institute, Thrissur, Kerala. He is the National Executive Member of NNF India and a National Executive Member Neonatology Chapter of IAP, and is a member Government of India Task Force for Augmentation of the Human Resources and Capacity Building in the COVID-19, State Academic Coordinator, Kerala, to Advanced NRP in the IAP, NNF FMG project, TOT in NRP and NSSR program, and is the President National Neonatology Forum Kerala year 2019 and 2020, and President IAP Thrissur 2017 and 18, Secretary NNF Kerala 2011 and 2013. His areas of interest are neonatal respiratory care, neonatal nutrition, perinatology, and intervention in the resource limited settings. Thank you, sir. We are welcome Dr. VC Manoj for this panel discussion. Thank you once again.
Thank you so much, sir, for kind words. Good morning, friends. Welcome to a slightly unconventional panel on, or rather a conventional panel on an unconventional topic. So before we proceed, let me introduce the experts today. I'll be just acting as a moderator. We have a team of 6 experts for this panel. Dr. Venkata Ramarao Paturi, we all know him. He's the man from Andhra Pradesh. Of course, he is the Chief Consultant, Neonatal and Pediatric Intensivist, Andhra Hospital, Vijayawada. Welcome, sir. We also have Dr. Dr. Ramarao has joined us here physically. Now we have Dr. Apur Burche. He is the Assistant Professor of Department of Pediatrics at Kastuba Medical College, Manipal. He will be joining us online. Apur, are you there?
Yes, sir. Thank you, sir.
Confirmed? He's there. Okay, fine. We also have Dr. Sangamitra. She is the consultant neonatologist at Nori Multispecialty Hospital, Vijayawada. Sangamitra, are you there?
Yes, sir. Yes.
Thank you. Thank you. We also have Dr. Nelby Joe Matthew. He is a consultant neonatologist at Tiruvalla Medical Mission Hospital, Kerala. Nelby, are you there?
Yes, sir. Thank you, sir.
Thank you. We have Dr. Nilesh Rao. He is a consultant neonatologist at Cloud9 Hospital. He is joining us physically. Nilesh, you are there. Okay, thank you. Thank you. And we also have, so we have 6 experts. The last, not the least, is Dr. Murali Raj. He is a consultant neonatologist at Kraft Hospital and Research Center at Kodungalur, Thrissur. So this is the panel with which in the next 45 minutes, I am going to take you to another area or another philosophy in HFO, which those of us who ventilate babies, it may appear slightly sound or slightly strange, but then probably it may not be. It may not be the way we ventilate in the current times. It may be the way we should be doing or whatever you can call it. So let's start with a story of a baby we had, I had in my center rather 1 month ago. It's a 24 weeks preterm 650-gram baby. Mother was rushed to the labor room. leaking with leaking history of 8 hours. So immediately a dose of steroid was given, magnesium sulfate infusion was started, and then we did not get much time. Baby was born, vigorous at birth, so was shifted in a hurry on TPs and on under thermal protection, cling wraps. Not at that time we could not even organize a embrace to NICU. In the NICU, baby was having distress was worsening, so we decided to anyway give surfactant, and we did to electively intubate the baby. Surfactant was given, and baby, it was decided to continue to keep the tube in due to respiratory distress. Sounds familiar? This is the scenario we all have. Now, the first question that is going to come to your mind when you're going to ventilate. I'm not going to tell you ventilation is only one of the parameters that you need to look at in a baby as far as baby's care in the initial golden hour is concerned. There are so many other parameters which I'm not going to touch upon today because our topic is restricted to that. Which is the mode you are going to ventilate this baby on? So initially, we conventionally started with our conventional mode. We don't use SIMV in our unit. So it was SIPPV, or otherwise called assist control with volume guarantee. We use, we target volume for all babies. And the PPO6, a 6 ml being a 24 weeks, a 6 ml per kg tidal volume was targeted. The PIP requirement was as high as 20, and the FiO2 we could bring down only up to 60. And the rates were 40, and the MAP requirement at this point of time was 12. So now, after having settled now at 6 hours of life, baby was still on these settings. This is the settings which we could not reduce any further. So we decided to give the second dose of surfactant. Seeing the whiteout X-ray, we decided to give the second dose of this thing. Now we decided at this point to convert to HFO. So we start our discussion from this point of time. We take this baby now. Let me ask Abur, why should you, or I'm saying, why was this baby? I'm not justifying. There are people who would like to continue on conventional. Why do people, at least some people, convert babies early on to HFO? Is there any advantage over conventional ventilation? Over to you, Apur.
Yes, sir. Thank you, sir. So basically, a high frequency ventilation delivers a very small tidal volume at a very rapid rate with a sustained mean airway pressure. Majority of the places still use high frequency as a rescue mode. As described in this current case, there are some studies to use it as a primary mode in severe respiratory distress syndrome babies, but that is still in working. Now, what HFO mode is extremely effective at is achieving a good pulmonary gas exchange. And especially in these extreme preterm babies, it's also lung protective. And the lung protective nature is especially more enhanced when you compare it to the conventional mode of ventilation, particularly when the high settings are required to achieve an adequate gas exchange. As you have shown in the case, the setting, the second dose of surfactant. So this is one of the very classical example where the benefits are there, because giving this sustained mean airway pressure with a very small tidal volume may limit the lung injury from the tissue stretch that happens, especially at the peak inflation, the cyclic peak inflation in our conventional mechanical ventilator mode. Now, the benefits over this not just exist in respiratory distress syndrome. It is particularly also seen in cases, another frequent case that all of us encounter in form of PPHN. It is also used, there's some little conflicting data in case of congenital diaphragmatic hernia, but that's another place.
Thank you. Excellent, Apu. Actually, our boss here, Dr. Dinagar, says that we have to wind up in 45 minutes. So we have experts, the 6 experts, lot of portions. I would request all the experts to kindly restrict to 3 minutes to answer a question. Of course, this way, that way, little time. We can this thing. So, but Dr. Apu has told us one very important aspect. That is that this HFO can be, if used electively, can be lung protective, at least hypothetically. So the indications of HFO can be as an elective mode, or as a early rescue, as in our case, or as a late rescue, as we do in most of the cases. So there are 3 ways of looking at HFO. We are today going to look at HFO-VG, so that we are talking about the lung protective effects of HFO. So early conversion, you end up causing less ventilation-induced lung injury, as was beautifully explained by Dr. Apu. So now moving on, as was mentioned, we converted at 6 hours of age of this baby to HFO. At that point, the map kept was so in HFO. All of us know there are 5 knobs to convert. If you don't want to, actually 6 knobs. IE ratio and flow, bias flow. If you don't want to touch, there are only 4 knobs. For oxygenation, you have MAP and FiO2, and for ventilation, you have delta P and frequency. So MAP, being an elective mode, you start with the same MAP of conventional ventilation, or maybe even lower. People may use lower, but as a late rescue, when you use, you need to use 2 higher. So we kept it MAP 12. FiO2 drastically brought down in the next half an hour to 25. The frequency we started was 12. Rational being that preterm lung, probably they ventilate best at higher frequency. Term baby, so resonating frequency maybe of the lung may be 10, and preterm, depending on this baby, might actually it was a higher lower frequency. This baby we can use even higher frequency, as we'll see. And tidal volume we used another parameter, VTHF. I will come to that subsequently. Let us discuss some basic principles when you convert a baby from conventional ventilation to HFO. Dr. Nelby, over to you.
Thank you, sir. As you said, thank you, sir. As you said, this is a case of we were trying to change from conventional to high frequency. It's a rescue mode in spite of maximum effort performed in the conventional ventilator. Here we have to mainly concentrate on which map you have to start on. As you said, we have failed in a map of 12. In this scenario, I would rather start at a map of around 15 to 16, around 2 to 3 centimeter more than the map of conventional ventilator. Then go look on the map gradually, step by step, so until the oxygenation improves and the lung is optimally inflated. Then another approach is to go high on the map, come down on the map. But we used to follow the other way. Next thing is amplitude. Amplitude should be kept as high as possible to have a vibration, visible vibration in the thorax should be there. Frequency, as you said, it's a small baby. You have kept as 12. I may have kept it 10, sir. And regarding the IE ratio, previously we thought of keeping the IE ratio at 1:2 in view of this air trapping, but now we know that the ventilators with active expiration, that is not an issue. So IE ratio will be 1:1. And the next thing is, I may give an AMV in between side breaths to maintain the functional residual capacity around the frequency 5 per minute with a map around the same. I will wait for half an hour to 1 hour, then get an X-ray done to see whether the lung is optimally inflated so that the posterior rib of the posterior end of the 9th rib is visualized. Then I will get an X-ray blood gas done, see the carbon dioxide oxygenation, and I will fine tune from there, sir.
Thank you, Nilvi. That is excellently explained. To just summarize, we have a heterogeneous. The first question that you're going to ask is, am I ventilating a heterogeneous lung or a homogeneous lung? So your strategy and the settings at conversion will be different. Other things have been described. Now I am rushing to the next this thing. Now, we said most of us do use HFO for oxygenation, not for ventilation. Ventilation, we are very comfortable, but we find that oxygenation, we get stuck. So the key is how to recruit lung. And this is where people make mistake. You overdo, you end up with pneumothorax, and early you underdo and you get stuck and you say, you blame the HFO because you are not doing the correct setting. So how do we recruit lung properly? We have Dr. Nilesh from here with us from Rainbow, joining us. Cloud9. Sorry for that. Yes, Nilesh.
Thanks, Dr. Manoj. So in HFOE, optimal recruitment is, as we know, is one of the most important things that we have to do to ensure adequate VQ matching, and also to ensure that there are no intrapulmonary shunts. although there are 4 or 5 different ways of recruiting the lungs, that includes stepwise increments. Then there are the giving sigh breaths, sustained inflation, intermittent sigh breaths. The most important or the most effective form is stepwise increment in the pressures. So we saw the pressure volume curve that was previously shown here, where there is this zone of atelectasis, and on the other side, there is the zone of hyperinflation. So we don't want to be on either side. So we want to be in the safe window. So how do we go about doing this practically? So we have to ensure before we do a recruitment maneuver that the baby, we do suctioning and the endotracheal tube is patent, and ensure that the baby is hemodynamically stable. That's extremely important. After that, we start the maneuver. So it is like increasing the mean airway pressure by 1 to 2 centimeters every 3 to 5 minutes, and closely monitoring the baby. So you can see decrements or reduction in the FiO2 and improvement in the saturations till the baby reaches FiO2 that is less than 0.3, and there will be some improvement as you keep increasing the pressures. So there is something we call the opening pressure, where all the alveolar units finally pop open. At that pressure, beyond that, if we keep increasing the mean airway pressure, we don't get any further improvements in the with respect to FiO2 reduction or oxygenation. That's when you mark the parameters of the map and where it happens, and then start reducing it further. You go down to a point where we reach something called the closing pressure, where again the parameters worsen, the FiO2 increases, oxygenation worsens. So for a given compliance, for a given pathophysiology of the lung, you can kind of mark this out, and then finally what you do, above the closing pressure, around 2 centimeters of map, above that, you keep the mean airway pressure and then closely monitor the baby. Of course, if you have done the X-ray earlier, then we don't need to repeat it. So we can.
Excellent, Nilesh. Thank you. So basically what I will summarize what he said, you need to recruit lung first by using by going up in set increments of mean airway pressure. Once you recruited lung, you should not stay at that pressure. That will go. That is the cause for air leaks. You need to come down. So what you do is actually you voluntarily de-recruit, and the de-recruiting is always by decreasing by 111. And you will find that suppose you are recruited at 18, and then by 15 baby is again till when you come down to 17, 16, baby saturation still will remain same. Once you come to 15, you will find that saturation falls. That means you are de-recruited. You just go up 1. 16 is your recruiting pressure in this case. So this is one of the basic clues which you need to remember. And then there are various other aspects which we cannot discuss. Now we have, okay, now whenever we do any intervention, one of the things that you need to be worried about is complications and deteriorating. You start, baby was reasonably comfortable on convention. You thought you were electively converting and baby deteriorated. So how do you actually detect signs of deterioration complication? Dr. Sangamitra, are you there?
Yes, sir. Yes, sir.
Please go on.
So basically, when a baby is on HFO, I think here our clinical acumen overtakes the machine, because here the machine is not going to tell us whether there is increase in MAP, whether there is need for more MAP, because we're not using EEG. So you need, our clinical acumen should be perfect. You need to keep monitoring the baby. And I think the first sign of deterioration here is probably you're overexpanding the lung, because you have just changed from conventional to HFO. So you need to be vigilant about causing any air leaks. I think in such a small baby, probably more than pneumothorax, you should, you're slowly overexpanding the lung, and it might result in pulmonary interstitial emphysema sometimes. So to avoid that, you should always go for optimal lung volume strategy here. And then one more commonest thing that we encounter is hypocarbia, and that might lead to IVH, which would be more dangerous for the baby. So here, how do you prevent a hypocarbia or look for hypocarbia? Is you need to get your ABG immediately when you just change over from conventional to HFO, like Nelpi has said, within 15 minutes, so that you're not overventilating the lungs. Get your settings right, and then have a clear-cut plan of when you're going to get your next ABG. And then the next one is because of hyperinflation, there could be reduced cardiac output, and this will result in, again, hypertension, shock, and poor urine output or raising lactates, which we should be vigilant about. And then the next thing is tube lock. This is such a tricky thing when the baby is on HFO, because suppose the baby is on conventional ventilation like SS control with VG, then you know your PIP is increasing and you know something is wrong there. But for such a small baby, you cannot even sometimes understand through looking at wiggle. I think you should be very cautious about looking for tube locks and suction. And then again there is a problem of de-recruitment. Then again you have to recruit, you have to come back. So I think HFO without VG is something where the clinician overtakes the machine. The clinician's brain has to work better than the machine here, and we need to be more vigilant, sir.
Thank you. Some of the clues, like whether your map is overdoing, like the same like when you use over PEEP, like your tachycardia or reduce urine output, the lactate in the gas raising, those things still hold good here. So I think Dr. Sangamitra has explained the whole concept very beautifully in the stipulated time, within the stipulated time. So hopefully you need to be looking out for all these when you introduce, put the baby on HFO. Now we have an expert here physically with us who has been using HFO for the last 25 years, a good friend of mine, Dr. Ramarao. Sir, how do you wean the baby? You have put the baby on HFO, baby is settled, baby is very comfortable, you need to wean. What are the basic principles? 3 minutes.
Thank you. Thanks for your kind introduction, Dr. Manoj. Now I could see more number of people. I hope more number of people have logged in. With regards to the weaning of HFOV, I've not seen your scenario, but I will try to answer the question. So mainly the weaning of HFOV, when we start weaning. So to all of you, the weaning starts from the time of intubation. That is in a traditional teaching, whether it's whether the baby is on conventional ventilation or an HFOV, the weaning starts from the time of intubation. Once you stabilize the baby, once the baby is clinically stable, and once improving X-ray, and once the blood gases are okay, then you need to start weaning. So weaning, how would you do weaning and HFOV? First, we would consider an FiO2. So wean FiO2 in steps of 5 or 10 or so. Wean the FiO2 to like 30 to 40%. So once the baby is
Are we muted? No, okay. So as was clear actually, so that depends on which lung are you weaning, heterogeneous or homogeneous lung disease, and then why have you indicated all these are going to affect. And now one word about weaning here, since we may not discuss that point. if you are using HFO, you need to wean basically two parameters, oxygenation and ventilation, both the parameters that control both. But if you are going to use the mode that I am going to introduce now called targeted tidal volume in HFO, you are taken care of your ventilation. You will only wean oxygenation, which means the only button for you to wean is MAP. You set the baby on HFO, and the MAP comes down, you extubate. That's probably the way when the HFO will turn out to be. So now, before we go on to that, we should know a little bit about our machines that we have in our Indian market. So, Dr. Murali, tell us, what are the HFO ventilators available in the market as of now? At least the major ones. Anybody in the attendees can contribute if more machines are there, and what are the basic difference between them? Over to Murali.
Yeah, thank you, sir. Thank you, sir. So there are different brands are available in the Indian market, and rather than, I would like to say that rather than the brands, it's the brain behind the ventilator that operates everything. So we have state-of-art Sensormedics 3100A. That is actually it is a pure dedicated HFO. And one thing is that you cannot do a volume on Sensormedics. And another hybrid ventilators are also available. And the importance of hybrid ventilator is that you can ease of shifting from a conventional ventilation to HFO. So you're using a dedicated HFO, it will be difficult to change the ventilator to a HFO ventilator, but a hybrid ventilator will be useful. And also there are a lot of variables like ventilator circuit, CT tube size, and compliance of lung and disease severity, depending upon the outcome of what you get from doing an HFO in a baby. So, so as I already told, Sensormedics 3100A, it is actually a true HFO, and it is a diaphragmatically sealed piston driver that operates to give a high frequency oscillation. And it has got an excellent, powerful ventilator. Actually, it is known as the Rolls-Royce of high frequency ventilators. But sadly, it is only in a dedicated HFO. We don't have a volume, or we don't have other conventional modes with the Sensormedics. And what we usually use is the SLE 5000 or 6000 and VN500. These two ventilators, I think, are most commonly available in India. And VN500 is actually a diaphragm oscillation. It actually a diaphragm oscillator with a linear motor piston pump that produces the oscillations. And it is a powerful ventilator. And I'm not supporting any brand, but when compared to say SLE or 5600, I think VN500 is a powerful ventilator and can produce that adequate MAP and also oxygenation and other things with this VN500. And another thing is that you can add volume guarantee in this. And SLE also you can add this.
Keep the volume out of it, Murali, at the time being. Otherwise, when, for the shortage.
Hello?
Yeah.
Hello.
Please go ahead. Please go ahead.
Yes. Other brands available are Leone or IVA or Fabian. And also these ventilators also have HFO, and volume is also available with this Leone. And the major mechanism of action of this ventilation is this diaphragmatic oscillation.
Thank you, Murali. So there are various brands available for you. One of the king of HFO ventilators, Sensormedics, unfortunately, is a dedicated HFO ventilator. You need an expensive machine. You cannot, until you are a electively HFO ventilating unit, probably it may not be practical in a busy, if you are running a busy clinic. So the hybrid ones which you convert from conventional, you convert all others, you can use both the modes. And then some of the newer ones, one of the ones that we all started learning ventilation in the 80s and 90s, the Baby Log also has HFO, even though nobody uses, or rather, I don't know, there have been papers on people using it also. It can also be used for HFO. Other major ones are all mentioned here. And if you're using targeted tidal volume, only the newer ones, like the VN500 or the SLE 6000 have that option. We'll come to that subsequently. So let's go back to a baby. Baby was as I said, at 6 hours of life was converted not to HFO. We were just discussing HFO. It was converted to HFO with volume guarantee. So the settings which I said we will discuss subsequently was the tidal volume. The tidal volume we targeted to start the ventilation was 2.2 ml per kg. So a little bit about. So now we introduce a concept. So far we have seen that ventilators neonatal ventilators are all pressure ventilators, PCVs. No VCVs, no volume controlled ventilation is available in neonates, but we still get away by targeting volume. So in HFO, if you want to target tidal volume, it is not going to be a 4 to 6 ml per kg, because you are going to, if you are going to use 4 to 6 ml per kg, you are going to ventilate the alveoli, and HFO usually we ventilate the, you should not ventilate the alveoli, you should ventilate the dead space, otherwise you will cause severe injury. The idea is to prevent injury. So you need to use smaller tidal volume. So what is the actual tidal volume that you should be targeting? Why is it? Sorry. Yeah. So okay, before we go to the tidal volume, so the what I was just now saying, that when you use pressure controlled ventilation, still you need to target volumes. So this concept of targeting volumes came first in conventional ventilation, and now it is a standard of care in conventional ventilation. It's a crime to ventilate babies without targeting tidal volume. I'm not saying you should put on the TT mode. You should look at the tidal volume and do. If you don't need the machine to do the targeting, you can target yourself. That's also fine. But you need to target tidal volume. You do not want the volutrauma and that electrotrauma, the worst two traumas, to happen to the baby. So Nelby, can you tell us why do you need to target ventilation in target volume in ventilation?
Thank you, sir. And so whenever we are ventilating a baby, one of our main objective is not to do injury to the baby and not to induce lung injury. And when targeting ventilation is an answer to that. Definitely is an answer to that. Actually, the concept of volume targeting came from animal studies, in which clearly showed that it is the volume, tidal volume, which dictates the lung injury rather than the pressure applied. From there, the concept of volume targeting came. Actually, this volume targeting helps to decrease the fluctuation of the lung volume, thereby decreases the lung injury. Let's go back to the same case which Sir was discussing. The baby was a 700 gamma baby having RDS. Suppose the baby was improving and you have put the baby on conventional ventilation without volume targeting. Then the lung dynamics, the lung compliance is keeping on changing. Over time, or because of the surfactant, that lung compliance is improving, and you have kept a specific pressure, say 20 millimeter. As the time improves and the compliance improves, you will be over-ventilating the lungs. The lungs will be more inflated, leading on to the worst thing we want, a volutrauma. Second thing, this not only damages the lung, this also causes hyperventilation. Carbon dioxide comes down and leading on to hypocarbia, thereby having long-term implication also. Suppose the same scenario, you are putting volume targeting, you have kept the volume as 6 ml per kg, then as the compliance improves, the ventilator auto-venes or comes down by the pressure comes down, so that the volume is kept same, the volutrauma decreases, and also the carbon dioxide washout and hypocarbia decreases, thereby decreasing periventricular locomalacia. Whatever said, we are now living in a world of evidence-based medicine. So what is the evidence? If you see, the Cochrane review have clearly showed that this volume targeting decreases the combined effect of BPD and death. Then periventricular locomalacia, intraventricular hemorrhage, then lung injury, hypocarbia, everything comes down. So volume targeting should be the dictum. It should not be an additional thing. It should come automatically. And one thing to add, rather than taking the blood gas in between and decreasing the this volume, it's better always to keep let the ventilator do the work. Let the ventilator do the auto-weaning purpose, so that the
thank you, Nelby.
Also will come down.
Thank you so much. So Dr. Nelby has beautifully explained the concept why we should always target ventilation. We live in the evidence-based era, and then there is lot of, this is only one of the most quoted evidence. That's all. There is enough and more evidence to say that targeting improves outcome when you ventilate. Now, if you look at all the outcomes studied, all are short-term outcomes. None of the long-term outcomes have been studied. That doesn't mean that they don't improve. If all the short-term outcomes improve, probably long-term outcome also should improve. But you should know the fact. And absence of evidence and evidence of absence are not the same thing. So probably it should be the norm. So having said that, now in HFO, so we have set a standard of ventilation now by you cannot ventilate a baby without setting the target volume. If you don't have a ventilator which has that VG or TTV mode, you can still target volume by looking at the tidal volume and then calculating and then weaning your PIP fast. If you have the machine, you don't need to use the machine will do the reduction of PIP on its own. But now we come to our case. What about in HFO? Is it possible to target tidal volume and will it improve outcome? It is by itself a large discussion we had in yesterday. I can see a few from yesterday's workshop. We discussed this, but then we will just go to the basic question that I will start analyzing with. If at all you are going to target volume, conventional, we know that 4 to 6 ml per kg, 4 ml for a term baby, 6 ml for a preterm baby, or higher for a even higher if it is a more preterm. Why do you do that? Because the volume that you give, majority dead space is proportionately larger in preterm babies. We are not interested in dead space ventilation. We want to ventilate the alveoli. So in order for the alveoli to get sufficient ventilation, for a smaller baby, you need to use larger ml per kg. 4 to 6 is what we all use. But can you afford to use the same in HFO? You cannot. Why? Because you will be eventually damaging the lung. You started by using HFO for ventilation protection and you are going to damage. You don't want to do that. So one of the basic principles in HFO is never ventilate alveoli, ventilate only the dead space, and from there the effect trickle down. If that is so, what is the value? We need a magic figure. So now, Nilesh, please tell us what is the value, optimal tidal volume in HFO that you want to look at.
So again, tidal volumes, we know in HFOV, we are ventilating the dead space. So we should not exceed the volumes to prevent volutrauma in HFOV. So the volumes, if we consider the volumes from literature, it is anywhere between 1.6 to 2.4 ml per kilogram. How do we go about setting kind of a tidal volume or finding out what is the optimal tidal volume in a mode like a VG mode, like a volume targeted tidal volume mode? So what we usually do in these ventilators is ensure that the baby is stable, then try to recruit the lungs to an optimal mean airway pressure, and then set the amplitude to get a good wiggle. And then we monitor the baby, we do blood gases, and the point that we also monitor the diffusion coefficient, the DCO2. And once we get a good PCO2 levels in a good range, like PCO2 around 40 to 45, so we mark the parameters, the amplitude for that compliance or for that pathophysiology of the lung. We mark the parameters and then go about setting the volume guarantee mode. We should understand that we can set around 1.6 or to up to 2 ml per kilogram for a term baby, and for a preterm baby like 2.2 to 2.4. And then we can monitor. If you are unable to get those tidal volumes with the amplitude in the conventional HFOV mode, one thing to remember is the frequency. The frequency, the type of frequency you are setting. You should know that there is something called the resonant frequency. For each pathophysiology and for whether it's a term or a preterm baby, there is a typical resonant frequency which you should be conversant with. So you should set the frequency also within that range. And finally, once we have a good stable PCO2, we go on to the HFOV VG mode. In the VG mode, we should remember that the relationship between frequency and PCO2 clearance, I think we'll go.
Sorry. So basically, very nicely explained by Dr. Nilesh. So the tidal volume, if you look at all these are very old studies. None of these are 21st century studies. All the 20th century studies looking at the dead space in neonates. So if you want to take a summary, I put it as the last part. 1.5 to 2.5 to 2.5 ml per kg is what you should be actually starting with. But as your expertise goes up, you tend to ventilate with lower tidal volumes, even 0.9 ml per kg and all that. That's a different story we will not discuss today. So do not start with more than 2.5. And very rightly, as said by Dr. Nilesh, if you can start with a lower lower tidal volume, the better it is. Do not exceed 2.5 ml. The idea is ventilate only the dead space. Now, I will skip all the studies for lack of time. Now, how are you going to do this? How are you going to target tidal volumes in HFO? Dr. Sangamitra, are you there?
Yes, sir. Yes, sir.
Go on.
So basically, when we want to target tidal volumes in HFO, you have planned, like Dr. Nelby has said, you want to set a tidal volume of somewhere between 1.5 to 2.5 ml per kg. So see how much tidal volume you want to set, and it is same like conventional volume guarantee, where you set the VG and then you have a delta P max. So you fix your range of delta P max, and then once you start ventilating, you see for the targeted tidal volume that you have set, how much delta P the ventilator, the baby is requiring. And then you look at the delta P the baby is requiring, and 20% above the delta P, you can put your max, delta P max, and then you start ventilating the baby, and you can adjust your tidal volume based on your PaCO2 that you see in your ADG. And one more thing that helps us here is you look at BCO2 levels also. Please
unmute. Sorry, mute all the other panelists. Please mute yourself. Mute everybody. Please go on. Sangamitra, please go on.
Yes, sir. Yes, sir. So set your delta P max based on how much the baby is requiring to target the amount of tidal volume that we have set. And one more tips and tricks in this is it makes us easy to identify tube block. Generally, when the tube block occurs, your delta P max starts increasing. So that's when you realize that the baby is stable so far, and then something suddenly happens and your delta P is increasing. You have to look at you have to suspect tube block, or whether you need to suction presence of secretions. So that is how you target tidal volume, and map is always constant.
Thank you so much, Dr. Sangamitra. So the basic concept is beautifully explained again. Like you set everything as per your HFO only, but here, like when you put the baby on targeted tidal volume in conventional ventilation, the pressure, instead of PIP, you set alarm limit of PIP max, and then you set your tidal volume. Here, you set, instead of delta P, you set delta P max as an alarm limit, beyond which ventilator will not provide you the tidal volume. And then you set your VTHF. VTHF, we said how much value we said, and this baby, anyway, now we won't be able to see in this. Like, so you have to see the wiggle up to the lower abdomen anyway. That has to be there in, or as like all other cases. So now, slide no more. Oh. Okay, so now to continue our story, this baby was, we started with MAP of 12. We did not have to go up any more than the conventional ventilation MAP. We came down. Baby was put on VG with a tidal volume. I started with 2.2 in this baby, and then we came down to 1.5. By then, your FiO2 baby was in air. Frequency, we had to go up to prevent hyperventilation. So up to 18. Actually, this is actually a different, we'll discuss this concept if we have time at the end, how you manipulate. And once he was on a MAP of 8 and FiO2 of 21, and of course a minimal tidal volume 1.5 ml per kg, he is now ready to be extubated. Now, we will not be, because of lack of, okay. So we'll just take the next concept very fast. So like use of HFO VG, will it improve outcome? And now I have a request I'm conveying from the organizers to all the experts. Please take only 2 minutes to answer your questions. Okay, will use of HFO improve the outcome? Murali.
Yes, thank you, sir. As for the discussions happen here, it may be obvious to everybody that it will improve the outcome. It's very clear that when we use volume guarantee, there will be fewer periods of hyperventilation, and you can have definitely a faster weaning. And the less period you keep the baby on the ventilator, the less will be the adverse outcomes. And it is clear that that HFO VG can stabilize the PCO2 through stable DCO2. So once the DCO2 is stabilized, and you can always
stick to the question. Answer the question, Murali.
Yes. Okay. Fine. That what I was trying to tell is that if you want the DCO2 stabilize, you can reduce the frequency of blood gas investigation.
Thank you, Murali. So to summarize, actually the evidence, we have the previous era, all the evidence had shown that like HFO worsens the outcome. 20th century studies, HI-5 study, HI-4 trial and all that, because IVH was more. Only short-term outcomes. But the first two studies without EVG, 2002, by one from UK, UCOS trial, and then the other one by Johnson et al. From US, they are the ones that showed that BPD improves with HFO and all. Subsequently, now the papers on HFO VG are sparse. We have only just one RCT, very few studies, which all show some improvement. The verdict is not out, but none of the studies have shown any adverse event by use of HFO VG. I will, for lack of time, I'll just tell the story. So our baby was extubated from HFO VG mode and put on nasal HFO on day 6 of. This is the baby. Baby is kept prone, and baby is on nasal HFO with the prongs. So I'm not sure, because there is a cling wrap. We put in our unit, we put a cling wrap to on the thing just to work whenever there is a shortage of incubator. That's why it is done like that. Mind you, this is a VN500 which does not have none of the machines have nasal HFO. This is actually improvised from here. Say HFO mode, you improvise it for nasal HFO. So now to continue. When to use, last two questions. Dr. Apurva, when to use, I'm sorry again, I'd like to request you to stick to 2 minutes. When do you use nasal HFO as a weaning mode?
Right. So nasal HFO, the maximum utilization currently based on the sparse literature that is available out there is to prevent reintubation. So anytime you have a child who has been extubated, if you want to prevent reintubation, that's where primarily all the studies have been done. There are 1 or 2 studies done in order to prevent intubation in a preterm babies, but majority of them is the post-extubation to prevent reintubation. That would be the most important. Now there you can start with a map of.
Go to the next indication, please. Sorry.
Yes, sir. So, and then rescue mode, that would be the other thing. Again, your baby is already on non-invasive and you're going to you're running out of that, then next would be the nasal HFOV. Those are the 2 most important indication right now.
Great. So evidence-based, and as a primary mode, very little evidence. Post-extubation mode, there is enough evidence now. And as a rescue mode, some cohort studies are there for use of nasal HFO. Now, what are there are various advantages. I will skip that. Now, the last question would be to the another legend in HFO, I would call Dr. Ramarao. When do you use nasal HFO?
Thank you. Thanks.
I'll give only 2 minutes.
Sure. Thanks, Dr. Manoj. To use nasal HFO, there are certain indications we already discussed. So we use it in once we wean from an HFOV, and once we extubate, you could extubate onto a nasal HFO. That's one thing. And the other thing is an extubation failure. In other extubation failures, before you consider intubation, you could use nasal HFO as one of the modes. And other thing is once we tried other modes like nasal CPAP. Or NIPPV, before you intubate, you could also try nasal HFO before you extubate. So basically, setup is more or less same. You could use either nasal prongs or nasal mask. You could use either of those. we have little experience in doing, nasal HFO. So even though we've used in a few babies, and we are comfortable with mask, but you could also use, nasal prongs. So settings is so kind of, it's more or less same. We'll use those, 4 settings, and based on the X-ray, ABG, and oxygen saturations, we'll change these settings accordingly.
Thank you, sir. So to cut the story short, now actually there is no recommendation. There is a McMaster NICU protocol on this for those of you interested, and there are a few other protocols also available if you want to start using nasal HFO. It's a fascinating mode, I would say. And right now, after starting to use this, you would love it. Now, if a HFO machine is free, any extreme preterm baby, 25, 26 weeks baby in my unit will automatically go post-extubation only to this actually. And once you start doing it, you will know the difference. But that's again a biased view by me. So you have to look at the evidence and use. So I would actually, first of all, I would like to apologize to all the experts for cutting you short because of lack of time. Or still we are exceeded the time, but you have done an excellent job, all 6 of you. Thank you so much. And the final word I wanted to say to the audience is volume targeting in HFO or nasal HFO. These are technological innovations that have actually outpaced the evidence. We do not have enough evidence. And when you try the vulnerable population, when you try interventions without evidence, you need to have sound reasoning. You should know the concept. If you do not know the concept, do not use this. If you can, the physiology, how it works, how when the baby deteriorates, can I pick up? Until all these things are clear, if you use these modes, you will create more harm. And another important thing is the flow sensor. HFO, VG, any volume targeting, if your flow sensor is no good, don't use it. It will confuse you. And there are various other concepts which we could not discuss. So I would stop here, and on behalf of all my respected panelists, I would like to thank the organizers for giving us time to present this new concept of volume targeting in HFO and non-invasive HFO. Thank you.
With that, we've come to the end of the session.
Hello. Hello.
I'd like to thank the chairperson and the moderator. Sir, would you like to say something? Okay. With that, we've come to the end of the session. I'd like to thank the chairperson and the moderator for such an informative and interesting session, sir. I'd like to thank all the panelists for their valuable insight. We will now be closing the session. Thank you, one and all. Before moving on to the next panel, we have a short 5-minute talk on CRP by, on CPR by Dr. Parimala. Over to you, ma'am.
Good afternoon. I know you're eagerly waiting the next talk. I promise you, I won't keep you more than 10 minutes, but I do feel it's my duty to kind of address such an elite crowd with this. I'm Dr. Parimala. See, there's one thing I find in common here. I have my teachers here, I have my students here, but there's one thing in common to all of us, from the junior most person who's sitting here to the senior most. We want to save every life possible, and we will go to any extent to do that. And every newborn life is precious to us. But But as we know, where are we today? With all this advance, with all of our expertise, where are we? India ranks 12th among 52 low and middle income countries with an infant mortality of 6 lakhs per year. This is UNICEF statistics. Though significant progress has been made in reducing under 5 mortality, the under 1 month neonatal, which we are responsible for, has not reduced significantly. In spite of all our talks, in spite of all our efforts, it has not reduced significantly. And why it has not reduced significantly? Next slide. The same thing again, it's just some more numbers to make the impact. India contributes to 1/5 of under 5 mortality globally, 1/4 of neonatal mortality globally, all over the world, and 1/4 is ours. and which translates to 630,000 deaths of under 4-week neonates. Though the causes of deaths have been detailed, so these are the details they have given, that infections, malnutrition, lack of access to proper medical care, apart from poor socioeconomic class, these are all things we cannot change because we are not politicians. We cannot change the infrastructure. We cannot change few things, which is contributing to this mortality. But as neonatologists, what we can do, which will help these babies from dying so much. One thing which got me thinking is, we know NRP. All of us are very well familiar with it. We know basic, we know advanced NRP. We're teaching it to every person here. But are we able to use this when a baby is actually not breathing? When does that happen? When the baby is not breathing, that happens at home. Who are the person next to the baby? Just the parents, or maybe the grandparents sometimes, or maybe just the maid with whom they've left the baby and both parents have gone to work. And that first 2 minutes we know is the golden minutes. And we know that we are not there to save that baby. So whether we can do something about it and whether that would reduce the mortality in some way. So this got me thinking, and that is what made me come up with this. Yes, so come up with the CPR app. So this is just an app which you can download in any Android mobile phone. It's there in the Google Play Store. It's called Save Baby CPR app. And this is not for doctors, as I would again like to insist. This is not for doctors. This is not for experts like us who are well versed in NRP. This is purely for your patient's parents. So every baby which comes to you after spending sometimes many lakhs in NICU, they go home, and I've seen some of them just come back dead. At least if they come back alive, you would be able to save them still. You could still use all our skills and do something. But when they just bring the baby dead, not doing any NLS, what we taught them, we all have a protocol. So we do teach NLS to every patient and then send them. If they've been in our NICU unit, we all do that. But still, when the time comes when the baby is not breathing, the parents are not, they're in shock, they're not doing it, or they forgot what we taught them. So I'm not talking about just having an ambu bag, searching for ambu bag when the baby is actually not breathing. All they have to do is just switch on the mobile phone. I'm sure every one of them are going to have it. Switch it on, see what to do, just follow the steps. So this is just nothing but mouth-to-mouth resuscitation, which they can give the baby at home, the first 2 minutes. And we know that babies respond extremely well to that initial respiratory support. So maybe every parent can do that for 2 minutes. Just watch that. But I would advise first you teach them how to do, because we don't want them doing it wrongly. Once you've taught them, they can download the app. They can just do it. And if the baby is still alive, then they can bring the baby to you for further care. So we've seen so many SITs. We've seen so many babies like this coming to us every day. So I want to request all of you, actually, just if in your practice, if you can advise your patients' parents to just do this first 2 minutes CPR by downloading this app. It's very simple. So if you have time, I can just play it. So we know that first golden 2 minutes is very important, and they have to do some resuscitation for the baby to just get back to the nearest hospital. And many times in Kerala and some places, and even remote villages in Karnataka, they have to travel many miles to just come to the nearest hospital. So this would be important. This is the details of the app. So it's available in Google Play Store. It's under the name Save Baby CPR. That's a direct link. And it's currently available in 3 languages, English, Hindi, and Kannada. Want to do in more languages so that language is not the barrier for the patient to understand and do it. So who are illiterate, yes, English is fine. Because in Karnataka, I did Karnataka and Hindi being national language. But I think with more support, we can translate into the other regional languages as well. So it has the CPR arm, 2 arms. One is for the, it will just ask them, are you alone or 2 people are available? If they say I am alone, it will show how 1 person can do the resuscitation. If 2 people are there, then it shows how we say like 1 person addresses breathing, other person addresses compression. So for both the babies, it is there. So it starts like this. They can select which language they want. And it asks how many persons are available with baby now. So people who can't read can just see the heads and just click on that, 2 or 1. Same in Hindi, same in Kannada. So this is a background technical details, which doesn't concern us much. Play that. Can you click on play? Might play.
Ooh. Is your baby unresponsive or not breathing? Check for response by tapping the feet. Baby. 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 If still no response, call for help.
I'll be the audience.
Look, listen and feel for breathing. If no breathing, check for pulse. If no pulse or unsure, start CPR. Open airway. Give 5 rescue breaths by covering the baby's nose and mouth with your lips and gently blowing air into the baby's lungs.
This is first, it just talks through them, because in emergency, there is a button where they can skip this whole thing because they would have already watched. When the baby is actually not breathing, don't think that it's going to talk like this and tell like, do this, do that. See, this is how you keep the airway. This is how you do that. All that will be skipped. It just says skip. They go to CPR. It directly starts doing, and the loop goes on for 3 minutes non-stop. So they just have to follow the loop for 3 minutes. At the end of 3 minutes, if the baby is still not better, they don't have help, they can just re-click it and they can keep continuing it as long as they get help, or if they can get the baby quickly. So this is only initial thing for people who don't know anything about it. This is like same what we teach them. And I think in the current COVID things, if you don't want to use your mannequins and all that because of mouth to mouth, and if you don't want patients to be using your mannequins, this can be used as well. But only difference I would like to stress is this is mouth to mouth and not amber bag.
Now give chest compression by placing your 2 fingers 1 finger breadth below the baby's nipple line in the center and press down to compress 1/3 of the chest. Count 1 and 2 and 3 and breathe. Now give 1 breath. Resume compression 3 and breathe in the same order till baby responds or you get help. Don't leave the baby till you finish CPR for 2 minutes. Let's start doing. Start giving first breath. Uff. Wait for a second, give second breath. Uff. Wait for a second, give third breath. Uff. Wait for a second, give fourth breath. Uff. Wait for a second, give fifth breath. Uff. Wait for a second, give chest compressions slowly. 1, 2, 3. Give 1 rescue breathe. Uff. Wait for a second, give chest compressions. 1, 2.
We're running short of time, and thank you so much for your valuable time. So this is just a gist. I cannot play further because I think the next session is due. Thank you very much. I expect your help in this.
Thank you so much, ma'am, for introducing us to the new app. I would like to start the new session, the next panel, and I will request the panelists, moderators, and chairpersons to come and be seated in the front. Dr. T.V. Ravi and Dr. Kirti will be joining us virtually. So, sir, are you all there?
Yeah. Yes.
I would first like to call upon Dr. Guru Prasad, who is a professor in HOD of JJMC Davangere, to come and introduce our moderator, Dr. Arvind Shenoy. Thank you, sir.
Good afternoon, friends. It's a pleasure always to introduce Dr. Arvind Shenoy. We have an excellent session for next 45 minutes on prevention of necrotizing enterocolitis. What should be the strategies? I think Dr. Arvind Shenoy should be the right person to moderate this. Most of you know there is no reason to introduce Dr. Arvind. Still, it's a duty as a part of the protocol. Arvind Shenoy is one of the most brilliant neonatologists I have come across in my lifetime. He is in one of the initial few DMs from PGI Chandigarh. Subsequently, he went to Australia for further training. I followed him in PGI as a 5th batch student. So he was the first DM neonatologist in the state of Karnataka. Then I followed him. And he settled in Bangalore and did great things. I moved to Davangere. That's the difference. He's a great academician. He is a passionate teacher and a good researcher. And more than anything,
He is a great human being. With this, and presently is working as consultant neonatologist and looking after Cloud9 group of hospitals. So I request Dr. Arvind Shanai to take over and introduce the panelists and start the session. And it's going to be one of the very enlightening session, I'm very sure. Dr. Arvind, please.
Thank you, Dr. Guru Prasad. You're indeed my guru. And thank you for your kind words, but we are running short of time. So with your permission, I'd like to start the topic right away. Could you please put the slides so that I can introduce my panelists? So we have with us Dr. Sahana. Sahana is here. Yeah, Professor Sahana here. I think the audience should clap because at least we'll know that. Dr. Raghavendra. Dr. Raghavendra Dodmani is here. Dr. Kiriti.
Yes, sir.
He's online. Okay.
Virtual online.
Okay. And Dr. Venugopal. Wonderful. Dr. Pradeep. Pradeep is here. Excellent. Dr. Biregowda. Wonderful. So all of us are here except I think Dr. Kiriti and Dr. Ravi are online. Guru is here in front of us. These are our CVs. You'll forgive me. All of you are very well known. If you don't mind, I won't go through all this. So the only reason for putting this up is most of the audience haven't seen you without the mask, and that's why we put it up. So go on to the next slide, please. Dr. Sana and Dr. K. So we begin with the case, I think, because learning comes to us from patients. So let's look at this case. This is a 30-year-old V2 mother with previous history of a death of a 30-week baby with NEC. Presents with PIH, threatened preterm labor at 29 weeks gestation. This pregnancy is fully booked and supervised, and all the scans, including anomaly scans, have been reported as normal. So, Dr. Sana, what is the role of antenatal steroids in prevention of NEC? Because these parents are frightened of the word NEC and they would want everything so that this baby does not die. Dr. Sana, over to you, please.
We all know that antenatal steroids has definitely reduces the risk of RDS. It also reduces the risk of NEC. Studies have shown that they, when mothers are exposed to the antenatal steroids, there is the NEC phase 2 or more, death is lesser. And also, when compared to the infants without exposure at all gestations. So the antenatal steroid should be given to all mothers who are at risk of preterm delivery within 7 days. It induces the maturation of the intestinal mucosa. It reduces the uptake of the macromolecules from the intestinal mucosa. Basically, it reduces the permeability and bacterial translocation to the liver. It basically protects the tight junctions, especially under inflammatory conditions.
Back. Okay. So, Dr. Raghavendra, what is the role of antenatal magnesium sulfate in this pregnancy?
So basically, antenatal magnesium sulfate is used in pre-eclampsia and eclamptic mother to prevent the tocolytic agent to prevent the uterine activity. So basically, it lowers the calcium level in the uterine muscles. So even MAG sulfate as a neuroprotection in a woman. So basically, it lessens the HIV, CP, and other brain injuries. Basically, it decreases the blood pressure and blood flow and stabilizes the cell membrane and reduces the excitotoxicity. And there are clinical evidence-based medicine says there are some studies which suggest that uterine magnesium sulfate exposure is associated with increased risk of necrotizing enterocolitis. It can cause even osteopenia and bone fractures in preterm babies. Thank you.
Thank you, sir. Now, the reason for bringing these two up was to actually have your opinion. One is neuroprotective, magnesium sulfate may cause increased risk of NEC. The other one, antenatal steroids, reduces risk of NEC, may cause increased risk of cerebral palsy. Will you or will you not use it?
It is better to use.
Dr. Sana, you agree? Would you give both? That means both the intestine and the brain both can get damaged. So this is the controversies, my friends. This is important to understand that we don't have all the answers. As of current evidence, Antenatal steroids are indicated because they prevent a lot of other things. But remember, if you're advocating repeated doses, there's a wonderful lecture by Alan Job that has increased incidence of cerebral palsy. The use of antenatal steroids is with caution. Magnesium sulfate, excellent drug. Neuroprotection, yes, it may. There is some reports of possible NEC. So remember, we are all dealing with double-edged swords, and this is the reason I brought this question up. So whenever you're using it, I'm not saying don't use it. Remember, there is always a double edge to every sword. Thank you so much for bringing these 2 points in. Dr. Kiriti, I know you're online and they are not showing your picture here.
Yes, sir.
We can hear you.
Yes,
Please
sir.
talk about the use of amoxiclav used in the mother, because this is one of the favorite antibiotics which is used in the mothers. Should it or should it not be used in this pregnancy?
Yes, sir. If mother takes amoxiclav, the amoxicillin present in that they definitely secretes through breast milk, sir. So microbial dysbiosis occurs in the newborn, and the risk of NIC is absence of primary infection results in a mucosal injury that affects the intestinal maturation and also increases the intestinal permeability, and there will be bacterial translocation from the intestinal lumen into the intestinal tissues, and you will get the inflammatory response in the form of activation of cytokines, apoptosis, and necrosis of the mucosa.
So this is the important point number 2. This is another drug which should not be used, because there is some evidence to show that when you use amoxiclav in the mother, you can have NEC in the baby. So in this family who's already jumping about NEC, who knows about NEC, there is one antibiotic you must warn your OB colleagues, madam, please use something else. Don't use amoxiclav, of course, only if indicated. Okay, Dr. Venugopal, the Doppler scan of umbilical blood flow shows reversal of blood flow. Would you like to comment on this as a risk factor for NEC?
Yes, sir. Any Doppler abnormality like absent blood flow or reversal of blood flow definitely increases the risk of NEC, especially in a less than 35 weeks of gestation. More than 35 weeks of gestation, we very easy to go with the feeding, where we are not restricting any men, or we won't go in a slower way. But if it comes in less than 35 weeks of gestation, once again we'll divide into whether it is extremely low weight, that is less than 1200 or 1250 or more than 1200, 1250. We'll go very slowly. Adopt trial also tells like whenever they are going aggressively, I learned 20 to 30 ml per kg, then the chances
We'll
of
come to that. We'll come to that. Sorry to cut you on that.
Yeah.
We will not talk about the feeds right now, but I thank you for making this important point that it is a known risk factor for NEC. Now, the point why we brought this up was if you don't have Doppler, how will you address this pregnancy? Would there be any other caution you would go?
Doppler in any antenatal.
Well, yeah, antenatal Doppler. See, there are 2 risk factors. The other we have not talked about. The other risk factor is this baby SGA? Growth restriction and or Doppler blood flow. As he rightly said, is a big problem.
A severe SGA will be chances of having an NEC will be more, because the simultaneously may have a Doppler abnormality even it has not been picked in antenatal.
So spare the brain and hurt the intestine. The diving reflex, as you have heard. So if you have these factors in this pregnancy, I think it's an excellent point. Thank you so much for bringing that up. So mother delivers 1 kilo baby at 29 weeks. Baby boy, why boy? More risk for NEC. So this baby, slight growth restriction at 1 kilo, it is not really SGA by definition, it's slightly lower. Dr. Pradeep, when would you start feeds in this baby? Any role for delayed initiation of feeds? I'm just giving you a background. This baby was managed by the previous panelists, and it has had all the best respiratory management and is doing fine.
Sir, I would like to start the feeds on day 1 itself and with mother's own milk. Because delayed initiation of feeds has not shown any reduction in the incidence of NEC. And whenever possible, we should use the mother's own milk. And in case the mother's own milk is not available, we should use the donor human milk. I would like to start on day 1 itself with colostrum.
Would you like to talk about the other points?
And there are other studies which have demonstrated that human milk feeding could reduce the incidence of NEC in premature infants compared to those fed with preterm formula in the randomized trials. And also Sullivan et al. Studied a total of 207 infants and found that feeding with an exclusively human milk-based diet is associated with significant lower rate of NEC than diet of milk fortified with bovine milk-based products.
There is nobody better than Dr. Guru Prasad to talk about this. Sir, what would be your final word? Because we all know mother's milk is important. I think your words will add wisdom to this.
And there is no second question about using mother's own milk. Expressed mother's milk is the best choice for in all gestational age babies and all days of hospital. Yeah, day one. I agree with what Dr. Pradeep said. The feeding should be initiated as early as possible.
Including in a respiratory sick baby, the feeding should be started. Thank you, Dr. Pradeep. I think we have covered this. Dr. Biragoda, is there any evidence to suggest any role of probiotics in NEC?
Sir, actually, before going to probiotics exactly, I just want to highlight the points of what are the mechanisms which probiotics will act. They will have upregulation of cytoprotective genes, downregulation of pro-inflammatory gene expression, and they produce butyrate and other short-chain fatty acids, which exactly help in to reduce the pH and oxygen tension, thereby suppressing the growth of pathogenic enterobacteria, and they support barrier maturation and compete with other microbes also. If we just look into the cumulative meta-analysis, actually it will help, but our overall mortality is not reduced. And additional studies are definitely required to guide the clinicians in most appropriate probiotics. If you just look at the one study, next slide. Next slide. Yeah, back slide. There was one study which has been published in Lancet. Probiotics may have definitely effective, but however, short and long-term safety probiotic needs to be assessed in large trials. Next slide. There is concern for the quality of preparation also because it has not been clearly monitored, and there is a lot of differences between the label and actual content, and quality control also is not there. That is another thing. And if you just look at the safety, when you just look at the safety, there are some incidences. Next slide, please. There are some incidences of case report where probiotic associated sepsis also is there, because what we are using these probiotics in the very extremely premature babies, which we have to be very cautious, where until large studies are available with us, we may not totally authenticate this, but however, definitely there is a role of probiotics use.
Thank you, Dr. Biragoda. You have touched on a very, very controversial area, because there are people amongst us who believe that the probiotics are the way forward. Anybody of the other panelists would like to disagree or add on to this? Any of you? No? See, the thing is, if you look at Cochrane, and there are many, many meta-analyses which have shown that probiotics protect against this thing. And those who have heard Dr. Sanjay Patole in Hyderabad would realize he is a strong probiotic man. He believes that there is a role of probiotics in prevention of NEC. So there are people who strongly believe in it. The meta-analysis, which are pooled with all the studies, tend to show an improvement. But Dr. Biragoda pointed out a very important thing, that not all the studies have used the same probiotic all over. Dr. Ravi, would you like to add anything? Dr. Ravi said, somebody said correct. I thought it was Dr. Ravi, no? No? You said correct. So, okay, they use different formulations. Some use a fungus, some use bacteria, some use spores. But studies have been done in our own country, including from St. John's. I'm not seeing anybody from St. John's in the audience. Including from St. John's, a randomized control trial was done, which showed that the incidence of NEC was substantially less. So the last word on probiotic, as Dr. Biragoda clearly said, has not been spoken. If you are planning to use probiotics, please remember there are safety issues which you should be aware of. And probably you should use, as of now, the current evidence is you should use one which has multiple organisms, not a single organism probiotic, but this may change as more evidence emerges. So one of the ways of prevention of NEC, which is most talked about and researched, is use of probiotics. Pradeep, when would you start feeds in this? Sorry, we have already done this. Okay. Which probiotics are available in the Indian market and which are suitable for use in this phase?
There is a probiotic by the trade name Daralac. It has 4 organisms: Lactobacillus acidophilus, Lactobacillus rhamnophus, and Bifidobacterium longus, and Saccharomyces boulardii that can be used. There is another one called Rescunate, and the other one is Econorm sachet, which has a Saccharomyces boulardii.
Which is a fungus.
Yes.
So there is a fungus, there is a bacteria, and there is also one which contains a combo. Okay, the combo is the one which has been trialed in St. John's, and many of the people I know are using that, but this is not a promotion for any particular brand. So if you are planning to use probiotics, read the literature carefully, be aware of the consequences, and then you should use it. If at all you use it, one of the things which you should remember is that use it if the rate of NEC in your unit is pretty high. If the NEC rate is anyway low, you don't have to use it. So, Kuru, would you like to add to this? No. Roxana, mother is unable to provide breast milk. What are the options to reduce the risk of NEC in this phase?
Mother's own milk is the ideal milk, but when mother's milk is not available, the next best option is the donor human milk. So the donor human milk acts as a bridge till the mother is able to produce the milk. Next slide. But remember that donor milk is not same as the mother's own milk. It is pasteurized, stored. The fat content is lost. Macronutrient content of the donor milk also varies. And also there is significant variability of the immunoactive factors after pasteurization. But studies have shown that significantly it reduces the NEC when compared to the formula feedings. And the feeding tolerance is also better.
Dr. Raghavendra, how would you increase the feeds once breast milk is available?
Next slide, sir. So there is sufficient evidence saying that human milk feeding is much better compared to the formula feed. And again, minimal enteral fail is safe alternate to complete fasting. So coming to a clinically stable, very low birth weight infant. So there should be early introduction as early as day 1. And you have to, there is sufficient evidence indicates that slow rate as low as 15 to 20 ml per kg per day, or faster rate at 30 to 35 ml per kg. Advanced practice is safe and it does not interfere or increase in the incidence of NEC. Quality of evidence is good. And next comes when there is a intolerant preterm infant without any clinical and radiological evidence of NEC, you have to have a minimal enteral field rather than complete suspension. And there is no evidence supporting continuous or intermittent tube feeding in preterm infants. And remember, human milk based fortifier as compared to bovine based fortifier may reduce the incidence of NEC, but additional studies are required.
We'll come to that. I think you've made 2 excellent points, sir. Thank you so much. This has been actually summarized very well in the clinical practice guidelines of NNF. I happen to be chairman of that committee, and we have reviewed all the studies till date. And the important point to make is what Dr. Raghavendra has said, that number 1, of course, human milk. Number 2, feed increase even 30 to 40 ml per kilo per day is acceptable, not associated with any risk of NEC. Number 3, that even if you're not able to feed due to other reasons, please maintain minimal enteral nutrition, which is 15 to 20 ml per kilo of breast milk can be given to the baby. Dr. Kiriti, the baby has reached EBM feeds of 100 ml per kilo per day on day 9. Should you add a milk fortifier?
Actually, there is no optimal timing to initiate a fortification. It is not yet established so far. But many centers, they prefer to start fortification when feeding volumes reach 80 to 100 ml per kg per day, sir. And it is fortification that continue toward the hospital stay of preterm baby. And titration of fortifiers should be based on the growth and the other markers of nutrition status, sir. Suppose a preterm baby fed by donor milk, because donor milk is a deficit of a lower level of protein and energy content. So we have to fortify the donor milk, sir. And if mother wants to give her breast to the baby, then we can encourage some feeds to direct breastfeeding. if while maintaining other feeds by expressed breast milk with HMF prior to hospital discharge. Suppose if infant growth is acceptable, then we can slowly increase the direct breast milk, and you can slowly cut down the fortified express milk gradually, sir. Thank you, sir.
Wonderful. Thank you, Dr. Kiriti. You have brought out two important issues. The number one issue is the panelists. Would you wait till 100 ml per kilo or would you fortify earlier? Do any of you have a contrary opinion? See, there is some evidence to suggest, see, one of the biggest problems in our country is EUGR. We all get babies who are already malnourished. Then we have intensive care. They come out of a severe illness. They have lost so much weight. They are extremely growth retarded. So the question is, we need to nutritionally manage them. PPN is okay for a sick baby, but a baby who can tolerate enterally, why not give more calories? So the way to give is to add fortifier. The question is, when do you add the fortifier? Any of the panelists? 100 ml per kilo is what is recommended, but there are certain studies which have looked at even at smaller volumes feeds to start a fortifier. That is an area of controversy, but you need to know that the use of fortifier in general is still recommended. Whether to use human milk based, which is better, or to use bovine milk based fortifier is dependent on unit policy. As of now, I'm not aware of any direct head-to-head randomized control trials, but in general, the consensus is favoring more use of human milk for obvious reasons. Dr. Venugopal, which fortifier would you use and why?
Once again, it has already been discussed. Fortification, like human milk derived fortifier is better. It has been shown in 1 or 2 trials, but N number is very less. More number of evidence which is supporting the human milk fortifier comes from the evidence where it is been compared to formula feeding with human milk fortifier. So that's a bit controversial. At present evidence, what I want to suggest is, if the patients are affordable, means to say we can go ahead human milk fortifier depending upon the unit policy. Otherwise, bone milk fortifier can also be used.
Okay, so the answer, short answer is use fortifier. Dr. Pradeep, you wanted to say something?
Yeah, I would prefer human milk derived fortifier.
Provided somebody is paying for it. Okay, I agree with you. There is a cost issue, and that is what is the reason which holds us back. But the use of fortifier, I think, is not controversial. The use of fortifier is strongly recommended, and that's what we all do. Okay, so Dr. Pradeep, when would you use a prokinetic in this baby, and which one?
Next slide, please. There are studies in recent years which show apparently conflicting results regarding the use of prokinetic agents in preterm babies with feed intolerance. The commonly studied prokinetics are erythromycin, metoclopramide, and domperidone. But there is a Cochrane review which showed that erythromycin at antimicrobial doses may not be effective in preterm infants with feeding intolerance. So till further studies are available, so I don't prefer to use prokinetics in babies with feed intolerance.
The CPG group has concluded there is no role for this thing. So even though these drugs are commonly used for babies who have small amounts of vomiting, gastric residuals, there is currently no good evidence to show that they work, and definitely probably should be used with a lot of caution. The baby started vomiting on this thing. Dr. Birigoda, any role for transpyloric feeds? What was that? I need to close?
Next slide, sir.
5 minutes, okay. So after this, we'll have a rapid fire round, and none of you will be shown your slides. Okay, so it's just for the, because 5 minutes we can't wind up because many of you have many slides.
I think there is a limited available evidence suggestive of transpyloric. The reason why we want to use transpyloric route is that could we bypass or could we limit the complications because of the reflux and complications, especially on the lungs. But there is a lack of evidence and finding an increased risk of once you start using transpyloric feeds, there is more of a gastrointestinal disturbance and some possible deaths also have been noted. And this suggests a randomized control trial of transpyloric versus gastric tube feeding in pre-infants is not a priority. Next slide. There is one retrospective cohort review which shows that transpyloric feeds is associated with this risk of death or BPD among very extremely low birth weight infants. And further investigation is required here because what in this study has happened is that they have not considered all the parameters, and they have not taken the consideration of other risk factors in the babies. So that is the reason this study may not be completely authenticated. So to conclude, I think I would say that transpyloric is not a choice.
Transpyloric is not recommended. So the short answer is that now we enter the rapid fire round. Please have your mics ready. Dr. Pradeep, should we feed this baby 1 hourly, 2 hourly, or 3 hourly? Why?
Sir, though there are some beliefs that the 1 hourly and 2 hourly feeds volume is less and this may help the feed intolerance, but the 3 hourly feed has not shown increased in the incidence of NEC. So any 2 hourly or 3 hourly both can be used.
3 hourly is what? This is for babies above 1,000 grams. Less than 1,000 grams, it's as per unit policy. Some units prefer to feed 1 hourly, but the frequency of feeding has not been associated with the incidence of NEC. So you can safely choose whatever your unit is used to. Dr. Sana, how this baby ultimately went on to develop NEC, as how often happens. How could this have been prevented?
Antenatal steroids, and then oral colostrum application, human milk, starting with mother's own milk, and then every unit should have their standardized feeding regimen. That because there should not be any inter-provider variation, and early picking up of the recognition of NEC is important. There are certain tools like Good Check NEC tool, and then neonatal needs, and it can be used though there is some low evidence in picking up those.
Would the next speaker also answer? Raghavendra?
Yeah. Basically, antenatal corticosteroids and proper breastfeeding techniques, standard feeding protocols, and clinical identification of neonatal signs and symptoms of NEC. That is very important. Picking up the signs and symptoms is very important in managing this case.
Excellent. So the crux of all this seems to be early pickup, because no matter what all you do antenatally and care you take, in spite of doing all possible, giving only human milk, you still can develop NEC because you don't know the last word has not been said. And the next question is, Dr. Kiriti, how long will you keep the baby NPO?
So it is better to give bowel for 10 to 14 days, sir. Why bowel means because patients with NEC have loss of gut motility. It is due to bowel inflammation and bowel thickening, sir. So bowel rest lessens the stress on the gut by limiting the luminal content during the time of intestinal stasis. So we can resume gradually by enteral feeding, and then if gastric decompression we have to do regularly by NG tube suction until the ileus resolves, and nematosis is no longer seen in the abdominal X-ray. During bowel rest, we have to concentrate on the parental nutrition, and we have to supplement the parental fluids because of third space leaks.
Dr. Venugopal, you want to add to that?
Yes, sir. What sir has told is right, but simultaneously I want to add a point like it's not fixed like 10 to 14 days. It depends upon how fast you can pick up the case.
So the reason for asking this is the most often grade 1 NEC is the overdiagnosed, and many babies are deprived of feeds for anywhere between 3 to 5 days. See, when there is intestinal perforation, child undergoes surgery, everybody would agree that NPO for a long period of time is mandatory and you have to put the baby on TPN. The reason for asking this question was because all of us in our unit always have babies, grower feeder babies who have feed intolerance. Is this stage 1 NEC not feeding for 3 to 5 days? Is it justified?
And stage 1 NEC is always overdiagnosed, as you told, sir. But yeah, in stage 1 NEC, we can restart it earlier itself rather than waiting for.
Because you don't have pneumatosis, the question is directed towards stage 1. That is the reason for putting that on. Thank you so much for clarifying that. Dr. Pradeep, role of oral antibiotics?
The studies have clearly proved that there is no role of oral antibiotic in prevention of NEC. However, there is one small study which has shown oral vancomycin to be effective in that. But at present, there is no role for oral antibiotics.
Oral vancomycin, gentamicin, so many studies.
Sir, initially there were studies on gentamicin they started using. The worrisome what we got is they started developing resistance. That was the worry which we started getting. later on, I think once we suspect a staphylococcal, maybe vancomycin is the good choice. Again, the worry is resistance to the bacterial resistance. So overall, I do not authenticate oral antibiotics, but still it's a preferential based on the individual cases. We can prepare.
Probably we should not, because so much resistance is there. So I agree with you. One has to be very careful. Any role for oral IVIG, Pradeep or any of the panelists?
Sir, again, oral IVIG, the role is not clearly authenticated. There were some studies, definitely it has got role, but the bioavailability and the usage is not very clear in the studies. So I do not totally agree with the IVIG, sir.
So any difference from the panelists before we wind up? Anyone would like to say the last word? We'll just start from Dr. Sayana. What would be your take-home message on this?
Take-home message is antenatal corticosteroids should be given to all the mothers who are at risk for preterm delivery.
Wonderful. You, sir?
Primary prevention is very important here. So identifying signs and symptoms early and treating the baby is going to benefit the newborn.
Excellent. Dr. Pradeep?
So the feed should be started on first day itself with mother's own milk. There is no role for prokinetics in feed intolerance and no oral antibiotics for prevention of NEC.
Even we can think about rapid rise of feeds so that extrauterine growth retardation can be avoided.
I think of late we have got a reduced number of NECs compared to the previous era. But however, we have to have a strong suspicion to about the NEC, especially when the babies are extremely very low birth weight. Once we have a strong suspicion, put them onto the investigation, especially imaging techniques. We have got a lot of advancement in the imaging techniques, and also we can put onto the biochemical parameters also. So once strong suspicion is there, we need to go for the aggressive therapy. So thereby we can prevent a lot of deaths.
So I will ask Dr. Kiriti to make the last comment as the panelist. Dr. Kiriti, are you online?
Yes, sir.
Your last advice to the listeners?
So definitely antenatal steroids and mother's own milk is better for the prevention of the mortality.
So I think that's some of the points I've put up on the board here. I think with that, I think we need to end the session. But before that, I must hand over to Professor T.V. Ravi. Sir, are you there? Please, you and Dr. Guru Prasad, request you to have the concluding comment.
Good afternoon, and thank you for this great opportunity to spend the morning with you and to discuss a very pertinent point as far as neonatology is concerned. And Dr. Arvind Shena has led the show in his own usual style, showing his expertise, and the panelists have given a very, very, very important and practical input to make this program very lively. Thank you all. Thank you very much. And thanks the organizers for having me here.
Please big round of applause to Dr. Arvind Shena. I said in the beginning, the way Arvind Shena conducts any session is very, very different. That they are the great qualities of a good teacher. How you conduct, make it interesting, and very clear take-home message. He didn't really deviate from the topic. So just to conclude, the panelists have made the points very clear. To prevent NEC, the take-home message should be prevention of prematurity, $1 million question. Anybody who can do that will be awarded Nobel Prize. So it is possible. The next best will be antenatal corticosteroid administration, a wonderful magic drug. Initially, we thought it enhances only lung maturity. It has very certainly proved it matures every organ in the fetus. Third one is using mother's milk, either EPM or mother's own milk or donor human milk. Early initiation and slow increment of feeds. And Arvind very nicely discussed whatever that you have tried is not very physiological to the gut. So only these 3-4 practices will prevent majority of the babies from developing necrotizing enterocolitis. Be probiotic, be antibiotic, whatever it is. They're all not really bowel friendly nature has not really made bowel for these things. So we have not very strong scientific evidence to really take it as a standard of care, standard of practice at this point of time. I thank you very much for this wonderful opportunity.
Thank you. Thanks for your excellent talk, sir, Dr. Arvind Shenoy and all other panelists. Take-home message to all of you is, so when you're seeing the baby with stage 1 NEC, assess and reassess, every 24 hours and 24 to 48 hours. And if the baby is okay clinically, if you are convinced that it's not NEC, don't starve the babies unnecessarily. Thank you. Start early feeds.
Thank you, doctors, for this wonderful session, and especially Dr. Shenoy for conducting it so smoothly. Without further ado, I would like to go with the next panel discussion on neonatal jaundice.
Hello, everyone. We are halfway through our day one's conference, not just in terms of time, but as our tag says, in becoming the best version of ourselves. So without further ado, we'll start with our panel discussion for the noon. It is on neonatal jaundice. I request Dr. Giridhar Sethuraman to be the moderator for the session. I call upon our esteemed chairperson, Dr. T.V. Ravi, to take over. So are you there, sir?
Good afternoon, ladies and gentlemen. At the outset, I would like to thank you for this great opportunity. And I'm glad that I have been entrusted to introduce an eminent neonatologist from India. So none other than Dr. Giridhar Sethuraman, who is the professor of neonatology, Chettinad Hospital and Research Center, Chennai. He did his MBBS from Kilpauk Medical College, MD from the prestigious MMC, Chennai. Thereafter, he went on to do DM neonatology from PGI Chandigarh. He has extensive neonatal intensive care experience, and he has co-authored OSCE and has framed a lot of his questions. He has several publications and contributions to various books in neonatology. He is examiner for DM neonatology and fellowship in neonatology. He is an NNF recognized trainer for non-invasive ventilation and neonatal resuscitation programs. I welcome Dr. Giridhar Sethuraman to take over from now as a moderator and start the session. Over to you, Dr. Giridhar Sethuraman.
Thank you, sir. Am I audible? Am I visible? Yeah. So it's a pleasure being a part of South Neocon 2021. The hybrid model is slightly new to us because I think this is my first program in a hybrid model where panelists are both online and offline on-site. So it's a pleasure being a part of South Neocon. I thank the team of South Neocon, our beloved Dr. Bidri, Dr. Kotresha, Dr. Dinakar and Dr. Prashant having given me this opportunity to conduct this session. It's a difficult task in emulating Dr. Arvind Shenoy. The earlier panel discussion, I had the opportunity to listen to it entirely. I think it was wonderful. If sir is there, thank you. Just my congratulations to sir. And so this topic, neonatal jaundice, it's going to be we know that's a very vast topic. And time is limited, hardly half an hour, already running late. So without much ado, I will just like to introduce the panelists. First, I'd like to share my screen. Is my screen visible there?
Yes.
Yes, sir. Thank you, sir.
Yeah.
So I think the panelists in this panel discussion need no introduction. First and foremost, I would like to, it's an honor to introduce one of my teachers, Dr. Guru Prasad. I think he's been known as a teacher of neonatology for many years. One of the forefathers of neonatology, I'll say. I think he's one of the person who's actually motivational to people like me also. It is an honor to have him in this panel. His insights in this panel will be very wonderful. The other panelists, I don't want to waste time in introducing them. I think most of them are well known and in their own areas of research and teaching and academic and patient care. So welcome you all, Dr. Jagdish, Dr. Fatehpur, Dr. Biragowda, Dr. Senthil Kumar, and Dr. Kirti. So I think Dr. Sahana, whom I had put up as one of the panelists, is not there in this panel. So her questions will be taken up by me. So I think we can go to the discussion. See, I'd like to, highlight a case-based discussion because that brings out the various highlights of newborn jaundice in terms of the thought process, the management, and also what I can get feedbacks from the different panelists and also from seniors sitting on site. So we have a baby X who is a boy born by forceps delivery at 36 weeks of gestation. And this boy has been exclusively breastfed, and the swelling has been noted in the parietal scalp at 36 hours, and the baby is icteric up to legs. So this was noticed by the attending physician. The obstetrician says that the mother is ready for discharge. It's already 36 hours. This mother, normal delivery, the mother is ready. The obstetrician wants the mother to get discharged. Indirectly, she wants the baby also to get discharged. So this is a question for just 1 minute. Guru Prasad sir, are you there, sir?
Yeah.
Yes, sir. Sir, I think it's this. Why I wanted you to answer this question is we have to give us the show us which is physiological and which is not physiological.
I think thank you very much, Giridhar, for your wonderful introduction, and all friends here sitting. He has placed a very important clinical scenario. It's a late preterm, 36-weeker, and developing jaundice at 36 hours. That is mid-second day of age. So 2 things that you should note, that this baby has 2 important risk factors. One is it is a late preterm. Second one, he has mentioned it is an instrumental delivery. There is an evolving cephalohematoma. So these are 2 important risk factors for this baby to develop hyperbilirubinemia. Question is it physiological or pathological? Globally, 40 to 60% of the babies will have physiological jaundice, term babies, and it may go up to 60 to 80% if it is preterm babies. But remember, jaundice which appears on 3rd day, later 2nd or 3rd day, that too on face is going to be physiological. Anything which we teach students, less than 24 hours, it is a serious jaundice, serious concern. Here it is 36 hours in the presence of risk factors like late preterm and concealed hemorrhage. It has to be treated as pathological jaundice, and you should try to convince mother, I need to monitor this baby more often, and there is this risk that this baby may rise its bilirubin and may land up in trouble. It is something very benign which we can treat. So Giridhar, the take-home message is this baby should be closely monitored and initiated treatment looking at the reference charts that we practice.
Yes, sir. Thank you, sir. Sir has been bang on there because the distinction between what constitutes physiological jaundice and what is non-physiological is, it's just an entity. That's all. I think the distinction is very vague there. So intervention, whichever requires intervention, even we should know that your physiological jaundice might also require intervention. To identify
Kramer's rule of cephalocaudal progression of jaundice. If you say the jaundice is up to legs, it can be anywhere from 11 to 14 milligrams per liter. That's definitely something worrying.
Yes, sir. So that is the reason that I want to put up this slide. So just don't reassure them saying that it is physiological. This baby has risk factors. About these risk factors, Dr. Sahana has been, she is not here. I think I will take up this question. These are the risk factors because sir was mentioning about the risk factors. The more the number of risk factors, the more the likelihood that this child will land up with the requirement for phototherapy or other things for treatment of jaundice. So this baby is going to be a preterm child, less than 37 weeks. and baby is having cephalomotoma or bruising. These are the two things in this child, your preterm child and your cephalomotoma and bruising. And this baby otherwise is having some ABO setting or an RH setting. There is known to be DXPD deficiency in the mother or the previous SIP has required phototherapy, or if she is a first-time mother, or she is exclusively breastfeeding the child. All these are risk factors that this baby could land up with the requirement for interventions for jaundice. So we have to be careful in these scenarios. So Dr. Sendal, can breastfeeding be related to jaundice? Because there is always a query whether, when we all know that we are all proponents of breastfeeding, still there is a group of people, and also we have a lot of international bodies which actually say that breastfeeding can be stopped for 48 hours in terms of prolonged jaundice. What is your take on this?
Yeah, regarding breastfeeding, only it is said can have been breastfeeding jaundice or on breast milk jaundice. One isn't related to feeding it because of this is a preterm baby, 36 weeks. So initial suckling, swallowing, and initial feeding should be monitored carefully. Otherwise, they will be having some form of dehydration. The enterohepatic circulations of this bilirubin will be high, may land up in a jaundice. Usually for breastfeeding jaundice, the baby will have excess weight loss and shows the signs of dehydration, and the jaundice will be getting exaggerated because of increased enterohepatic circulations. Another one is called breast milk jaundice, which is usually just start within 3 to 4 days, but it usually peaks around end of second or third week. So now, even whatever may be the things for breastfeeding jaundice, we want to encourage breastfeeding because it clears the meconium and decreases the enterohepatic circulations. Even for breast milk jaundice, we need to continue breastfeeding. Only if the value is more than 20 or 25, then only we need to bother about breast milk. But otherwise, we can continue breast milk for things. For breastfeeding jaundice, we should increase the amount of milk.
So do you really want to actually stop breastfeeding when the levels are about 20 to 25? And this is baby is probably in the early second week or middle of second week. Levels are pretty. Otherwise, the baby is well. Do you want to actually stop feeding temporarily and then reevaluate, or what will be your intervention?
No, we just continue breastfeeding. There's no need to stop or.
So this is this is the difference that we are. This is the one point that I want to highlight here, because we will go through a lot of guidelines on neonatal jaundice, especially from Western societies. They mention that when other causes are ruled out and the jaundice seems to be prolonged, then I think breast milk could be a culprit, and there could be a advantage in stopping breast milk temporarily for 24 hours and reevaluating again. But breast milk jaundice itself, the terminology itself is, what experts are feeling is it is something that we should not use. I think we heard from Dr. Bhutani 2 years back also that I think even in the Western societies, this terminology is something that people don't want to use at this point of time, because still breast milk is not the culprit here. Nothing has been proven in breast milk to be causing prolongation of jaundice so far. All these are hypotheses. The problem which happens with breast milk is not the breast milk, it is only the breastfeeding failure. So the failure of breastfeeding, giving inadequate feeds, is the reason why this jaundice tends to be prolonged in this baby. So at this point of time, ensure that adequate feeds are reaching the child, and breast milk is the way to go. So next question. There was a mention by Dr. Guru Prasad about the cephalocaudal progression of jaundice. So, therein where visual assessment can play a vital role in identifying jaundice. Jagdish sir, if you're there, what is your take on this, sir, about the visual assessment of jaundice?
Thank you for the opportunity. So there's high evidence to say that visual assessment in high levels of jaundice is poor, whereas still when the jaundice is around 12 to 14, visual assessment, there's a good correlation, provided like our bedside teaching, go to bright light without a yellow background, and that may give you a clue at lower levels. But at high levels, definitely there is a poor correlation between the levels of jaundice, that is the measured bilirubin, and the clinical assessment. So as this baby has enough risk factors, and the jaundice is already at around 11. I mean, reaching the legs, it's a bell ringing sign that it is doesn't correlate with the levels, but yes, it gives us a warning sign there's something sick. With just to add to a mnemonic called jaundice for assessing the risk factors for the postgraduates who are there. So you can just easily remember the risk factors. The jaundice within 24 hours, Asian range, under 37 weeks, breastfeeding jaundice, that is nursing, and then deficiency of enzyme, incompatibility, cephalohematoma, and elder sibling receive phototherapy. So that adds on to this. So as far as visual assessment for high levels, I said correlation is poor.
Yeah, I think the message is clear here. When visual assessment, when jaundice is seen beyond the umbilicus, the correlation is poor. So at least at this point of time, don't reassure saying them that it's likely to be low. And of course, the environment in which the jaundice is visualized also plays an important role here. As far as possible, visualize jaundice in the daylight. So we'll go to the continuation of this case. You have access to transcutaneous bilirometry, and so we measure the bilirubin in the transcutaneous route in the glabella 36 hours, and its value came out as 11. We saw that the baby was icteric till legs. Icteric till legs in the Kramer's rule, the overlap of range was 11 to 18. So 11 was acceptable. And of course, once this value was seen, the next thing is the obstetrician, the parents all want discharge of the baby. So, Dr. Biragowda, if you're there, just a quick, can you give a quick recap of what is transcutaneous bilirometry? Because that seems to be the in thing for monitoring jaundice in most hospitals now.
I think that is the recent advance where we can immediately check, that is a spot check only we can do, where we are going to take the measurement of 3 readings. So once we take the measurement of 3 readings, we can average it and look in what exactly is the bilirubin well. Definitely it is a very good instrument, but however, it cannot be totally authenticated for the results. Once we need to have a clarity, as Jagdish Somana sir was talking, I think once higher levels are there, we need to go for the serum bilirubin level only. That is the best measurements.
So, you're right, sir. The problem with your transcutaneous is it's a good modality. It's a non-invasive modality. So parents are quite happy. There are frequently used instruments which are available in the market right now. Even more instruments are available, but they're not been rigorously studied before. So these are the ones which have been studied earlier. The Bilichek and your Draeger JM105. And the issue is once the higher levels of jaundice, again, correlation with your serum bilirubin, which is the gold standard, is going to be poor. So more than 13 or more than 13 have a bilirubin assessment. Of course, if the dark individual, or if it's going to be after phototherapy, or if it's going to be a preterm child, especially now the cutoff is less than 30 weeks, where transcutaneous bilirometry's correlation is poor. So these are the times when actually correlation, reliance on transcutaneous bilirometry could be an issue. So, but these are very good instruments where your volumes of deliveries are high. We know the jaundice is a very significant problem. That could be a role that these instruments have these instruments, if available, which could actually be very baby friendly, mother friendly, and also give us quick turnover times.
I think Giridhar, just adding to that, I think as we said in the beginning, physiological jaundice is universal in all babies.
Yes, sir.
We see of late lot of parents, and they say, why don't you check how much is the jaundice, all that. As it is a non-invasive test, you can just do a screening, show
Yes,
them
sir.
it is in the safe zone. The other way, you can avoid unnecessarily drawing sample. Only when you are suspecting pathological jaundice, you doubly confirm with the test.
Yes, sir. Yes, sir.
Before you decide about intervention. So
Yeah,
transcutaneous bilirubinometry is extremely useful in an hospital setup prior to discharge for screening.
Yes, sir. Thank you, sir. I think the message is well taken. So I think this question has already been answered. How effective is it? And because it works, it works at the skin level. It doesn't actually assess what is there within the bloodstream. So I think that might be either an underestimation or an overestimation. At lower levels, it tends to slightly underestimate. At higher levels, the correlation is extremely poor. So it's more than 13 have a serum bilirubin check through a blood drawing. So I think the gold standard right now is lab bilirubin. We all understand that that is going to be the gold standard or comparison level. But if we send a bilirubin level for any neonate to 3 or 4 labs, we get 4 different values. That is a problem with this because there seems to be no agreement between labs. So I think Dr. Kirti, if you're there, can you please comment on how is this method use a lab serum bilirubin and the pitfalls of bilirubin estimation using this method, ma'am? Because a lot of different discrepancy in lab reports we see very commonly.
Thanks for the opportunity. Yeah, everybody does face this issue with serum bilirubin. Almost to the extent of 10 to 20% variation can be there between labs, that is inter-lab variation. Not only even intra-lab variations can happen like with respect to the same patient and the same sample. So this is a common issue which everybody does face. So this not only depends on the quality of the lab, but also the method which is employed to analyze the serum bilirubin. So we do have like around 3 methods which are employed commonly like to analyze the serum bilirubin. One being the DISO method, the second one being the Vitros method, and then the HPLC, which is the gold standard. And apart from that, we do have like for academic purpose like micromilli spectrometric module, which uses only 0.01 ml of blood, and which is more in relation to the unconjugated bilirubin rather than the total. Coming back to the DISO method, before enlightening on these methods, so we have like these 4 fractions within the serum bilirubin. There's something called as the alpha fraction, which is more in relation to indirect, and other the beta, gamma, and the delta, which are more in relation to the direct component. So this DISO method, like the issue is like it does measure every component, but there is an issue with respect to the beta fraction of the bilirubin. So estimation of this component, and which in fact the Vandenberg test, which is used like it's a modification of this DISO method. And then the other one which is not depicted, sorry, in the slide is the Vitros method, like where we have an issue with respect to the delta, the delta component, like which is closely bound to the albumin. The fraction of conjugated blood, that is basically underestimated in case of the Vitros method. So that is the issue with respect to Vitros, and it's like, and that is the most reliable thing, but bad luck, it's a costly affair, and it is more often like restricted for the research purpose rather than for like a regular neonatal jaundice care.
So thank you, sir. I think you have brought out the different methods of lab estimation of serum bilirubin. The commonly used method, as you told, was a DISO method. But every method is going to have a pitfall, and probably the direct fraction is the one that always causes the problem, because we see labs commonly reporting direct fractions either too high, which could be related to the methodology, or could be the presence of some more directly acting bilirubin is not it's getting picked up there. So this HPLC, again, it's going to be a very expensive one, more for research rather than practical applicability. So still we have a problem with lab tests. I think standardization of labs will play a very important role in actually getting your bilirubin, to improve the reliance on the lab bilirubin levels. So we just have continued the child. This child, as I told you, is at 11 at 36 hours. And so this is this was plotted on the chart there, and this is what we have. So, we all know this chart. We have used this called the Bhutanese nomogram. Just Dr. Sendil, can you just quickly tell me about the nomogram? How do you use it?
Yeah, actually, this Bhutanese chart is it's a pre-discharge to assess the pre-discharge bilirubin. So you can make a decision whether we want to discharge it, or we want to follow the baby, or we are not to discharge. We must make sure that. So you have 3 lines. It's plotted against an total serum bilirubin with an hours of life, and you have 3 lines. One is in 40th percentile, and top one is in 95th, and another one is in 75th percentile. So anything less the bottom line below this is a low risk. Anything above the 95th percentile is an high risk. If your baby is in between the 75 above the 75 percentile, means we no need to discharge it. And anything below that 40 percentile, that means low risk category, we can discharge it. Anything between 40 to 75, we need to follow within 24 to 48 hours. That's the thing we can get it from this Bhutanese chart.
So right there, if the take-home message from this, when you plot on these charts, if it is going to be in the high intermediate risk zone and the high risk zone, then I think we should be more cautious in discharge. Either we should call them back immediately about what is going to be the next question on. So about discharge, I think Dr. Suhana, I think, is not here in the thing. So that was what was actually discussed. So if the baby's bilirubin prior to discharge is in the if the baby is otherwise more than 38 weeks in the no risk factors, even if in the high intermediate risk zone, then we can actually discharge her and but ensure that the baby comes back to us at 48 to 72 hours, because this baby's bilirubin could still go up. But if the baby is going to be in the high risk zone, don't discharge and have a bilirubin after 24 hours within the hospital itself. The baby is in the low risk zone, then you can safely send them home. I mean, mind you, this is for babies who are more than 38 weeks and without any risk factors. Risk factors are referring to in the previous question. But the baby is going to be less than 38 weeks, or the baby is going to be more than 38 weeks, but with risk factors, then if the baby bilirubin is in the high intermediate risk zone or the high risk zone, don't discharge. So there's a subtle difference here in the, when do you discharge? The baby, no risk factors, more than 38 weeks, even in the high intermediate risk zone, discharge, but call them back. If with risk factors or less than 38 weeks, even the high intermediate risk zone, don't discharge. Of course, the baby's bilirubin is in the high risk zone, then you don't discharge and have a repeat bilirubin after 24 hours. So just 1 minute, I'll go to that previous slide. Yeah, sorry, I think I missed the. Sorry, yeah. So this baby is at 68 hours now. Baby is reassessed in the Well Baby Clinic after discharge. Bilirubin has come as 17. Now at 68 hours. How will you plot the bilirubin level, and will you start this baby at phototherapy? This question is for Dr. Fatehpur.
Thank you, Dr. Girdhar. Actually, there are well-established phototherapy nomogram charts which are available, graphs, where we have to plot depending on the age of the child and the bilirubin levels. Here, there are 3 different categories: infants with lower risk, medium risk, and higher risk. I will not go in detail about that. This child, he is having a late preterm and also having risk factors. So he is a high risk category child. So this child need to be have lower threshold for starting phototherapy. So for this 68 hours, almost 17, it needs phototherapy. And also because it is well above the plot, what we have seen above the line for which he needs phototherapy, we have to even plot the same thing in even exchange transfusion levels also. And also we have to, in general, we have to start phototherapy whenever the child is having above the expected line in consideration with the risk factors, and also at least 2 to 3 levels below also we can start phototherapy treatment. Regarding risk factors, there are few risk factors like isoimmune incompatibility, the sepsis, birth asphyxia, bilirubin level, albumin levels less than 3 grams. So these acidosis, lethargy, these all increase the level of risk of kernicterus. So whenever we have to consider these risk factors whenever we are going to start the phototherapy.
So thank you, Fatehpur sir. I think this requirement for phototherapy, many charts are right now available. I think the one which we have been more accustomed to use is the American Academy of Pediatrics charts as per the jaundice guidelines given out in 2004. I think it all depends on the risk factors in the gestation of the child. In this baby, we had more risk factors. Gestation was also on the lower side. So we chose to use the high risk line, and it was well above the high risk line. So phototherapy is required in this child. So I mean, we cannot keep carrying on these charts everywhere. And right now, being smart is being the current mantra. I mean, I just wanted to ask Dr. Jagdish, are there smarter ways of evaluating the nature of interventions baby requires? Any other more user-friendly ways of looking at it, sir?
Yeah, as this today is an era of just everything answers just a click away. So I think there are 2 options for you all. One is you can have it as an app, or you can look into the web page. app, you have Billy Quick Calc app, where you just enter, which incorporates both the Bhutanese risk assessment as well as American Academy of Pediatrics guidelines normograms. So you can just need to enter the value, the age or the hours of life, and then you get the answer of the risk assessment. And when you just flip over, you can get also the normograms where you can get automatically plotted and gives you an answer for phototherapy or exchange. It's very easy to use, fastest to use, and quite reliable. And I think we are all in the pocket. The answer is in your pocket. And regarding for more than 35 weeks, you have the Billy Tool webpage, or you can have the preterm babies. You also have the Billy Rex, Premier Billy Rex webpage. So it's just a click away.
Yeah, thank you, sir. I think now smarter apps are available. I think Dr. Jagdish has been mentioning many apps. So you can use those apps. These are more user-friendly, give you, what you need to know. You don't have to, think too much about what needs to be in the child. Look at what is given in the app regarding the interventions required and go according to it, because these are based on the recommended guidelines. So we'll go to the continuation of the case. You have decided to start the baby on phototherapy because it was well above the cutoff line. And what is the nature of the phototherapy will you use, sir, Dr. Kriti?
Yeah, when I'm prescribing phototherapy, I need to make three things clear while prescribing things. One thing is like whether to go for conservative or intensive. Second thing, what's supportive care. Third thing, the monitoring part. So coming to the first part, like, should I go for conservative or intensive? So in that, like, what is, first of all, like, what is intensive phototherapy? We need to know. And when do you give this intensive phototherapy? How to give this intensive phototherapy? And then the last one, like, is there any issues, advantage or disadvantage of giving this intensive phototherapy? So to define, like, what is intensive phototherapy? Whenever there is irradiance of like anything more than 30 micromillivolts per centimeter per nanometer. So anything more than that is called as intensive phototherapy. And when to give this intensive phototherapy rather than like conservative is like whenever there is rapid rise in serum bilirubin 1, or maybe the serum bilirubin value what you got like is just maybe 3 milligram per deciliter hovering around the exchange range. So then maybe like you need to consider intensive phototherapy or conservative phototherapy. And then next thing is like how to give intensive phototherapy. Again, like we can give the intensivity like by choosing the appropriate unit. There are different units which are available, or decreasing the distance between the phototherapy unit and the baby. And then the third thing, maybe like by increasing the body surface area. So coming to the type of units like which we have. So with the good old, all the tubes being outdated, like we are left out, like we have now basically CFL system and the LED system, which are the advantages over the traditional ones is like basically we don't have like a hyperthermia issue or the dehydration issue with respect to this. So, and the CFL and the LED are almost like equally effective when it comes to like bringing down the serum bilirubin. The plus point could be like, yeah, so the lifespan of LED is almost like 50,000 hours when compared to CFL, which is around like 8 to 10,000 hours. So that is one plus point. And then, so with respect to the unit, second one, like the distance, we can reduce, as I said, like we can reduce it to like 15 centimeters close to the baby. Third thing, the body surface area, the irradiance, which is coming in contact with the baby's body surface area. Single surface, like almost it touches on 35% of the body surface area, and multiple, it could be double or triple, like it can go up to maximum almost 85%. So these are the three variants like by which like we can increase the irradiance exposure surface area. And then after having like given like which is whether conservative or intensive, which one out to when. So then the second one is basically supportive care, which is the most important thing after having initiated phototherapy. We need to maintain the hydration status, second thing. And then the third thing like monitoring. Apart from serum bilirubin, we need to monitor the temperature, because with these LED systems, like we have like hypothermia risk when it comes to these new modules rather than the hyperthermia risk, which was there anticipated in the older modules. So we need to be cautious about the hypothermia. Second thing, we need to monitor the urine output for the hydration status, apart from serum bilirubin.
Yeah, thank you. Just briefly summarizing what Dr. Kirti had so far told. So you can choose to start off with single phototherapy if it's on the line or just below the line. But if it's going to be way above the line or increasing, then always go with multiple units, because those are the ones which give you intense phototherapy, as defined that already. And regarding what the nature of the, instrument which we need to use, equipment now, I think LED units are available. And even though the meta-analysis actually said that both are equally efficacious, but still LED units in terms of giving higher irradiance at, and they are more user-friendly, less, they cause less temperature alterations. And very importantly, they don't, because our place, a lot of voltage fluctuations happening in India. So they work well during low voltage situations also. And they are more long lasting. So all these are brownie points for the LED ones. The super LEDs which are right now available, so most of them tend to use the LED devices, especially at very high levels. He has told a little bit about the monitoring also. I think Dr. Biragowda, can you just tell us when you decide to stop phototherapy, you initiated phototherapy? Dr. Kirti had told us about monitoring and also the temperature, the fluid balance and everything. So when you decide to stop phototherapy, how will you see the bilirubin levels and how will you stop phototherapy?
Regarding other monitoring, Kirti sir has already told. I just want to focus more onto the bilirubin level.
Yes, exactly.
Monitoring bilirubin level is a very important thing because we need to be very cautious. There are certain practical aspects I just want to highlight on bilirubin level. Many a times, so let's say a baby has got admitted for the phototherapy with bilirubin level of 18. And you send for the lab value for the next value. I think after 6 hours, you just get a monitoring done. Probably the lab may give 12 or something like 8. So it is very unusual. We have to be very cautious on these issues because before a lab person gives the report to the patients, we need to look at the report and again ask them to recheck and check, because sometimes what will happen is once you admitted the patient, you say that the bilirubin is 18, it is going to come down, and suddenly the patient will get the bilirubin level done and the bilirubin level goes something like 20. That also we should be very careful. And we need to prime the patients before and end what are the things which may happen. Generally, if you just look at the bilirubin rise, generally it rises on 3rd day and may go up to 9th day. So these are the days we must be very cautious for the rise of bilirubin. So I think we can get monitoring done about the bilirubin level repeatedly. Even we can get in 4th hourly when the intensive phototherapy, where the bilirubin level, intensive phototherapy is required, where the bilirubin level is very high. And we can get to bilirubin level done once a day if the bilirubin level has come down, which is in phototherapy range. I think we can stop the bilirubin when the bilirubin level is somewhere between 10 to 12. We can stop the phototherapy when the bilirubin level is somewhere around 10 to 12 or below that. And we must be very cautious about the rebound bilirubin rise also. So that has to be, we have to be very careful.
Yeah, thank you, sir. I think there is a lot of variation in practice, like what is being done. So I think monitoring, especially in terms of how frequently you have to measure the bilirubin levels, I think it's something that varies from institution to institution. What generally is recommended is at least have the first level after starting on phototherapy quickly, probably between 6 to 8 hours, so that you know that the phototherapy is effective or not. Once your bilirubin levels are static or started to come down, then you can choose to do it every 12 to 24 hours also. So I think if it is going up, again have monitoring every 4 to 6 hours or 6 to 8 hours, and then you can decide. So all this will actually let you know whether this baby is, can someone remove that annotation which has come, because which is there on the screen? The resource person, can you do that? So I think stoppage of bilirubin also is another thing that seems to be a lot of variation in that the phototherapy I'm meaning. So I tend to stop when the levels are too below the cutoff where we started. We started at 16. If it is 14 now, then I tend to stop it. But again, there is some variation here. So we need to understand that variation is likely to be there because these are all expert consensus. So quickly, Dr. Fatehpur, anything on the additional fluids, IV fluids or additional feeds to be given to the child in addition to breastfeeding, quickly, because we're running short of time.
Sir, you want to talk?
Actually, it depends on two things. One is what type of phototherapy you are using, and also the present condition of the baby. Regarding phototherapy, the latest one, LED, usually they don't cause much heat loss, insensible water loss. So usually they don't require additional pallada fluids or intravenous fluids. Whereas the older one, CFL and the conventional phototherapy, they used to induce a lot of insensible heat water loss. So usually we used to give more than 25% extra milk or IV fluids. Coming to the general condition of the baby, if the baby is lethargic, not taking feeds, or there is excessive weight loss, clinical signs of dehydration, or we have to give extra pallada feeds or extra milk we have to give. And also intravenous fluids, we have to give if the chance of going for, if they are just below the exchange transfusion levels, then also we need to start IV fluids considering the exchange transfusion. Otherwise, routinely for a well child, term child, we don't give any extra additional fluids or either milk or intravenous fluids.
Yeah, that's a message is clear. Don't stop breastfeeding. Breastfeeding needs to be continued. Express breast milk probably to supplement direct breastfeeding can be done. And if your bilirubin levels are pretty high near the exchange zone, the baby is appearing quite dehydrated, or then I think there could be a role for IV fluids also. I think the fluid of choice where people have used in different trials is 1/5 the DNS, but that is something that we'll have to make it and administer because it's not readily available. So the next question is
Dr. Giridhar.
Yes, sir.
Yeah. The organizers are asking.
Yes, sir, please.
Last 5 minutes they are telling.
Yeah, please, sir. I'll just wind up with this scenario alone, sir. I think the baby is now receiving single phototherapy at mother's side 12, and now, I mean, after initiating phototherapy at mother's side, it's now 20. So what will be the further plan for this, Dr. Jagdish, quickly?
I think since it's rising despite phototherapy and the rate of rise is quite a bit, so I would consider intensive phototherapy. And since it was receiving in the mother's side, so it assess whether it's the spectrum, intensity, distance, extent of exposure is right. And then I would try to shift him for a intensive phototherapy along with feeds and fluids if required.
Yes, sir. I think what we
assess for bind. Yeah.
Okay. So assess for bind. I mean, additional units to improve the irradiance. And probably giving fluids at this point of time might be mandated. Of course, this baby cannot be managed on mother's side. Baby has to come to the intensive care area. So this baby's bilirubin dropped and the baby has got discharged. So this is very common scenario. I think I have more scenarios, but I think we are running short of time. So I think what we discussed so far, it gave an overview of how we manage jaundice generally in neonates, which are more than 35 weeks. I think I just want to tell you that for less than 35 weeks also, we have some operational thresholds have been given as an expert consensus. I think AAP has its own guidelines. There is some Europe, I mean, the UK guidelines and NICE guidelines are also there. So I think we have more people who have come with guidelines for less than 35 weeks. We can choose to use which one of these we are comfortable with. But when I understand that this is one area which is commonly being explored, the final thing is not, I mean, we don't don't have the final word on this. More new innovations could be evolving. So if we could quickly have comments by each of the panelists, first by Dr. Guru Prasad.
Yeah, regarding what, Giridhar? Tell me.
Anything, sir, anything on jaundice, sir, because your passion is on bind.
Yeah.
I think so you can talk about bind, sir, bind and how it should never be and it should never be there.
Yeah, it is very unfortunate that even today we are seeing bind. And because I'm working in a medical college hospital, and on average every 6 months we see one case of bind. And secondly, we continue to see RH hemolytic disease. That is something which is unacceptable, despite the anti-D being made available. Third important thing is a lot of babies who are discharged from our own hospitals are coming back to the hospital. I request the residents, postgraduates who are here, please do a good examination, especially with reference to feeding and the clinical assessment of jaundice prior to discharge. In the presence of risk factors like any setting for blood group incompatibility, all that, be very careful. If you are discharging prematurely on request of parents, as it was discussed in the scenario, make it a point to come back after 48 to 72 hours. We have seen our own inborn babies who are discharged coming back with bind after 3 days, 4 days. That should not happen. And ensure breastfeeding for no reasons. Breastfeeding should be stopped in any of these infants. Continuing breastfeeding is very important in resolution of the pathological jaundice in majority of the situations.
Thank you, sir. Those were wonderful messages. I mean, Dr. Biragowda, anything what you have covered so far, any of the messages to the audience?
No, sir has given a very good message. I just want to add on to the indirect, RH hemolytic disease. Choosing the blood is very important. Many times they choose the wrong blood, which once you do an exchange transfusion for the, especially RH hemolytic, where we are bound to do exchange transfusion many times. The moment you choose a wrong blood, probably we are going to see the case which is.
So can you tell us what blood will choose, sir, depending on scenario?
The best blood what we are supposed to choose is AB plasma, which has been mixed with the own negative cells, is the best blood. That is the best blood which we have to choose. Option is only given to that.
Okay. If the baby's blood group is mother is if the mother is A negative and the baby is A, positive, then
I think we may have to get a cross matching done from the mother's blood as well as for the baby's blood. I think we can choose O negative blood again. O negative blood which has been cross matched with the mother's blood as well as baby's blood.
Yeah. The message is clear there. You can use. The blood, you can choose the baby's blood group cross match against the baby's and the mother's sera. Of course, it is ideal to choose packed cells and suspended in AB plasma. That is going to be a thing, always negative. So I think Dr. Fatehpur, any messages for the audience from your presentation?
When the baby is inside the hospital, always promote breastfeeding. That will, if you promote the breastfeeding, again, the chance of going high levels of bilirubin will be less. And once the baby is discharged, make sure to follow up them. That is more important rather than treating and all. Follow up and preventing the kernicterus and other complications.
So the mantra seems to be 3 things, basically monitoring and ensuring adequate hydration in terms of breastfeeding and ensuring that the baby comes back to us and follow. So Dr. Sendil, messages?
Yeah, it's very clear that for every baby, risk factors for sepsis or risk factors for hypoglycemia, for every baby, we must able to put at the risk factors for jaundice. What are the risk factors is there for the jaundice, and make sure that pre-discharge bilirubin should be taken before the discharge, early discharge, so that readmission rate or chances for an kernicterus will be low. So the 2 things, risk factors should be assessed, and pre-discharge bilirubin should be mandate for every baby before discharge.
And Dr. Kirti?
AFM again, once again, don't interrupt breastfeed to sustain phototherapy, but interrupt phototherapy to sustain breastfeeding.
Super. Good. Yeah, I think that is a message well taken. And final comments by Dr. Jagdish.
I think we need to create a yellow alert. That's a yellow alert among our obstetric colleagues and our junior colleagues, and say no to bind.
Just adding to that, Giridhar.
Yes, sir.
We are aiming for single-digit NMR by 2030. That is, take a decision and stick on to that. So also no bind by 2030, if not by 2025.
Definitely, sir. Definitely. Well taken point. I think most of the valuable comments given by our panelists, they are something that we need to enforce in our institutions so that the sustainable development goal, that is NMR single digit by 2030 comes to fruition. So I think we conclude this panel. I would like to hand over to the moderator for final comments. Dr. Ravi, sir.
Excellent deliberations, and I think we have covered all the pertinent points related to neonatal hyperbilirubinemia. One simple question: what is there any role for exposure to sunlight?
Yes, sir. Any of the panelists want to take up this question? Role for exposure to sunlight?
exposure to sunlight also, there are many studies. I think in African countries, they have done canopy like tent like thing to expose the child to decrease the bilirubin also. But the problem is once you expose the child to sunlight, after they come up for follow-up or anything, it's very difficult to assess the level of the bilirubin by visual methods. We have to depend on the either the blood levels and all. So, and also exposure to sunlight, there is always chance of temperature instability. Either they will be going for hypothermia and hyperthermia. Both are quite possible.
I think just adding to what Dr. Fatehpur said, that's how the phototherapy was discovered.
This one,
One of the
yes,
staff
exactly.
nurse noted that babies who were in the wards where there was sunlight, they had less often jaundice than those who are on the darker side of the room. That's how the phototherapy was discovered. But that should not be extrapolated. That sunlight is should be encouraged in clinical practice for as a treatment. You should be convincing parents when it is physiological, it is physiological. It doesn't need any treatment, any intervention. Unclothing a newborn and holding it in sunlight, you invite both the problems of hyperthermia and hypothermia, depending on what season you are talking about. Only when it needs treatment, there is need to assess and then admit and treat. Because the people have burned their fingers by advocating this in clinical practice.
Definitely, sir. I think this point, has to be emphasized that sunlight, even though it has been good and it has been something that is advocated by our forefathers also, and which has been the basis how phototherapy was actually invented. But still, I think we know that the spectrum is quite broad, and depending upon where you are, depending upon the cloud cover, the time of day, the latitude, everything, what spectrum reaches the baby is very erratic. So, and this has been proven only in, it has been proven to work if the babies are under a canopy which filters out all the bad UVs and all. And in African countries with mass phototherapy at very low bilirubin levels of 8 to 10, I think now need for phototherapy at these levels is itself being questioned. So I think if your bilirubin is still concerned about sunlight, I think it's nothing wrong in exposing them. Of course, you have to take care of, ensure that the temperature stability is there. Otherwise, you can ask them to actually reflected light which comes through the our windows and all. You can ask them to get exposed to that light. That will also be helpful. Yeah. Okay. Anyway, I think we are.
Dr.
Yes, sir.
Point. We had analyzed like basically those who came with like high bilirubin values. So
yes, sir.
we want to ask like, them like basically why was this delay?
Okay.
Even after appreciating that the baby is jaundice, it is not that they haven't appreciated the jaundice. They didn't appreciate jaundice, but they were aware of this basically the heliotherapy or the sunlight therapy. So this is something like a false reassuring thing. So definitely, in spite of like basically knowing that the baby is icteric, it needs intervention, they may delay the like basically the intervention or coming to the hospital for the checkups. So apart from the like the side effects and other things like the UV and the temperature and other things like this is a very false reassuring thing. Like basically, if at all like they're not at all knowledgeable, basically they come at a later stage with high bilirubin rate where they land up in like exchange transfusion or even with bind. Thank you.
Yes, yeah, that is well taken point, sir. I think if there are no further comments from the chairperson, we can conclude this panel, sir. I thank everyone for having given this opportunity. The wonderful session. Thank all the panelists for giving their views in this panel discussion. And have a very great day. Thank you.
Yeah, thank you. Thank you very much.
Thank you, sir. Thank you, sir.
I thank all the panelists, chairperson, as well as the moderator for this wonderful session. We shall now move on to the next panel discussion.
The littlest feet makes the biggest footprint on our heart. Good afternoon, everyone. I would like to take this opportunity to move to our next panel discussion, which is on charts in neonatology. I would also request our esteemed chairperson, Dr. Anand, to introduce our moderator. Over to you, sir.
I welcome Dr. Manisha Bhandarkar. Panelists, Dr. Srinivas BH, Dr. Shashidhar, Dr. Priyadarshini, and Dr. Ashwin.
Yeah, a very good afternoon to everyone.
Good afternoon, ma'am.
Can we start?
Yes, we'll start, ma'am.
Okay, thank you very much. And at the outset, let me thank the organizers for giving this opportunity for this today's panel discussion. It is the hybrid form is something which is new for all of us, and I hope we are able to do justice to this topic in the given time period. So with me, I would like to introduce the panelists who are here for this particular topic. A little different topic that we are going to talk about, very practical, which we all see in our NICUs in and out. We have Dr. Shashidhar. We all know him, very active, dynamic neonatologist. From St. John's Medical College. Welcome, Dr. Shashidhar. I could see you there. Thank you. We have Dr. Priyadarshini Kulkarni, another young dynamic neonatologist from my own city, Belgaum. And she's in Venugram Hospital in Belgaum. She has done her fellowship in perinatal medicine from Dr. Bidri's hospital in Vijaypura. We have here Dr. Srinivas BH, sir. Thank you, sir. He is a consultant neonatologist and pediatrician from Mysore. And we have another young neonatologist, budding neonatologist, Dr. Ashwini Bidri Aniket from Ashraya Hospital, Chikmagaluru. So thank you everyone for being there. And I'm the only person who is virtual here. And I'm sure we will together make this happen. So when I was thinking about the charts in the NICU, this particular topic, we have to think about why do we need charts in the NICU? What is the importance of these charts? So with those of us who are in the medical college and those of us who are practicing a neonatologist, we have realized that the charts are important both for medical education as well as for patient care. When it comes to teaching, the charts enable the students to take, and as well as the caretakers, to see visually what is laid out in front of them in a very organized way, and thus helps them to understand the topic and how they need to go about it, so they can process the content and make the connections more easily when they look at the chart. Similarly, for us in the practical areas, for patient care, we need charts for monitoring. There was a very good discussion about charts to be used in jaundice. Charts for approach to diagnosis, how to go about with the investigations, charts which can be used for treatment, charts to display the statistics of the unit. And there are a lot of, if there are some QI projects going on in some change in methodology which is being followed in the particular unit, we will need the charts for that to be displayed for that as well. So every chart in the NICU has a purpose. And the purpose, I thought when I was thinking about it, would be to have a uniformity in care of patient care, to ensure that there is a standard of care. So even if there is change of postgraduates, change of healthcare personnel, the same standard of care for that particular unit is maintained, and thus we maintain the quality of care. So this is what would be the role of charts in patient care, and especially in the NICU. So the different types of charts which could be there in the NICU would be right from emergency charts to the routine care charts, those which we use for treatment, so that is for documentation as well, approach to any management of challenging cases, for growth monitoring, and discharge planning and follow-up. We don't have much time to go in detail about each of these charts, but I would request the panelists to comment about how some most important of these charts play their role in ensuring that we serve the purpose of maintaining the uniformity and standard of care in the unit. So to start with, I would like to ask Dr. Shashidhar, what sort of charts would you want in the NICU or in the delivery room or in the emergency area for emergency management in the NICU?
Thank you, ma'am. Before I think I go into chart, the most important chart that I think we need now is a glucose monitoring chart. I think most of us will be having low glucose levels in the audience, so which you may not be able to see from there. So we are holding them from lunch.
Oh,
That's
yes.
why. So coming back, I think all of the hospitals which you are trained in will have some chart like this. I think should, especially when you have a separate pediatric emergency room, when or pediatric casualty or an adult casualty where you need to receive a newborn patient. This is the chart which we use in St. John's in the emergency room, where a newborn baby comes in and a pediatric resident or a pediatric postgraduate or even an adult medicine person is there. He has no clue what to see in a newborn. So we have laid out a little bit. So name, age, all that is self-explanatory. For a newborn baby, we need to know one previous slide, ma'am.
Yeah.
We need to know definitely his birth weight, current weight. So because we need to know what is the percentage of dehydration. We also need to know definitely his gestational age. Second, presenting complaints, if any, MLC, yes, no, that will come in. Vital chart, we have to make it as simple as possible. So everything was included in one table, that heart rate, respiratory rate, saturation, CFT, etc. Even general physical examination, we want it to be simple but complete. So we need consciousness, color, jaundice. So it has to be like a simple chart, but which will be used. We don't want to leave blank pages and everybody writes whatever they want. Like ma'am mentioned, there has to be some standard of care. So everybody, once he sees this chart, he has to fill this. So, and each column has to be filled. A systemic examination takes about half a page or quarter a page. Next slide, ma'am. So, and then we need to assess based on this. Either you can use TABC, which, or you can use the pediatric assessment triangle, which is in PALS. So airway, breathing, circulation, which will tell you how to triage this baby. Secondly, once you make that, we don't need a perfect diagnosis when any baby comes into an emergency. We need to know whether it's stable or whether it's unstable. In unstable, whether there is respiratory compromise, circulatory, cardiovascular, or neurological. So you need to know only basic elements of this diagnosis. We don't need a pinpoint diagnosis. So in respiratory, we need to know what the resident or the doctor thinks in that way. Is it lower airway, upper airway, parenchymal, etc. In cardiac, does he think it's a cardiac shock? And simultaneously think about management. So when a resident circles respiratory distress, then he'll immediately see his options are O2, HFNC, CPAP, or intubation. So his mind will definitely go there. When he has 3-4 patients coming in, it will be easy for him to think like that. When he thinks of circulatory compromise, he will see that next is fluids, inotropes, antibiotics. And we need to maintain this golden hour. Whenever the patient comes in, the first hour is most important. So we have made a column for time. Cardiovascular, does he need CPR? So if he has already done it, we don't want to write and then do CPR, but obviously it has to be there. Working diagnosis, little plan of advice, what has been done in the ER as form of a table. So suppose 3-4 people are giving drugs. One is giving anticonvulsant, one is giving bolus, one is giving inotropes. Everything will come in one table. So what dose has been given is understood. When the patient comes to NICU later on, what dose, what route, who has administered it, and what time. So that if you want to retrospectively audit that this management in ER was okay or was fine or very good, you may need to compliment them if it is complete. Finally, investigation. Sometimes child will remain in ER for half an hour or 1 hour till the bed in NICU is there. So in between, if they have done an ABG, X-ray, and we have, even in X-ray, we have made a provision for just a picture so that wherever they see opacity or something, they can just mark it over there. This is the monitoring chart, which is similar. Heart rate, temperature, pulses, CFT. If the baby is there for a long time, they need to use it. Downey score is what we use. We don't use Silverman-Anderson score so much. So, and we don't expect them to remember at that time. So they just have to circle whatever they see. And finally, the calculated Downey score will be there. More than 6, they need to go for intubation. So just to show you some of the filled charts, this is how it is filled. It doesn't need more than 5 minutes time to fill the entire chart. So just they need to circle it, write some values like sugar values, etc. And if you, for a pictorial representation, you can use a Silverman-Anderson score or a Downey score for RDS scoring.
this is the chart filled for emergency room monitoring. So suppose 3 p.m., 4 p.m., 5 p.m., what was the heart rate? What was the BP? This was one of the filled ones with treatment, whatever they have given, dose of 10% dextrose, who was given, when is given, and their signatures. So that was about emergency room. The second aspect of emergency management is at delivery room. And most hospitals have this, a delivery room chart where you have a place for mother stickers. That mother sticker by mean mother's demographic details. What is her name? What is her hospital number? If it is a baby born to you, then we shouldn't be able to confuse if there are two mothers with the same name. So her number, her name will be there. Suppose if it has come from anybody referred by whom, so that anybody who sees this chart next time knows to get back to the referral doctor. Time of birth, date, everything is self-explanatory. Birth weight, gestation, most of you will have it. Previous obstetric history in the form of a table. Mother's education also is there. Current pregnancy, if there is any obstetric complication. So they just have to write or tick the medical and obstetric complications that you see in the second page. They just have to circle it. We have made a separate column for ultrasounds and Dopplers. If there is anything special, they will enter it there. Intrapartum problems also, most of them are listed and they have to just circle it. Delayed cord clamping, skin to skin contact are something which we try to enforce. So this has been included in our delivery room sheet. Also is Apgar score. Suppose even if you don't know what is Apgar score, by just looking at that, you can give an Apgar score 1, 5 and 10 minutes if required. And what are the details of resuscitation? Have you given CPAP? Have you given bag and mask? Have you given intubation, chest compression? Everything can be written there, and what time. New Ballard score for gestational age assessment. And finally, there was diagnosis. This algorithm, all of you know, and you can use that in your labor room as well.
Yeah, so thank you, Dr. Shashidhar, for that. I just added this algorithm because this is a very common chart which is displayed in all the delivery rooms. So which is important for the, helpful for the residents as well when they are going through the resuscitation. So thank you for that. So these are the at least the basic charts which we need regarding the emergency care and the triaging of the newborn. Once that is done and once the baby comes to for the management in the NICU, the first and foremost, of course, and this is one of the things, the to documentation of the treatment chart also, which is required. We will come to that later on. So other emergencies which could be there for which the charting may be needed is neonatal seizures, neonatal shock. So every unit may have there some way of putting it for the residents or for the people who are providing the support, and they can have the charts for them for as a ready reckoner for them to decide how they should go ahead with the emergencies. So that is about the emergency care. Once the baby comes to the NICU, the first and foremost, whenever the baby comes, we are worried about the temperature maintenance. So, Dr. Srinivas, can you please tell us how are we going to do the temperature monitoring and intervention, and how charts are going to help us in doing this?
Thank you, ma'am, for the opportunity. Coming to temperature monitoring, which is most important for the well-being of the neonate, we usually do the auxiliary temperature and for temperature. If the temperature is between 36.5 to 37.5, it's normothermia, which doesn't require any monitoring, any interventions. So we can check the temperature every 4 hours in a day, unless there are any medical indications. So if the temperature is less than 36.5, we can consider hypothermia and probable sepsis. So in this intervention, we can relocate the bed away from the heat loss, and we can provide additional air if close observation is not required. And also we can ensure blankets, clothing which are pre-warmed, and also recheck the temperature every hour in a 24 hours and until 2 consecutive temperature readings are normothermic. And also notify the medical team if environmental causes are excluded or patient looks unwell. If the temperature is between 37.6 to 37.9, we can call it as a low-grade fever. Interventions needed are we can assess the environmental factors responsible for this and observe for clinical signs of infection and or sepsis and consider removing layer of clothing if it's overdressed and decrease the isolate temperature by 0.5 degrees centigrade early if it's really applicable and recheck the temperature every hour for 24 hours until 2 consecutive temperature of less than 37.6 are achieved. And if the temperature is more than 38 degrees centigrade, we can consider it as fever and sepsis is a possibility. And for this, notify the medical team about the possibility of sepsis and assess the environmental factor and observe for clinical signs of infection or sepsis and screen for full septic skin. And if under this, the special considerations for hypothermic or around hypothalamic dysfunction and any recent immunizations and probable equipment failure also we need to be think of. So this temperature, this monitoring chart is one of the essential chart to be kept in NICU.
Absolutely. Thank you very much, sir. So anybody who looks at this chart would have some idea of how they should go about depending upon whatever the temperature of the baby. And if the baby is hypothermic, then we have nothing, the best solution we have is about kangaroo mother care. So Srinivas sir, would you please tell us about what sort of KMC charts would you like to display for the benefit of everybody?
These benefits, KMC benefits, we can put in leisurely languages in front of the NICU so that the patient attenders can read. So we can put the 3 charts: benefit for the baby, benefits for the family, and benefits for the nation. Coming to benefits for the baby, it provides warmth for 24 hours a day. 24 hours a day, to say the KMC is the best incubator. It provides multimodal stimulation. It causes reduced infection and it increases alertness and the baby can quite sleep well. It provides better IQ and provides earlier growth spurt. There will be chances of decreased apnea, decreased oxygen requirement will be there, and also it will provide a physiological stability. Coming to benefits for the family, it saves money. Chance of early discharge is a possibility. Father can return to work earlier with the better follow-up with KMC and again the better IQ, decreased child abuse and abandonment, and breastfeeding success rate will be more with KMC. And overall, it provides a healthy baby. Coming to benefits for the nation, it causes decreased neonatal and infant mortality. It's cost effective, more intelligent babies for the nation health, simple and applicable everywhere. So these charts, I think we can put in front of the NSU for the benefits of the family.
Yeah, so basically they will be motivational for the parents as well as the staff to ensure that the KMC is
where the father is also providing KMC, where more and more families involved, showing that they can also give.
Yeah. Thank you very much, sir. So that is about the temperature monitoring and the interventions that need to be done in case of hypo or hyperthermia. Now, once a baby is in the NICU, if it's a sick baby, we need to look at how we are going to prepare the fluids and the feeding of the baby as well. So once it comes to preparation of the fluids, especially the new entrants in the NICU, the nurses, everybody needs guidelines, protocols, and charts how they are going to go ahead with the fluid preparation. So can I ask Dr. Ashwini, what sort of charts would you like to put up in the NICU with regards to fluid preparation?
Thank you, ma'am. I think fluid preparation is a very important thing in NICU because in newborns, we know that we calculate the fluids in a very meticulous way. So fluid preparation charts are important to mainly minimize the fluid overload and also fluid deficit. To have uniformity in preparation of fluids, not just the nurses, but the new entered PGs need to know as to how much ml of fluid, how much what goes into the fluid is very important, and it's better to have a fixed protocol in a unit so the errors in making the fluids is reduced. So there are so many charts in fluids which we can have and which reduces the difficulty for many of them. So one could be the calorie for the term and preterm as to how much calories are required, how much protein maximum and minimum you can give. the fat, calcium, phosphorus, iron, vitamin A, D, E. All of these are very important things to be given, but what is the minimum and maximum is very important. So based on that, we can calculate. The other thing which we can do is what each fluid has. Most of us are asked these questions during our PG time as to how much an isolate P contains, how much dextrose is there, how much sodium, potassium, calcium, each of these fluids have. So that becomes very important when you're calculating the fluids and you want to minus or add a particular electrolyte. So you need to know what is the basic content of a fluid to add on or reduce the sodium, potassium or calcium you're giving in for the baby. Next, the other charts you can have is quickly, like we always want to know the percentage dextrose or we want to know the GIR. So the color chart is, I'm not sure if you can see it well. It tells you the percentage of dextrose and how much GIR each ml per kg, like 10 ml per kg, 20 up to 150, 180 ml per kg of a certain percentage of dextrose, how much GIR is we are giving. So that's very, very important when we want to tell about the GIR and how to, keep the glucose, I mean, the euglycemia in the babies, and also to increase and reduce the calories. The other chart is the basic chart which we all use, that is per the day of life and how much fluid we give. That is for preterm and term babies, or babies who are 1 to 1.5 and more than 1.5 kgs. Like for example, for a preterm less than 1.5 kg, you want to start with 80 and then go up to 100. And on day 5, you can go up to 150 ml per kg per day. So these are the charts in fluids which help us minimize the definitely minimize the errors.
Yeah, thank you very much, Ashwini, for that. So IV fluid preparation is most important. And once the IV fluids are taken care of, then we decide about feeding these small and sick newborns. So some of these charts, if they are put up in the NICU, they will be also a good guideline for the PGs at what, I mean, these are very common charts which we all are aware about, but how to assess and what action to be taken. This will be again guiding them how to increase the feeds, when to initiate breastfeeding, when to start with the spoon feeding, when to, and then from spoon feeding how to go over to the breastfeeding. So these are sort of ready reckoner charts, easy to be followed, good guidelines for the nurses as well as the residents who will be working in the NICU.
The other chart I did not put up in the fluid chart is also important, where you can tell as to how much ml per kg we have been advised to give, how much is the fluid going on, how much is the feed going on, how much fluid is going on with the IV antibiotics, so that if you're saying 150 ml per kg, all this has to be calculated within the 150 ml per kg. So we can have charts of that also in our NICU. And of course, the input-output chart, which tells you about your RT aspirates, which tells you about the amount of fluid lost in the urine and how much total input you're giving. These are the other two charts you can have in your NICU, mainly to take care of the input-output. Thank you, ma'am.
Yeah, thank you, Ashwini. Once these babies are being taken care in the NICU, we have taken care of their IV fluids, we have initiated feeds, and then we come across more other issues. One of the commonest issue which we come across is neonatal jaundice. We did have a elaborate discussion, panel discussion just before this session, but here, can I ask our panelists to tell us about how do we go ahead with the neonatal jaundice and how do we monitor it and what are the charts to be used?
Hello, ma'am. Thank you.
Yeah, thanks, Priya. Yeah, please go ahead. Yeah.
We just now had a very elaborate discussion on jaundice, so I'll just quickly brush through in 2 minutes. This particular chart which I'm referring to right now is called Bhutanese chart. This is used mainly for discharge planning. As you can see, we have 3 zones: the high risk zone, the intermediate risk zone, and the low risk zone. In intermediate risk zone, it is subdivided into high intermediate and low intermediate. If the bilirubin of the baby, which is plotted against the hour specific normogram, falls in the low risk zone,
which means the baby can be safely discharged and followed up after 3 to 5 days. However, if the baby is in the low intermediate risk zone, then it would be prudent to call the baby back at least after 48 hours for clinical assessment and if required to do the serum bilirubin levels. However, if the baby is in high intermediate risk or high risk zone, which I believe the baby would have already been under phototherapy, should be monitored closely. Can we go to the next? This is again one of the most commonly referred to chart in the NICU. This tells us about the guidelines for phototherapy. As you can see on the x-axis, we have hours and days of life, and on the y-axis it is serum bilirubin. The topmost dotted line represents babies who are born at term with no risk factors. The middle line represents babies who are born at 35 or more, or who are born at 37 or more with risk factors. And the lowermost lines is babies who are born more than 35 weeks with risk factors. The risk factors being J6PD deficiency, isoimmunization, lethargy, sepsis, asphyxia, hypoalbuminemia. So in this case scenario, when we plot the bilirubin levels against the hour specific nomograms, it guides us whether we should initiate phototherapy right away or we could wait. Can we go to the next slide now? Next.
Yeah, this is the one for exchange transfusion.
It's a similar one that we saw. This is for exchange transfusion. Here again, we have 3 lines representing the same things, but only thing what the difference here is when we plot the serum bilirubin on the graph, we can wait for 5+, meaning if the jaundice level is 15, we can see we can wait up to 20 to do the exchange if there are no signs of bind. However, if there are even a single sign of bilirubin induced neuronal damage, then exchange transfusion should be carried away right away.
Yeah, thank you, Dr. Priya, for explaining these charts, and these are a must in the NICU, which are going to ensure the uniformity of care and standard of care with regards to babies with neonatal jaundice. Another very important aspect, which has already been covered earlier by Dr. Srinivas, is regarding kangaroo mother care. Dr. Priya, can you just tell us how should we have this KMC monitoring chart in the NICU? How does it help in maintaining good standard of care?
KMC monitoring chart is important for 2 reasons. One is to calculate the number of KMC hours, and the second one, it acts as a self-assessment for the mother. Meaning, if mother has done KMC for 2 hours today, tomorrow she'll be motivated to do it for 4 hours, and day after tomorrow 6, and subsequently to increase the number of KMC hours, and also to bring about the uniformity in the care. Here, as you can see, initially the KMC was only for the babies who were stable, but in the recent few years what we are seeing is those babies who are on CPAP or on even invasive ventilator can be given KMC, and this definitely helps in multiple things like bringing down the vitals back to the normality, helps in better weight gain, helps mother for better bonding between the mother and the baby. As you can see in the chart, name of the baby, of course, then any neonatal complications if the baby has had, what is the birth weight, when was KMC initiated, and by whom. It can be mother, father, or caregiver, but it would be preferable to just have 2 people giving KMC to the baby. And then we have weight, which is one of the most important motivating factor for the baby. Even that 10 to 20 grams of weight gain per day itself is such a motivating factor that she would want to continue KMC or even increase the number of KMC. And then we have in this chart, the feeds. Is the baby on RT feeds? Is the baby on fluids, or is it on Pallida or direct breastfeeds? Any IV medications? And then the number of hours. And of course, the most important is temperature. Temperature definitely will be better controlled while the baby is on KMC than even when the baby is under the radiant warmer. So it's very important to maintain this chart mainly for motivation of the mothers and for uniformity of the care in the NICU.
Thank you very much, Dr. Priya. So these are some of the must charts which we have while the baby is improving in the NICU. And once the baby gets settled down, once the baby starts improving, the next very important parameter which comes is the growth monitoring. So Dr. Ashwini, can you please tell us which are the important charts we need for growth monitoring in the NICU?
Yes, ma'am. Thank you. So growth monitoring becomes very important in NICU because of extreme prematures, low birth weights, or extreme low birth weights when we handle. And it's very important as to, because the weight increases almost 6-fold between 22 to 40 weeks. So if we don't do it in a right way, the children end up in having extrauterine growth retardation. So it also helps in early intervention. So as to how you weekly, when you chart, you know what to do and how to increase the calories and nutrition in the baby. So there are different growth charts which we have. The Fenton's growth chart, which we use between 22 to 50 weeks, and then Olson's growth charts, which we use between 23 to 41 weeks. Then there are WHO growth charts, which we use more than 40 weeks of gestation. IAP growth charts, again, which we use more than 40 weeks of gestation. And there are international postnatal growth charts for preterm by Oxford University, which are used again for 27 to 64 weeks. So these, how often do we chart? Usually the weight once in 3 days, or at least once in 7 days, and then length and head circumference weekly. So we know how the baby is growing, and when there is a dip and anything less than 10 centile or a 50th centile, we know what is to be done, so that we definitely can avoid EUGR. So I think keeping growth charts, and in spite of doing everything, when we don't monitor the growth, we don't know how the baby is doing well, because this is very important for the neurodevelopmental outcome as well.
Yeah.
So this is the Fenton's growth chart which I've put up, and this is the Oslin's growth chart which I've put up. So this tells you there are like 5th centile, then there's a 50th, and then the maximum being the 97th, 50th, and then the 90th and 97th centile. So ideally anything less than 50th should start alarming you, so that you can do corrective measures appropriately, so you prevent EUGR in these babies.
Yeah, thank you, Dr. Ashwini. There is lots more that we can talk about the growth charts, but it is basically just to prime all of us what sort of charts should be there necessarily to ensure that we monitor our neonates who are being taken care of the NICU. Besides this, the care of the newborn, there are certain other important charts which are necessary for all of us to remind, not just us, but for the nurses as well. One is the infection control and housekeeping charts. So we all have these charts in our NICU, but it's important that they are displayed properly, and then we keep looking at them to remind us that yes, we have to do hand washing, we have to have our 5 moments of hand hygiene. These are the housekeeping practices in the NICU. They are to be displayed so that the nurses can ensure that this changes, housekeeping routines are followed. They have to maintain charts that it has been done for every shift. If there is to be cleaning going on, or whichever equipment which has been used, it has been cleaned and kept back. So all those charts need to be maintained to ensure that the proper housekeeping practices are followed in the NICU. And after doing all this, once the baby is ready to get discharged, then I mean, I have just put here 2 important charts, but probably there are some of the units will have many more sort of a checklist to ensure that the discharge planning has been completed. So one is this, our ROP chart, which is maintained in the NICU to ensure that every time the ROP is done, it is entered and the record is maintained, so that the next time when the baby comes, we can look at it and see how it has progressed. The follow-up schedule, especially for low birth weight babies, how often they should be seen, when they should be seen, when they are supposed to be given follow-up for the high-risk baby clinic. So these sort of charts also need to be displayed in the NICU so that everybody is aware about it. Another important thing is not just have the charts and put them in big folders and keep them in the NICU to be shown when inspection comes, but they have to be displayed properly. For example, the hand washing chart should be displayed where the hand washing area is. And secondly, they should be displayed at the eye level. For example, over here in the labor room, if the NRP chart is displayed way above where the residents or the person who is taking care of the baby cannot see what is supposed to be the next line of action, then then they are of no use. So basically the placement of the charts where they are to be maintained is also important. But even before that, I would, before we come to the end of this session, what I would just like to say is that the charts are there as guidelines. Charts don't replace examination. They don't replace clinical acumen. They help us to take the next decision, especially when we have to follow a proper protocol. But it is also important the charts need to be updated. Sometimes we make the charts and we forget about it. And maybe sometimes for 5 years, 10 years, they're just there in the NICU. So it is important that we regularly keep updating our charts, and we ensure that whatever care we provide is proper evidence-based medical care for our babies. With that, we come to the end of our this panel discussion. I hope we have done justice to this particular topic of charts in the NICU in the given time. Thank you, organizers, for giving us the opportunity. I thank you all the panelists for having been there. And I'm sorry I'm not there physically. This is the first time that we have had a hybrid panel discussion, but thanks very much for your cooperation.
Thank you.
I would request everyone to come back by 2:30 after lunch. Thank you.
Okay. Do you want to come? I think I can hear it. I've unmuted. I think now you can.
To the mic.
No, no, it's okay.
Just like that. Good afternoon, everybody. Looks like there is a slight delay only because the earlier panel got over quite late, so they've all gone for lunch. So we're just waiting for another 5-10 minutes to start the sessions.
Okay, thanks for that.
Yeah, me too. I don't think they responded. Is there a way to communicate? Can you text them personally? Text Dr. Sujna and Dr. Sidhu and Dr. Ismail that we start soon. 10 minutes and we're waiting for the participants to come. Okay.
No, we got you. We got you.
One that you sent just now. That's the only one.
I'm asking people to just talk in front.
So there were a lot of people actually, but I think we just left for lunch. The other PPT is not necessary. So South Neocon panel, cooling panel.
That was for the workshop, I think.
Workshop.
Yesterday was a workshop.
Hello.
कैसा करना है?
Dr. Nanda Kumar entered the meeting.
Who's going to admit?
क्या होगा?
See, we have another team for the technical sector. Okay. I think they've also want to have lunch.
Speaker. Ravi sir.
Hi guys, sorry, I'm here.
Oh, great. I think Pratap sir wanted to discuss something, sir. He can do it now.
ಇವಾಗಲ
ಅದೇ ಏನೋ ಪ್ಯಾನಲ್ ರನ್ ಮಾಡ್ತೀನಿ ಅಂತ ಇದ್ರು.
We will go like that.
ಅದೇ ಸ್ಪಾಂಟೇನಿಯಸ್ ಆಗಿದ್ರೆ ಚೆನ್ನಾಗಿರುತ್ತಲ್ವ ಸರ್?
Leave it.
ಸರ್ ಊಟ ಆಯ್ತಾ?
ಆಯ್ತು, ನಿಂದು?
ಇಲ್ಲ ಸರ್, ಇನ್ನು ಕಾಲೇಜಲ್ಲಿ ಇದೆ. ಐ ಥಿಂಕ್ ಪ್ರತಾಪ್ ಸರ್ ಚೆನ್ನಾಗಿ ಊಟ ಹೊಡೆದು ನಿದ್ದೆ ಹೊಡಿತಾನೆ. Is a good okay.
Good evening, good afternoon to one and all present here. Today's topic is going to be therapeutic hypothermia and EEG, which is going to be moderated by Dr. Pratap Chandra. I would request our HOD and the chairperson, Dr. Premalata ma'am, who does not require any introduction in the world of pediatrics, to speak, to introduce the moderator. Thank you.
Thank you. Yeah, neonatal hypothermia, very controversial subject after the Helix trial. This topic is going to be discussed by Dr. Pratap Chandra, who is a neonatologist trained in UK and expert in neonatal cooling, neonatal transport, air ambulance services, and he is working in Indiranagar Motherhood Hospital. He is the director of New Bliss Health Services Private Limited, lead of Neonatal Cooling and Transport Committee Karnataka, lead neonatal and pediatric ambulance services, and his area of interest are, as expected, hypothermia, transport, extreme preterm babies, cardiology, research, and training. Welcome, Dr. Pratap Chandra.
Thank you so much for the kind introduction, ma'am.
And should we request the chairpersons to come over, and then Dr. Ranjan is going to be virtual, I think. Okay. He's already there. Okay. So, sir, Dr. Ranjan, sir, with your permission, we're going to start this panel discussion.
Yeah, go ahead, Pratap. Can you hear me?
Yes, sir, we can hear you.
Okay, thank you.
Right. We have an eminent panelist here, a group consisting of Dr. Suja Mariam. She is going to be joining us virtually, and she's already there. Dr. Sidhu Cherki, he's working in the BM Patil Medical College in Bijapur. Nicely, he's put this topic onto me on the last day and then said, you got to do the moderation. So we'll see how it goes about. Dr. Ravi Swami, I don't think he's joined. Can somebody call Ravi Swami, please, and ask him to join? So Ravi Swami, he's a consultant at Manipal Hospital, Bangalore. He happened to be one of the investigators for the Helix trial as well. So that's why it's important if he joins as well. And again, no need to introduce more. Dr. Prakash, he is from SRMC Medical College, Chennai. You can come over this. So there are going to be 2 or 3 panelists who's going to be talking virtually, and sir is sitting here. So do you want anybody for company? Anybody volunteering to be panelist, please come over here. Come on. Right. So this is, as ma'am suggested in the introduction, it is one of the most controversial topics. It has become mainly because of a multi-center trial results, the Helix trial, which came out recently, and then very strongly worded, and the strong recommendations that cooling cannot be done in the low middle income countries, not just India, it goes to Bangladesh, Sri Lanka, Pakistan, or any of the African countries. So these are some of the strongest recommendations. So what it means is it puts us in a spot. It puts us in a spot where whether to cool or not to cool on the suitable babies. So as I understand, Dr. Ranjan sir, along with other eminent people in IAP and NNF, they're having a concerted effort to come out with some position statement on what to do so that we are all medico-legally protected as well. Also, why deny one of the best therapies that I thought well studied recently in the recent decades after the steroids to be just completely dismissed from the country like India. And considering the fact that we have almost, the incidence of HIE or birth asphyxia is extremely high in countries like India. So without further wasting time, I would like to bring in, Sidhu first, okay? None of the panelists know what the questions are going to be. They're all randomly put across. So they have to talk about it based on their own personal experiences. And please keep it to, very short and succinct because we have only about 30 minutes time, right? So what are the practical difficulties, Sidhu, when there is a baby referral call for a baby who's born with a delayed cry, right? Here, just for the audience, I'm just going to go through a baby who's born and it's having birth asphyxia, its difficulties in referral, and then it's intensive care. So I will go through a journey of this baby, right? So Sidhu, can you take this first one, please?
Yes, sir. Yes, sir. Am I audible, sir?
Yes, you are.
Yeah, thank you for accepting to moderate the session at the last moment. Coming back to the question, sir, there are a lot of practical difficulties what we face in a day-to-day practice when there is a referral call for a baby with delayed cry. Usually, we do transport around 60 kilometers to 100 kilometers around Vijaypura. We get a call as so when the baby doesn't cry after 1 or 2 hours, where they have kept in the baby in NICU, and they would have put on the warmer and they have just put on a hood oxygen and they are waiting for the doctor to come and receive the child. This is the first instance what we come across in most of the PHCs and CHCs and district hospitals as well. Coming to the from a referral nursing homes as such, they just intubate the child by anesthetist, and we just get a call that baby has not cried, we have intubated, kindly come and pick the child. These are the 2 scenarios which we face day to day, sir, right now.
Thank you so much, Sidhu. And we all know that the resuscitation people are not just going to be pediatrician or neonatologist. It could be just a nurse, or it could be an obstetrician, or even the anesthetist. So therefore, it's very important for us to understand what goes behind that. And Dr. Uma, you would like to comment on the rest of the things?
Not knowing sentinel events, it is very true. So it depends on how well the obstetric unit is. If it is, it's a unit where a pediatrician is going for delivery call, yes, we will get some information. And also, like, I'm not sure how many will have CTG monitoring, how many will have late referrals, how many will have like babies who had lost the fetal movements for 2-3 days and then landing up as an emergency. So definitely not knowing sentinel events is a huge thing. And gestational age, I think in our setup, if you ask, I think majority of the time they get dating scan done. And so we would know the gestation age, present condition and ABGA score. As I said, if the pediatrician is there on call, we would be knowing the rest of the things.
Okay. Thank you. Just moving along. And, I don't know whether Dr. Ravi Swami is here.
Sir is there, sir.
Sir is there? Huh?
Yeah.
I can't see him.
Ravi.
Ravi, please welcome. You're actually not seen. So can you please put on your video as well? It's for the benefit of the audience. Right. Dr. Ravi Swami is happened to be one of the investigators for the Helix trial. So who better than him to kind of answer these questions based on the Helix trial? So Ravi, could you highlight some of the practical difficulties that you had in clinically assessing these sort of babies with HIE, especially in understanding whether to go ahead with cooling or not, or to bring those babies into your trial or not? There's pin drop silence. Ravi, are you there? He's not there. All right.
I think he's
paused. You want to take this question?
Yeah, I'm not sure about the Helix. You want to talk about the Helix trial? Yeah.
Not the trial.
Guys, you can hear me? Pratap, you can hear me?
We can hear you.
Yeah, okay. So what we had was, we had a clear-cut criteria in terms of which babies who are eligible. So a population, predominantly the birth weight above 1.8 kg, and we had the ABGA scores, because not everyone would do the blood gases. So that was one which we didn't have. But in terms of assessment, then we had a structured neurological examination, which was completely scored. All the people were trained how to do the scoring. And based on the scoring, all the mild cases were excluded and the moderate and the severe were included. So that's how the babies were enrolled for the study.
So thank you very much. And obviously you highlighted some of the difficulties that you had to face in getting these babies on. And I will come back to the Helix trial in a bit.
Sure. Yeah.
Moving on, Dr. Prakash, would you like to take this? What do you think would be the challenges faced by the pediatricians to refer the babies to the tertiary center, especially if they're not players who does active cooling in their own hospitals?
I think considering cooling benefits. So with that position, we can what the pediatrician to refer to a cooling center. First of all, I think as Dr. Pratap was saying yesterday, we should have the center trained to how they should be cooled, because cooling is not beneficial the later we start, even in the 6 hours, with less than 6 hours, less than 3 hours, and more than 3 hours. Now, also, for them to do a systematic assessment at the referral center needs to be, emphasized, and the right time they should call, and probably starting cooling at the referral center. I would, unless they are trained to do it, I would not be asking them to do. Is that the challenge? Yeah, that is a challenge, important challenge. Correct. Which a referral center would face. So they should have a tie-up. If the center is nearby, early referral, and then they should come pick up, and then or they should be in a position to manage the baby till the unit comes to pick them up.
Absolutely right, because as we see, if you want to give therapeutic hypothermia as a therapy, it is an emergency. So you need to select these babies and start cooling as early as possible. So moving on, I think Dr. Suja would like to take this if it's okay. So parents have now agreed for the transfer and now waiting for the team to arrive. So they have given a call to you. You are one of the, the tertiary centers who do active cooling. So they've called you and then they said this baby might be eligible for cooling. What is your advice to the referral center until your team probably reaches there or they are coming on their own? What is your advice and what are the challenges that you've you potentially face during transport?
Yeah, hi, good afternoon. So when a team lower center is referring to a higher center for therapeutic hypothermia, it is very important that our communication is intact. We have to ensure that the team will be reaching here within 6 hours. We have to ensure that they assure the hemodynamic stability of the baby before transport, because more than the cooling, stabilizing the baby is also very important. So the ventilation, hemodynamic status, blood glucose, securing IV line, starting fluids before transport is very important. Now, during transport, there are many discussions about passive cooling during transport, which the TOBI body is now advising for all during all transport. So we have to ensure that they have regular temperature monitoring during the transport, and there should not be any active warming. It is preferable that the baby's temperature is kept around 34 degrees Celsius, but if it is falling rapidly, the baby should be wrapped with continuous monitoring of the vitals during transport. And consent from the parents before transport is also very essential.
Absolutely. Thank you very much. I think you've highlighted good points there. One of the approach that you can take before or during the transport is called the stable approach, where stable is an acronym for, for the sugars and, temperature and everything. In here, Dr. Suja was mentioning about the temperature. Too low temperature is also very dangerous for these babies. Also hyperthermia is also not good. So if you want to do things, do it in the right way. And then teaching and training is extremely important going forward in dealing with these sort of babies. So moving on, it's not working. I think I've moved forward quite a lot. Right. Possibly Sidhu, you can take this one. The baby is now admitted in your NICU for cooling because you've gone there, you've retrieved the baby, you maintain the hypothermia during your transport as well. And what investigation and procedures would you advise at the time of admission for these babies? Some of the practical points.
Yes, sir. As soon as we receive the baby, we'll place the baby under radiant warmer, which is switched off, where it is a two-member procedure. One trained registrar and a staff nurse will be doing it. The staff nurse will be keeping the cooling machine ready. As soon as the cooling machine is ready with the mattress, we will place the baby under the mattress and switch on the servo controlled cooling machine. What do we have right now? Servo controlled critical machine, and it will be set at a target temperature of 33.5 degrees Celsius. If the baby has come with a passive cooling, it will take hardly 10 or 15 minutes for the baby to reach target temperature of 33.5. We do monitor by using a rectal probe. There will be two probes basically. One is a rectal probe, other one is a surface probe, which is placed either on the forehead or the sternum, sir. Coming to the investigations part, center lines will be secured prior to starting the cooling itself via UVC and UVC. We will be collecting complete blood count, as well as if the baby is ABGs and X-ray will be done. And we do SGOT, SGPT at admission as well. And regarding the admission process, simultaneously the consent for cooling will be taken from the parents, and baby will be shown to attenders once the cooling is initiated in our unit.
Absolutely, that was well narrated, because looks like you practice what you're preaching. So the most important thing here is to have a level 3 NICU as a start. Okay, so at least that should be the recommendation. We are hoping that it will come out through the discussions from the seniors. And very important on the central line, after you start cooling, peripheral lines are very hard to get. And a lot of these babies, Sidhu will agree with me, will have a multi-organ involvement as well.
Yes, sir. Yes, sir.
Yeah, so therefore you might need inotropes. So we strongly discourage people using inotropes in the peripheral line, right? If they may need calcium correction. Similarly, we cannot do calcium peripheral line. So these are the reasons why you have to equip your NICU to a level 3, and then you start this cooling as an adjuvant. Thanks, Sidhu, for that. I need to look at the question, then ask. All right, so Dr. Prakash, it's for you. While undergoing cooling, the baby developed, this baby also had meconium aspiration, and consequence to that developed severe hypoxemia, and ventilator requirement got worse. What would you advise in this condition? Would you start nitric if it is indicated as well?
Okay, let me make it a little precise, but it's like one of the essay questions to answer. Right. So, right. So I think the PPHN management will go on. We would like to continue cooling and take all measures to control PPHN, and including starting nitric oxide. I am not in favor of going for an ECMO, because without knowing the neurological status, the ECMO, one of the things to consider in ECMO is the long-term outcome. So probably until nitric oxide will go on, and then the needed inotropic support, everything would be continued. With all this failed to achieve normoxia, and I would not stop cooling. In our experience, we would have faced this about 3 or 4 babies, and out of which 2 babies did improve with these these interventions, and some babies we could not, whatever we did. But even after stop cooling, the hypoxemia did not improve. So I'm not sure is there any relation, though there is the theoretical risk of cooling increases the pulmonary pressure physiologically also. Cooling does increase the pulmonary pressures.
Absolutely. I think that was very concise, and thank you very much. In our cohort of almost 90 babies, we also encountered 7 babies with severe pulmonary hypertension. 3 of them had to die because it's also had a severe HIE, and hypoxemia got better in 60% of the cases. So moving along, I think Dr. Suja, you can take this. The baby who we have cooled also has sepsis. This is one very unfortunate baby. HIE, sepsis, PPHN, everything is in there. And then would you consider stopping cooling? If not, what are the other measures that you would take in this situation?
Stopping cooling should not be the first option for any of these babies, because these are expected complications and we should be prepared for them. So if there is deranged coagulation, we'll start treating them blood product transfusion, vitamin K administration, appropriate antibiotic techniques. Only if there is severe life-threatening bleeding which is not getting controlled, then that should be then the final decision to terminating hypothermia should be taken.
Thank you. Would you agree with that, Dr. Ravi Swami? Would you?
Yeah, I mean, that's the last thing. In my experience, be about 2 or 3 cases we had to stop cooling because of PPHN was one of the main reason. Of course, you keep monitoring your platelet count, and if you're really struggling, yes, then that is the last option.
Yeah, brilliant. So now I think coming to Dr. Uma here, who volunteered to come as a panelist. How do you manage these babies if they develop seizures, while they're undergoing hypothermia? And could you suggest some of the anti-epileptics that could be used?
So I don't think the seizure management would be any different from normal neonatal seizures. Only thing which we need to remember is phenobarbital metabolism is impaired, so their half-life might be more. So we should not go for 20, 10, 10. We should stop with 20 and then 10, and then move on to the second line of anti-epileptics.
Absolutely, perfect. So second line would be some places.
So we would be phosphenitoin. Sometimes we do levetiracetam.
Levetiracetam.
So phenobarbital, phosphenitoin, or levetiracetam as second line.
Perfect. Also, Sidhu, you want to highlight, say if this baby had seizures under control, we are rewarming this baby, and then this baby gets a breakthrough seizures. Yes. Have you ever experienced it, and yes, how do you manage that?
Quite commonly it happens, sir. 2 complications during rewarming will be intraventricular hemorrhage and breakthrough seizures. As soon as the baby throws convulsions, we try to sedate it with either fentanyl or escalate the anticonvulsant. We look for an intraventricular hemorrhage or any electrolyte imbalance, basically. And we have tried working on it. We try to rewarm at 0.2 degrees Celsius so that the risk of seizures and IVH is reduced with that.
Absolutely correct. I think rewarming can be 0.2 to 0.5 degrees per hour. If yes, the baby's had seizure, then you go really slower than that. And
sir, regarding anticonvulsant, I think your unit is practicing Levera. Would you like to highlight it?
We give levetiracetam as the first lines. One reason is because we think
it has got less sedative action compared to the phenobarbital. And a lot of our neurological assessment gets completely impaired with phenobarbital. However, I realized that phenobarbital role as a chloride on the chloride channel is much better than levetiracetam. So I tend to err on the caution, this one or that one. But if I already diagnosed this HIE and then started cooling, I would use either phenobarbital or levetiracetam. I don't want your unit to change anything because of one unit's experience, right? So moving on, I think Dr. Sujai, you can take this. So you've been cooling this baby or any other babies, you've been cooling for a while, and then you realize suddenly that this may not be just straightforward HIE. There may be an alternative diagnosis that you have to think, which comes under the umbrella of neonatal encephalopathy. Can you highlight on that?
Yeah, there are, when there is no perinatal history or details available, it is known that around 40% of the cases can have some concurrent causes for neonatal encephalopathy. It could be some rare inborn errors of metabolism, some chromosomal disorders, severe early onset neonatal sepsis, or the baby could have an intraventricular or intracranial hemorrhage because of other reasons. So when the history is not very clear that was an acute peripartum event, it is very important our concurrent evaluation and investigations go on. Our blood counts, our blood cultures, the neurosonogram, everything should go concurrently. And when we find that there are very strong features that this is purely neonatal encephalopathy unrelated to HIE, then probably we can consider early termination of hypothermia. This includes both the clinical and lab evaluations.
Brilliant. Thank you very much. Dr. Uma, you have any experience of any alternative diagnosis that you could highlight here?
With the interest in metabolic, like not only in our unit, I do get kind of calls from my colleagues in Chennai, like who have faced this problem. We have had a baby with molybdenum cofactor deficiency who had an exact HIE mimic, not in our unit. There was one chromosomal, malformations, cerebral malformations, which was not picked up antenatally, who we cooled and then we have to withdraw. The alternative diagnosis, which I would think as a treatable inborn errors of metabolism, will be pyridox independence issues. So they can have like increased fetal movement. Primary may not appreciate, but the second gravida would be able to appreciate. So that is one treatable cause which we need to think as a HIE baby.
Absolutely correct. So we had a baby where we cooled, absolutely indicated for cooling. This was a very difficult forceps extraction from a peripheral center, fitted all the criteria. So we cooled. And when we rewarm the baby, you feel like it's crying and all that stuff. So you extubate, the baby suddenly, collapses. Had 2 times had to be reintubated. Then we were thinking, what is happening? Actually, the lower limbs and upper limbs and even the body, there was absolutely no movement at all. Therefore, we had to do an MR with the neck as well. And there was transection of the cord at the C3, C4 levels. So obviously the prognosis became very bad, and then the baby went on a DAMA. So moving on, Dr. Raviswamy, would you change? I think this question will be for all of the panelists. And I would like to get the information first from the other panelists and then from Dr. Raviswamy in the end. Would you change your practice of cooling babies with moderate or severe HIE after seeing the results of the Helix trial? Can we start with Dr. Prakash? So this part is very important. And
actually what happened after this Helix has come, I instead of a lot of things, anything to spell with Helix, starting with heel, we end up saying Helix. That's become the talk of the town. And thanks to the Sudhin trial and others for highlighting that trial. Now here, I think the trial, they're very clearly saying that the take-home message, what I take is, you cannot do cooling on a center with which cannot provide the appropriate care. Now, I do understand they're all conducted in tertiary care centers, but I think they did mention in that they could not provide 1:1 nursing. So I feel, especially in babies with hypothermia, you need to identify earlier signs of deterioration. And also to take other thing which I cannot generalize from the Helix trial is if you look at the population is not comparable in the sense the outcomes and the population. So if you look at many of the data has come out, did not have such a high mortality. And from just, though they did not directly say, the majority of the patient helix have a moderate, but the mortality was very high among moderate. So I think in a center where the mortality rate is very low with perinatal asphyxia, and they can provide a very good care for the neonates, I think we should continue cooling until we have another some helix plus trial or opposite helix trial, which says even in a private sector, it increases the mortality. I would not stop cooling.
Brilliant. So the message is quite clear from Dr. Prakash. Not every unit should be cooling it. First of all, be adequate enough to manage the intensive care, and then you consider this as an adjunct. And Sidhu, what is your opinion on this?
Sir, I agree with most of the things what Dr. Prakash has said. First thing is once this helix trial came, I think I spoke twice, thrice to Ravi sir. He was like, wait for the publication to come out. Why are you hurrying? Because I was worried about the legal implication. In fact, I spoke to you also, sir, about it. The two things. So we have been more cautious. We have not stopped cooling. But I agree with most of the things. We have been more cautious, and this concept of tertiary care is individualized in our country. That is what I believe in, sir, actually. Because see, everyone says 1:1 care provided, but nobody really knows what is going on actually. That is the point. If we are able to give 1:1 care and trained residents are available around the clock, I think we should be able to pool for moderate to severe encephalopathy with better outcomes. In fact, we have one already publication which I've shared with you. We had good results, in fact. But I think we will be more cautious with the helix results, but it will not stop cooling. That's what I would like to say.
I think that is what a lot of people are suggesting as well. So what my opinion there as well would be to add neonatal transport as one of the major things in retrieving these babies. Don't allow them to come in an auto rickshaw or behind a bus or something. So that is one thing which is detrimental, because the time of arrival of these babies, they're already very bad condition. So would you reflect the same, Dr. Suja, or do you have any other opinion on this? Dr. Suja, you have to.
Okay. Okay, so yeah, for the classical cases, we wouldn't be stopping cooling, because the benefits, we still need more evidence to say that it is absolutely not beneficial. But for the outliers, probably as Dr. Sidhu said, we have to be more cautious. 7 hours coming, no classical history, but we are thinking of asphyxia. For those cases, probably we should be cautious, spend a detailed history, be sure that has been an acute perinatal event, and then proceed ahead with the cooling.
All right, thank you. Dr. Uma is waiting anxiously to put her views across. Ravi, I will come back to you. Last one is yours.
With due respect to a well-conducted RCT, I would still continue to cooling because of our own personal experience. I think if there is a well-established inborn unit with a proper sentinel event documented, definitely I think those babies would be beneficial, because in helix, the 80% of them had like moderate, in the sense it was a prolonged HIE, partial prolonged HIE. The other thing is maybe we are kind of contemplating that we should take consent, because previously we have been thinking that it is a standard of care and we were not taking consent. Maybe we have to take consent in these babies, explaining the pros, cons to the parents and carry on with cooling.
I think that's perfectly right. Where consent is not needed is when a thing is a standard of care, a therapy. What it means by standard of care, if a baby is having desaturation, you're supposed to give oxygen. If you don't give oxygen, then you're legally prosecutable. So we're all eager to hear from Dr. Ravi Swami, his opinion and his conclusions. I hope it will be little less drastic than however it panned out in the papers and the newspapers. Over to you, Ravi.
Okay, thank you very much, Pratap. So thank you. I hear all the views from all the panelists. So here are my views. Okay. In terms of the study design, the way the study has been conducted, it is unbeatable. If anyone challenges that, then that will be something
we
which we have to look
Very
into.
well conducted study.
Yeah. So that is out of the question. So nobody can tell what is there anything wrong and stuff like that. So that's why I was telling Sidhu, wait for the study, analyze for yourself, and then take it. So in that way, the results of the study are valid. Okay. So that is the first point which you all need to agree. Now, the second point, now look into, is that applicable to your population? Because when you do a critical appraisal of any studies, you have to answer these questions. Is the study well conducted? And you say yes. And you see if the study results are valid, and you say yes. Now, the third question is the result applicable to my population? And that's where you guys have to take your own calls. So for example, those babies who are born in public sector, if you think your baby is matching like that one in Helix, born to a mother, maybe not that well, very good antenatal care, low birth weight, did not receive proper resuscitation, or the first 6 hours was poor, and so on. Such babies, when you get the baby, think twice before you cool these babies, because this is exactly like a Helix baby. And these babies, perhaps you have to be using caution before you cool, because you know the outcome in such babies. Because if you see the babies who are in Helix, they were all they all had clinical seizures. Most of them all had clinical seizures. So things what you'll start using now is that, I would probably say in my personal practice, is that I would put an AEG before deciding whether I should cool this baby or not. Because in Imperial, all our babies who are inborn, they first get an EEG on the brain, and then you wait for half an hour to 45 minutes, make an absolute decision whether it is mild encephalopathy, moderate, or severe. So that is something which I would really suggest all of you guys, that look for the weight, make sure that this is a sentinel event. All the antenatal scans were perfect. It was a perfectly healthy baby, good weight baby. The blood gas showing the pH is below 7, base deficit above -16. You do an AEG and it is fitting with moderate to severe, and you're absolutely sure that this is fine. This is a baby predominantly like a Western world baby. There's nothing wrong here, and I would go cool. If you have the facility to do an MRI, please do an MRI. Like in Hammersmith, we get our babies, we get it's like babies are born, they go to MRI and then come to the unit. So we can look at whether it's white mat injury or a gray mat. You don't have facility, that's not a big deal. But at least AEG is a must. And be sure that your baby is really fitting the one on the Western world. Please do go ahead and cool. If you are seeing that your baby is looking like a Helix baby, have 2 or 3 opinions, as Uma told, get a parental consent, and then still go ahead and cool. Because the problem is, one litigation comes and the lawyers are waiting for you, and they go with all the, and as I told, I don't think there will be another Helix type study for the next 10-15 years, because I don't see any ethics committee will give you permission. So if it will be only observation studies you'll be putting, and observation study will never come to an RCT. So next RCT maybe after our lifetime, as I see, but keep yourself safe. So choose the population and then go ahead with cooling.
Yeah, thank you, Ravi, for that elaborate, explanation, and the caution that we all need to exhibit in cooling and following this therapeutic hypothermia. And nicely, he's termed these babies as Helix babies. That's that's another diagnosis that we have got. Thanks, Ravi, out of this trial. And any closing remarks from any of you in the panel is welcome.
I would just say the same thing. Just stay safe. Look after your back. In doubt, take 2-3 people's opinion. And as Uma told, consent. If possible, video record that consent. And
okay. Dr. Do not mistake me about this. See, well-designed study is different from just for the audience. Well-designed is different from well-conducted. Well-conducted is, to eliminate a lot of bias. The bias elimination is, there are a lot of bias which we cannot eliminate. And the only bias which I feel is that the mortality rate being very high in a setting, and that's only where, we find it to be difficult. So I think any baby who satisfies for cooling, center could provide, is what I would just, put forward.
Yeah, thank you so much, Dr. Prakash. I think in the end, what I would like to conclude is from the South Neocon panelists as a moderator as well. So I think we should exhibit huge caution
Make sure your selection of the babies is very, very good. Like how we do, majority of our babies are outborn, but then we have a great relationship with the referring center. And I go almost every month to do the training to these people. So you will understand that what they're trying to talk, and you are both in sync. So that is very important. Also consider people who are cooling. I know you will all get the referral where the babies just are brought in. Ravi mentioned one of the things like seizures. So seizures actually is the only objective way of knowing that, everybody will get scared. Mild encephalopathy or even, going on to the moderate, it's very difficult even in the experienced hands to ascertain this as a mild, moderate or severe. The other thing is HIE is a dynamic process. If the insult has happened, the condition can keep getting worse. So you make an assessment for not cooling, but then you go off to sleep is again not on. So therefore, one-to-one nursing care is absolutely necessary in these babies. One last point before we conclude is that even if you're not cooling in this era, you are supposed to document why you are not cooling. That is extremely more important than what you've done as a therapy, right? The baby did not satisfy the criteria, A, B, and encephalopathy was not there. And at the end of the day, you've discussed all with the parents of the possibilities, and maybe we considered up to 6 hours, 8 hours, whatever you want to say. Until that point in time, the baby did not fit the criteria for cooling. Therefore, this baby, although was considered, we did not cool. I think this statement should be there for you in the notes so that medico-legally you're completely covered. Also, as Ravi suggested, we need to make sure the consent is taken, which is possibly with a video recording as well. And then make sure that that is stored. Any, medico-legally, you can still be sued up to 18 years of the child's life, right? So when the child is developing, that is when the people think, oh, my child is not doing well, very severely handicapped. That is when people will feel the anger and they want to come back and sue the doctor. So to cover your backs, please store all this thing until up to 18 years. That is legally also true, right? With that, I think we would like to conclude the panel discussion. Thank you so much for the panelists who could join here. Unbelievable. And then thanks, Uma, for accepting the offer. And Dr. Suja, Dr. Ravi, and Dr. Sidhu, and also our chairpersons. Thank you so much.
Dr. Pratap, for conducting such a nice thing, actually.
Thank you. Can I just quickly comment with your permission? No, thank you. No, thanks a lot, Dr. Pratap and other panelists, Dr. Ravi and Dr. Suja and Dr. Sidhu and Dr. Ravi. This is with regards to Helix trial. So I know that it's a very well conducted trial, and I think it took about more than 400 babies or so. Yeah, it's a big trial. Could acknowledge that trial. But based on one trial, whether you could change our clinical practice or not, that is questionable. I think the systematic review and meta-analysis have shown that therapeutic hypothermia is definitely useful in babies who fits into the criteria. I think take-home message to all the people is from South Neocon is if the baby fits into the criteria, if you have this setup, if you have the team, I think it is better to cool the babies. So a single trial, yeah, it's a very good trial. But based on this trial, I wouldn't change my practice. Thank you. Thank you, one and all.
Thank you, sir.
I'd like to thank Dr. Pratap Chandra for moderating this session, and also thank the panelists. Thank you.
Good afternoon, everyone. I once again welcome you all for the South Neocon 2021. Thank you for joining this afternoon. Before continuing the topic, a small fact about which is the first enzyme which shows a proof of a reaction, a biochemical reaction, a metabolic reaction inside the body was called diastase, which is now called amylase. So going by this metabolic fact, let's start today's session, which is on the topic inborn errors of metabolism, suspect and approach, which is moderated by Dr. Uma Maheshwari B. So I would request ma'am to moderate this session. And the chairpersons for today, for this session are Dr. Ranjan Kumar, and who will be joining us virtually, and Dr. Venkatarama Patari, and our beloved ma'am, HOD ma'am of MVG Medical College, Dr. Premlata ma'am. So I would request her to introduce our moderator for this session.
Yeah, good. Now, our under neonatal mortality, almost about 30% are due to sepsis. Now, we don't know how many of these sepsis babies really had sepsis, how many were due to IEM. Now, we need to know when to suspect IEM and how to approach them. So to conduct this session, we have Dr. Uma Maheshwari, who's an expert in this field. Her field of interest is both IEM and genetics. She is a professor of neonatology at Sri Ramachandra Medical College, Chennai. And we had very good workshops also conducted by her yesterday. I hand it over to you, madam.
Thank you, ma'am, for the kind introduction. So it's my a very good afternoon to all. It's my pleasure to have online as well as offline panelist. So I would call upon, I think Dr. Sendil is attending online. So is he there? I'm not able to see him. Dr. Sangamitra has apologies because she has important meeting. So as Dr. Sangamitra could not join us. So Dr. Abhishek. Dr. Abhishek, are you there online?
Yeah, I am there. I hope I'm audible.
Put on your video as well for us.
Yeah.
Thank you, Dr. Abhishek. So he's associate professor from Mangalore. Dr. Sendil is from Trichy. He's a consultant neonatologist. Dr. Nilesh Rao. So he's a consultant from Cloud9 Bangalore. Thank you. Dr. Prashant. So he's from St. John's. So we heard a lot of innovations from him in the morning session. Dr. Parimala. She's a consultant neonatologist from Aster Hospital, Bangalore. Dr. Chaitali, she's joining.
Yes, ma'am, I'm here, ma'am.
Thank you so much. And she's a consultant neonatologist from Davangere. So when this was given to me, the initially IEM approach and panelist, so I was thinking like, how am I going to take the session? So I thought like, let me demystify some of the misconceptions. And then like, we thought we'll run it as a case-based scenarios to make approach and for a suspected IEM. So we all think inherited disorders are rare. This is a misconception. Maybe it is individually rare, but collectively they are common. So in our newborn screening program, we almost see 1 in 1,400 is the incidence of IEM in our neonatal screening. So the other one is we think that it should be considered only when it is a positive family history. It is not so. So most of them are autosomal recessive with the consanguinity. So I think we have to consider in any consanguineous or non-consanguineous, because it is endogamous population, we need to consider IEM. So IEM mimics sepsis, as madam rightly pointed out. Yes, it is a close differential diagnosis of sepsis. If you do not have any risk factor for sepsis, then suspect IEM. And also it can coexist with IEMs. So say for example, multiple carboxylase deficiency can have fungal infections, and E. coli infection is very common in galactosemia. So it can even coexist. So because we got a diagnosis as sepsis culture positive, we should not think that, oh, this baby do not have IEM. So difficult to remember presentation of each. Yes, I am also in the same board as you all think. It is difficult because there are so many pathways. So what should we do? We should have an algorithm-based approach, and it should be staged from a broader category to a small, highly specified category. And maybe you might think only few are treatable. So why should I kind of do so much to fix it? But it is not for the few treatable. I would think majority are treatable, even though it is not curable. The majority are treatable. And also, what do you, so the family or the parents who is waiting outside your NICU, the baby who has been well and fed very nicely for first 2 days, suddenly deteriorating, they are in ICU. So you need to answer the parents, right? So definitely for counseling, formal genetic counseling, it is important to arrive at a specific diagnosis. The other one is like many of the times we get referral saying that breastfeeding is contraindicated. They said that I should not be giving breast milk to this baby because the baby was suspected to IEM. It is not true. Breast milk has nutritionally advantageous, and definitely it should be given in a quantified amount to any baby. It should be started as early as possible. After crisis, there are only very few absolute contraindications. I would say infantile onset VLCAT, infantile onset long chain fatty acid defect, and galactosemia. These two are the only absolute contraindication. In all other IEMs, we can give breast milk. So with that introduction, so I am going to the case scenarios. First, I would like Dr. Parimala to take this case. So you have a baby who is a term appropriately grown with uneventful antenatal and perinatal period and was discharged on breastfeeding. Baby developed poor feeding lethargy and seizures on day 7 and got readmitted. And the first line investigation showed acidosis and elevated ammonia.
Thank you. Good afternoon, everyone. I would start. Can we just go back to the This is exactly I want to stress, because we know that inborn errors of metabolism, we have a long list of investigations, and every panel you choose, some extra zeros are added to the cost. So how do we choose? Do we ask for every single thing available under the sky, including the genetic test, or we can have some kind of even an idea just with the presentation and little bit of idea, and then go along accordingly, then have the first line, second line, and third line. So here, though the slide looks very simple, with just this clinical history, we can rule out so many of the inborn errors of metabolism. So if you see here, it is a term baby, appropriate for gestation baby, and baby had uneventful antenatal presentation. So all inborn errors of metabolism can present in different ways. Some present fetal. So mothers will keep saying like so much of hiccups baby did. Actually, it would be a neonatal seizure, which mother was perceiving intrauterine. So that's a fetal presentation. So most of the cranial abnormalities, all the maybe some cysts and everything, brain abnormalities, all that associated with the inborn errors present fetal presentation. The next one I said is a perinatal period is uneventful. So the next presentation is at birth. At birth, the baby can present as HIE. That is why we had differential diagnosis of IEM for HIE, because many of them just present with, and also antenatal other thing is decreased fetal movement. So all the tone disorders, whatever disorders of IEM, which causes hypotonia, can present as decreased fetal movement, which mother would have perceived already. At birth, again, baby will be poor tone because maybe paroxysmal disorder. So it is not working. So the baby cannot have a good tone. So that cannot be a healthy baby, which we would have just discharged on day 2. And the third thing is, I said, baby discharged on breastfeeds. So if it was galactosemia, if it was some inborn errors of metabolism, which is going to cause severe hypoglycemia in the baby, the moment baby was on breastfeeds for 2 days would have shown some symptoms. So this baby probably did not have a set of inborn errors, which I told you about. Might still have, we can always rule it out, but that is not the first line of investigation. We are going to look at this baby. This baby presented as a third presentation, which we call as intoxication. Intoxication means it needs, for some metabolites, it needs some time to accumulate in the body. As long as baby was inside the mother's womb, mother was clearing it for the baby. Suppose this baby was some organic acidemia. I would give an example. So mother was clearing the acidosis. So when the baby is born, there is no symptom. And it needs some time for this acids to be produced by the body, accumulate in the body, then cause symptoms in the baby. So these are babies which are going to look healthy at the initial first 2 days, go home and then come back and present because of the intoxication or excess metabolites which have accumulated in the between 3 to 1 week, 3 days to 1 week or anything. So just with clinical, we can have at least an idea before we directly jump into the first line investigation. So once we have this idea, once we are suspecting inborn errors of metabolism, I would even now not say like just because this baby came like this, because this is a panel discussion, we are presenting only the inborn errors related to this. But then this baby, we have ruled out sepsis, we have ruled out other seizures, other reasons for seizures, electrolyte abnormalities, everything, and then gone further. So those investigation you will not find in the first line because those were excluded. So we suspected IEM, and as IEM with this presentation, how did we approach? So first line, I would just mention what first line, Dr. Uma would explain further. So the first line investigation baseline, which we have to do is CBC, because many inborn errors can have neutropenia and thrombocytopenia as a presentation. So if you see that, again, you can list the set of disorders which will have neutropenia and thrombocytopenia. So you can remove the others when the presentation is like that. LFT and RFT, because we have one set of disorders which will present as liver failure. So they will present predominantly as jaundice, liver failure, elevated enzymes. So we can go in that direction if we know the baseline LFT. RFT, because we know that we have urea cycle disorders, we have other disorders which involves the kidneys, and even renal tubular acidosis we have to exclude before we diagnose the inborn errors of metabolism. Simple RFT will kind of give us a clue towards that. Blood gas. So again, find out what is the, whether there is acidosis or whether there is alkalosis, whether there is a normal gas. So acidosis, only the acidemias can present with acidosis. So alkalosis, we have the urea cycle disorder. So we are not going to get organic acidemia with alkalosis in the gas. So we need not investigate for organic acidemias if your gas was normal. It might be a simple test, but we are screening there. And then in the blood gas itself, we can check the anion gap. So as we know, if that much of metabolite is accumulated in our body, our pH and urine pH, even urine ketones and pH, I've not mentioned here, that also we can do because it's a simple test. That much of metabolites to accumulate, urine pH has to be below 5. So if it is something 6.5 or 5 to 6.5, it can still be RTA, not metabolic errors. And then we have, so check the anion gap. So whether it's increased anion gap, normal anion gap. So accordingly, we can always exclude so many of them. Then comes ammonia, glucose, and lactate. So glucose is normal, are all the glucose disorders, all the galactosemias, everything goes away over there. Ammonia is high or low. Again, we'll show you in the algorithm how we can approach that way. Lactate may be high, may be low. That again depends on how much the baby can excrete or how much is accumulated. So with this, Dr. Umar.
Thank you. Thank you so much, Dr. Parimala, for explaining excellently like how you would kind of suspect IEM in this particular baby and also the baseline investigation. Just for just to remember easily, you can remember this as an acronym GALAC, so which stands for glucose, ABG, lactate, ammonia, and ketone. I think in our subsequent case scenarios, we will be talking like as GALAC normal, GALAC abnormal, because even when my PGs report to me, they say, ma'am, GALAC done, GALAC normal. So that will say that, okay, my glucose are normal, ABG normal, lactate normal, ammonia normal, and no ketones. Okay, when okay, so just for the postgraduate learning here, so I have put some scenarios here. So if you have a glucose which is hypoglycemia or low glucose with acidosis, and lactate which is normal or lactic acidosis is present with ammonia elevated and ketone elevated, so we would be suspecting organic acidemia. Okay, so next, if the ammonia alone is elevated so much with respiratory alkalosis, because ammonia being a respiratory stimulant, it can cause respiratory distress and wash out the CO2. So that is my suggestion would be like it would be a urea cycle disorder. If the glucose is low with low ketones, then the possibility is fatty acid oxidation defect. If the glucose is low or normal with no acidosis, but lactate alone is predominantly high, and whenever you repeat it is high. That is primary lactic acidosis, which would include both pyruvate dehydrogenase, pyruvate carboxylase, and mitochondrial. If GALA is normal with ketones alone pouring out, then the possibility is maple syrup urine disease. So subsequently in case scenarios, we are going to bring this up again and again. So having kind of discussed the baseline investigations, what are the second line investigations you would like to do?
So can you have this? So as second line, now because we already know whether it is acidemias or alkalosis or ureocycle disorder, fatty acid disorder, or glycogen storage or glucose disorders, these are the things we do next step. So we do the plasma amino acid, at the same time even urine amino acids, because there are some which can present only as aciduria and there may not be acidemia. So plasma, you don't find anything, but urine is full of acid. So that again, you can find out what it is. So we have to have plasma amino acid and urine amino acids, total and free carnitine, because sometimes carnitine deficiency can be secondary, associated with another inborn error of metabolism. So you just supplement carnitine and that's treatment enough to overcome that inborn error. So we should always check carnitine, even though it's not directly related to what we are suspecting. So acyl carnitine profile and free carnitine, because we know depending on which enzyme it's affected, one of them will be elevated. Urine GCMS for urine organic acid. So it is not enough when we do just the blood spot metabolic screening for most of the babies, what we do, and say that that baby does not have inborn errors of metabolism. We should always do urine. If you strongly suspect, urine and blood should be done before we exclude inborn errors. And galactosemia test, it's simple test, even bedside. Now, before we even used to do along with this urine glucose ketones, which we have done already. So this would be the second line.
Thank you so much, Dr. Parimala. So GALAC plus, so we have added on few plasma amino acids, urine organic acid, TMS, and enzyme assay depending on the condition. So of course, molecular is the final common pathway, which we'll discuss later on in our slides. So this particular baby had a blood urea nitrogen, which is very high, with the TMS showing elevated C3 and the corresponding ratios, which is suggestive of methylmalonic or propionic acidemia, and plasma amino acid showing elevated glycine, and GCMS is showing elevated 3-hydroxypropionic acidemia. So what do you think is the possible diagnosis, and is there an algorithmic approach which we can do in this baby?
Definitely, we have the algorithm for organic acidemias, but it's very obvious here. So you see that there is acidosis. So it is one of the organic acidemias. In that, which one? So there is elevated glycine. It may or may not be elevated sometime, but you definitely have a elevated 3-hydroxypropionic acid. So with that, we can say that probably this is propionic acidemia. That would be the diagnosis. And one other thing I would just like to stress with all this thing is also look clinically. So this plus your clinical, you'll be very well you can narrow it down and accordingly go and approach with the same test with minimum number of tests, but then with the accurate diagnosis. One important thing out of all the investigation, which is very, very important, everything is important, but then very important, which we have to address immediately, is your blood urea nitrogen and ammonia, because if it is severe hyperammonemia and the blood urea nitrogen is so high, within few hours, they can go into irreversible brain damage, also sometimes mortality. So if we can just initiate our hemofiltration, remove all that, do the treatment within few hours, just 2 hours to 4 hours, they can die. So if you can pick up that and immediately act on it. Again, the samples are important. Never take squeeze sample, never take tight sample. Sample should always be from an arterial line or capillary or free flowing sample from a central line. These also make sometimes difference in that lactate and ammonia, how it transported to the lab. So that is also important. Sometimes you may get false results because it was not transported properly. These also should be taken into account. Thank you.
So, do you want to tell about the algorithms as well? Okay. So this is 2 algorithms we have selected because this baby had acidosis as well as ammonia elevation. So with the increased anion gap metabolic acidosis with an abnormal organic acid, it is propionic acidemia. You can choose this, or even if you choose approach to hyperammonemia algorithm, it's not very clear. No, this is not very clear. Okay, so here, if the symptom is happening after 24 hours, because less than 24 hours, it is possibly transient hyperammonemia, it is organic acidemia. So what we learned from this case would be GALAC, which is baseline investigations, and blood urea nitrogen when it is elevated, it is suggestive of organic acidemia. Blood urea nitrogen when it is very low, it is suggestive of urea cycle disorder, because in urea cycle disorder, urea is not produced. So your blood urea, that's a very simple investigation to differentiate. And also we learned about algorithmic approach. So moving on to second one. So we had a baby R who was referred in view of seizures with the decreased activity and continuous hiccups at 5 hours of life. Dr. Prashant, you would be willing to take this case. It's outborn term neonate delivered by LSCS with a birth weight of 2.7 kg. Cried immediately, noticed to have seizures within 1 hour. It's a non-consanguineous marriage and baby had previous sibling death at 21 days, treated for sepsis, meningitis, seizures, and suspected IEM. So what are the potential reasons for you to suspect IEM in this particular neonate?
This baby had a history of previous sibling death, which is not explained. And there were seizures within 1 hour of birth. We talked about therapeutic hypothermia and all. So, but there was, with that background, so there was no history which is suggestive of perinatal asphyxia. So this is a very early onset of seizures. And the thing which is not come up in the thing was, so the after feeding, it actually started worsening is actually what they said. So these are the reasons why we thought it could be suspect IEM.
Thank you. Actually, like we screened because you said it is IEM, screening was done and GALAC was normal. So what are your suspects? Because we discussed GALAC can show organic acidemias, urea cycle disorders, FAOD, MSUD can be picked up by GALAC itself. So this baby's GALAC was normal. So what are the, can you kind of name some diagnoses which will be top in a list with the baby presenting as seizures?
Yeah, so the primary presentation is seizures, as ma'am was saying. So we have different presentations. When you have seizures as the first presentation, that is early onset seizures, you have these differential diagnoses: non-ketogenic hyperglycemia, pyrite oxide deficiency, sulfite oxidase and molybdenum cofactor deficiency, and biotinate. Some case of biotinase deficiency also can present with early onset seizures.
So TMS was done and this is the report. Okay, they said it is normal, absolutely normal. Would you be happy with this report?
Yeah, we won't be happy with the report because most of the time we look for TMS to give us the answers. So unfortunately, in this case, it was all negative for us. So that's the reason why we went ahead to did a urinary GCMS, plasma amino acids and CSF amino acids. So because we were still suspecting non-ketotic hyperglycemia, and this is what the results which actually came back from the lab. I think it must be clear on the screen. Only the monitor has this problem. So just to read out, the left side actually showing the amino acid panel and the plasma, where the red circle denotes the glycine levels, which is very high. And on the right side, you can see the CSF glycine, which is also very high. And lower down, you see a CSF plasma glycine ratio, which is elevated, that is more than 0.08.
Okay, so so it's very true that TMS alone is not sufficient for diagnostic evaluation in IEM. I think we need to go ahead doing like plasma amino acids and CSF amino acids, as rightly pointed out by Dr. Prashant. And I think here the clinical suspicion had turned out to be true and they had kind of diagnosed NKH. So moving on to the next baby. So we had, this is the firstborn of third-degree consanguineous couple, discharged on day 3 and was brought on day 9 with irritability, abnormal movements, and poor feeding. Dr. Chaitali, do you want to comment on this particular baby?
Yes, ma'am. Here this is a case which was discharged, went back home, and it was fine. I assume here the postnatal and antenatal events were normal in this case. And suddenly this baby has presented on day 9 of life with abnormal movements and poor feeding. Any baby which was uneventful, antenatal, perinatal event, and suddenly presenting with abnormal movements, again, index of suspicion should be going for IEM. And also we can keep differential diagnosis of anything. Okay. So since now the GALAC has been done in this case, glucose is normal, ammonia which is normal, lactate, and urine is showing ketones positive. So once when we talk about urine ketones present, we have to either think of diagnosis, two differential diagnosis we can keep in mind. As just now we discussed by the moderator, ma'am, either you can think of organic acidemias or maple syrup urine disease. But since this had normal lactate and normal ammonia, only the ketones were positive. I prefer going for most likely diagnosis for maple syrup urine disease in this case, ma'am.
Thank you so much, Dr. Chaitali. Because we all know that the TMS would take some more time to come. Is there any other alternate option which is available in most of the centers?
Yes, ma'am. When we are suspecting MSUD, one is we can go for MRI with MRS. Also, if there is any clinical history suggestive of any odor in the urine color, also can give us a clue that it might be a case of MSUDs. But the best diagnostic is MRI or MRS features, ma'am.
Okay, this is the MRI and MRS report of this particular baby. So, do you want to please enlighten on this?
Usually MRI features in MSUDs, we get edematous changes mainly in the cerebellar involvement or internal capsule. And also you can see here diffuse restrictions, MRI showing an elevated levels of branch chain and amino acid chain levels in keto acids, ma'am.
Okay, so I think for the postgraduates who are here, I do not know whether there are any postgraduates, but you just need to memorize this particular MRI picture. This should be there in your memory. If you get such picture, it is suggestive of MSUD with the clinical picture. Of course, we should never forget the clinical picture here because baby discharged on day 3 and brought on day 9 with abnormal movements. And this picture, it is maple syrup urine disease. So even before we get the TMS report, we might be starting on treatment. And this is the TMS report we got.
Yes, ma'am.
So what is the significance of this TMS showing very high?
Usually in MSUDs, you get high levels of branched chain amino acid levels in the urine, ma'am. And here in this case, we can see there is very increased levels of leucine and isoleucines. So it is a classical case of MSUDs.
Okay, thank you, Dr. Chaitali, for the beautiful explanation. I think it is important not only for diagnosis, also for closer follow-up. We need to kind of monitor, keep monitoring the leucine level. There are specific targets to achieve at, it depends on age-specific targets. We need to monitor the leucine levels. Thank you so much for giving us the information on MSUDs. So just to be on the treatment slide. So the major principles of IEM would be based on decreasing the substrate, increasing the disposal of toxic metabolites, providing deficient metabolite, and also increasing enzyme activity. These are the 4 major principles, management principles. If you have to apply the same management principles in MSUD, so for decreasing availability, we need to keep nil oral for 24 to 48 hours, and also start on BCAA free formula, and also quantified amount of breast milk as we discussed. For increasing enzyme activity, we can provide thiamine. For increasing disposal of toxic metabolites, not only for hyperammonemia, even for leucine, we can use peritoneal dialysis or continuous hemodiafiltration. And one more thing is to increase the enzyme activity. Now the permanent cure will be to do a liver transplant because the transplanted liver will provide the enzymes. Okay, thank you so much.
Thank you, ma'am.
And we will move on to the next case. And so the pearl here in this case would be MRS would give us a clue. There is a pattern recognition in MRI, and also we learned about management principles. Yes. So moving on to the next baby. So it's a term appropriately grown baby with Dr. Abhishek. It's a term appropriately grown baby with no significant antenatal. Sorry, it's for Dr. Nilesh. It's a term appropriately grown baby with no significant antenatal or intrapartum risk factors and collapsed at 22 hours of life with no spontaneous movement in the postnatal ward. Baby was shifted immediately to NICU and the resuscitation was started under UAL, UVC, started inotrope, etc. But baby did not improve even with your maximal respiratory support. So what are the top 3 differential diagnoses at this point and how would you like to proceed?
So ma'am, in this case, this was a completely normal baby who was well fed, it was in the ward. Sudden collapse, no risk factors, absolutely. So of course, we have to look at the usual BDs that we go with. One is sepsis. But of course, we would want to consider inborn errors of metabolism. And congenital heart disease, this is not the typical time they present. Typically, we have this duct-associated lesions. Typically, 72 hours to 96 hours is when the babies collapse. But of course, we have to keep these in mind. So one of the things to remember, because this presented very much when we look, I think we'll be presenting the case here on, is like, it's like a neonatal spectrum of the SIDS. So we have to always, it is worth remembering that there are a few which present well before the usual presentation of inborn errors of metabolism. So of course, these were the highest on our differentials. We have also ruled out the usual things like low sugars, low calcium, electrolytes, everything was ruled out. The sepsis workup was negative. All the cultures were negative. There was a structurally normal heart, but when the baby was admitted to the NICU, the function was extremely poor because the baby we had a lot of CPR and it was like almost in a moribund state. So in the GALAC, the blood glucose was normal. There was a severe metabolic acidosis. There was a high anion gap metabolic acidosis. Lactates were very high. Plasma ammonia was high. Again, this was post-arrest.
Sorry, what investigations would you like to do?
So after the initial investigations, of course, we have to go into tandem mass spectrometry. Also, we have to do plasma amino acid profile by HPLC. It's a high performance liquid chromatography, and also the urine GCMS. So here we had a difficulty getting urine because the baby completely shut down. And of course, the ancillary studies like tissue biopsy.
So if you have to say that like they have to collect some samples before it's a perimortem sample. This is a report which you have got in TMS and it was showing an elevated C16, C18 levels with abnormal ratios. You got the C16, C18 by C2 as 2 and they gave a report as CPT2 or CACT deficiency. So your diagnosis is right here. So you have suspected IEM. What is the role of molecular testing here?
One of the things is, as a neonatologist, any of us can come across these kind of cases. So one of the things is the parents, extremely anxious parents. Everything is normal. What is happening in your hospital? Why is the baby sick? Is there infection? You're not able to pick up? Lots of anxiety. There is lots of distress both for the parents and for the neonatologist. So having a diagnosis is something that is kind of a closure for the parents, because in this case, the baby passed away. We could not revive the baby. And she had this baby after 8 years of not having a baby. So in this kind of a thing, of course, this is not the primary modality. TMS is the most important. But when you're not getting in the biochemistry and TMS, you're not getting anything conclusive, you can consider exome sequencing. Other thing is, if they are planning another pregnancy, probably this might have a role. And of course, in counseling of parents.
Yeah, well said, Dr. Nilesh. I think I would agree with him. And this particular baby, I think they got a mutation as a homozygous in CACT. and it's well worked up and well done, I would say. It's a pathogenic mutation, so there is no confusion in the prenatal evaluation of next pregnancy. The important things which we learned from this particular is IEM could be an important etiology for apparent life-threatening events or near miss or SIDS, and the importance of molecular diagnosis. So moving on to, thank you, Dr. Nilesh. So moving on to next case. So it's Dr. Sendil. Dr. Sendil?
Yeah, yes.
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 So this is a case you have shared with me. So it's a 38-week, 2.6 kg female baby referred for poor feeding with the yellowish discoloration of eyes and urine on day 10 and showing icterus with hepatomegaly. I think this is a very common scenario, isn't it? So we often see conjugated hyperbilirubinemia. And this particular baby also had a deranged coagulation profile and liver enzyme abnormality and thrombocytopenia. Actually, baby was on DBF, antibiotics and supportive care was given. Appropriate investigation was done in terms of TART, sepsis screen. Ultrasound was not suggestive of EHBA. Metabolic reports were avoided, but the parents asked for discharge on day 17. But they turned to you on day 35 with the abdominal distension, with the liver cell failure in terms of hepatosplenomegaly and ascites, with the investigation showing anemia, elevated CRP transaminases, cholestatic jaundice, and hypoalbuminemia. At this juncture, what are your differentials?
Actually, it's everyone will be looking for it's an neonatal cholestasis syndrome, and initial septic and torch investigations are normal. So we have been strongly suspicious of an IEM etiology. That means acute renal failure related to an metabolic liver diseases. So we thought of an metabolic issues like which particularly affecting the liver, especially like galactosemias and tyrosemias and fatty acid oxidation deficiencies. And the reason behind this, baby is actually is getting worsened with direct feeding on our breastfeeding. The baby is getting worsening of an liver parameters, as well as the baby is going for a liver cell failure, and torch and septic screenings were negative. So we strongly suggest it is a metabolic.
So among this, is there any bedside test which would clinch the doubt?
Yeah, sure. That's same. We can go for an red reflex, and we can look for a cataract, zone like cataract.
I think this is a very important message. So do not have to do complicated tests, etc. If there is such a baby, if you have a ophthalmoscope and look at the red reflex, it can be evolving. Maybe you would have done red reflex at the time of birth and it was deemed as red reflex was present. But like it can be an evolving cataract because of the underlying metabolite being accumulated in the eyes. So definitely looking at the eyes and looking for absent red reflex would definitely give us a clue. So what would be the line of management, Dr. Sendil?
So usually only on supportive management, and usually we need to stop the breastfeed, and we must be going for a lactose-free diet, maybe on soya milk, soya-based formulas, and usually we'll give an only on supportive management. For a dearranged renal, for dearranged liver parameters and coagulations, we support with an FFP, and since there is an hypoalbuminemia and ascites, so we given albumin transfusions. So rest of the things is only on supportive, and babies improves with this lactose-free diet and supportive measures like FFP and albumin transfusion.
Yes, actually, like maybe even when there was a deranged liver profile, when the baby was put on galactose-free diet, slowly the metabolites get better. So her ascites improved and the baby also improved because like you have promptly recognized and have put on lactose-free diet. What do you think would be the long-term outcome of these galactosemia babies? How do they do?
So usually sometimes they will have some ovarian failure, and sometimes they have endogenous galactose productions will be landed with an intellectual defect.
Yes, that is very important point to remember. So that's why even developed nations are contemplating whether to include galactosemia as a screening because it is not entirely treatable. Even if we are kind of absolutely spot on the diet, giving only galactose-free diet, sometimes there could be some endogenous galactose production which can go and affect the brain and cause intellectual impairment. If it is a female baby, they do a ovarian wedge biopsy and keep it in the earlier phase itself. They put it in frozen state so that they can have a IVF pregnancy in the later life. So because it is an anticipated complication in female galactosemia babies. So these are the timelines with which a neonatal liver cell failure will present or liver cell failure will present in terms. Apart from GALD and neonatal hemochromatosis, day one itself, there is liver dysfunction, it can be mitochondrial. Because galactosemia, it comes around a week's time. Of course, UCD, OA, FUOD will have also encephalopathy as a presentation along with the liver dysfunction. Tyrosinemia almost around 2 weeks. It can be congenital disorder of glycosylation. By 6 months, when the weaning food is started, it will be a hereditary fructose intolerance. Somewhere after 4 years, it is Wilson's. So with this case, we learned 2 important things. What is the bedside clinical examination to be done, and what are the etiologies of metabolic liver disease? Thank you, Dr. Sandil, for participating. So next case, I think because the organizers are saying want of time, this is Dr. Sangamitra's case. I'm skipping this because she's not there in the panel. Not moving. Moving. Pulling. While we'll wait for the presentation to come up there. Sir, this is the last case. We are finishing with this. Dr. Abhishek, we have not involved Dr. Abhishek. Please go back. Dr. Abhishek, like you have faced with a similar situation as the rest of the panelists. You have a baby who presented, like previous slide, presented with an uneven full antenatal and postnatal period, presented with hyperammonemia. Previous slide. Previous slide. Okay, so you had a baby who had uneven full antenatal period, referred on day 3, lethargy, poor feeding, encephalopathy. We have been discussing GALAX so commonly now. This particular baby did not have acidosis, had high levels of ammonia. Because as Dr. Parimala told already, I think increase in ammonia is very dangerous to the CNS and you have to take care. Can you give us some guideline on when you should be starting on any therapy for ammonia?
Yes, ma'am. Yeah, this baby that was admitted here basically had very high ammonia. So we knew we are dealing with a case of hyperammonemia. And ammonia is very bad for the brain. This baby already had encephalopathy and was ventilated. So roughly we can say something less than 250, we can go for medical management. 250 to 500, I would definitely arrange for peritoneal dialysis because that is easier to arrange, and if feasible, arrange for hemofiltration. And more than 500 or more than 1,000, definitely go ahead and do a peritoneal dialysis or a hemodialysis.
So this particular baby was ventilated in view of encephalopathy. Peritoneal dialysis was done successfully, and after 48 hours, ammonia was reduced. And as we discussed, TMS, GCMS, plasma amino acids were done, except plasma amino acids showed a mildly elevated glutamine. All others are normal, and baby was neurologically normal at the time of discharge. So as most UCD, fatty acid oxidation and organic acidemias are reasonably ruled out by the above report, what are your differential diagnoses in this particular baby with hyperammonemia?
Yeah, at this stage, we had very few DDs left with us because hyperammonemia with the normal ABG. So we were thinking in terms of transient hyperammonia of infancy. Second would be citrine deficiency, other acquired causes or a portosystemic shunt. But the most important thought in our mind was about the proximal urea cycle disorders. One of them being the CAVA, CA5A gene mutation and carbonic anhydrase 5 deficiency.
So well said. I think these are the other differential diagnoses which we need to keep in mind apart from fatty acid oxidation defect, organic acidemia, and urea cycle disorder. This baby was discharged on special formula and appropriate treatment. And you have done a molecular testing because we discussed that molecular should be a part and parcel. So I think we kind of discussed about this question already. What is the clinical utility of exome sequencing? And of course, it would help us to kind of help in diagnosis of newer IEM and also in some certain disorders. I would like you to say that what is the likely prognosis in this particular neonate because you have got a molecular testing which is diagnostic of CAVA.
Yeah, this baby was neurologically normal even at the time of discharge from the NICU, and definitely hyperammonemia, if managed promptly, the prognosis is good. And this child is currently 18 months old and is growing well with normal neurodevelopment. And the family has been provided with a medical care plan in case there is any decompensation. So this is very promising for us because even we are hearing and dealing with this particular condition for the first time. And family also has a genetic diagnosis in case if they want to plan for the next pregnancy, they have a report of the index case.
Thank you, Dr. Abhishek, for bringing in a newer perspective in terms of a very well prognosticating factor, and it usually produces only transient changes during crisis alone. Otherwise, CAVA deficiency, they do developmentally normal and they do really well. So I think we kind of spoke in this as a newer diagnosis evolving with expanding use of genomics and treatable cause with good prognosis. So with that, like I would like to conclude. Can I have one concluding remarks from everyone? Okay. So I would like all my panelists to tell one point to take home for the delegates. Dr. Parimala.
Clinical examination and algorithmic approach.
Thank you. Excellent.
TMS normal does not exclude IEMs.
Absolutely. So especially when we are asking as a newborn screening, they will not report glycine elevation at all. Very well brought out in that particular case. Thank you.
Again, be aware of causes of the same thing. Like if everything else is normal, there are other modalities available. Of course, get help, expert help, and other new things like exome sequencing.
Dr. Abhishek.
Yeah, any sick IM child, especially with hyperammonemia, proper intensive care, good supportive care, going for advanced modalities like even peritoneal or hemodialysis can be life-saving.
Thank you. Dr. Chaitali?
In case if we don't have any MRI facilities, we can get done TMS is unlikely or not affordable. Even MRI can pick up most of our IEMs. So you can go for MRI and then send a TMS workup.
Yeah. Thank you. Dr. Sendil?
Yeah, simple clinical clues like doing a red reflex and always suspect whenever we having in cholestasis, and eye examination is vital, and don't forget to include an metabolic screening whenever there is a progressive rise in cholestatic.
Thank you. Thank you so much. I immensely thank all the panelists online and offline who have been with me, and thank you for sharing your cases. Thank you so much.
Thank you, ma'am.
Thank you.
Thank you.
Thanks a lot, Dr. Uma, for your excellent and informative talk. Thanks to all the panelists, so Dr. Parimala, Dr. Prashant, Dr. Nilesh, Dr. Abhishek, and Dr. Chaitali. Can I check 30 seconds, ma'am? Yeah, just 30 seconds. A couple of quick comments. whenever the baby presents with conjugate hyperbilirubinemia, so while investigating for metabolic causes like if you're suspecting galactosemia, let's say that baby presented with conjugate hyperbilirubinemia, deranged coagulation, and deranged LFTs, but you won't see kind of hyperglycemia or the ocular cataracts all the time. So when you're investigating for galactosemia, when you send for the full metabolic screening, or when you wait for a Galliput, you could consider starting galactose-free formula feeds, so that is soya formula or amino acid formulas. I think there is a take-home message. Yeah. Just one more quick comment, ma'am. While investigating for these metabolic causes, you've sent the metabolic workup, full metabolic workup, and also genomic exome sequencing. That will take time. 10 to 14 days. Genomic exome sequencing will take about a month time. In the meantime, shall we consider to start a metabolic cocktail that includes thiamine, biotin, carnitine, coenzyme Q, pyridoxine, etc.?
That last slide of treatment was missed in my presentation. That had the lytic cocktail, that vitamin B12 with that carnitine I mentioned earlier, plus thiamine, and also a couple more actually, pyridoxine. So this has to be given, and if possible, 24 to 48 hours of feed withdrawal till we rule out all the inborn errors, and fluids and correction of the acidosis and all that. So supportive treatment has to be given, because that's the only thing we can do till we get a diagnosis. Thank you.
Thank you.
Sir, I would just try to add. I think generally we are now moving away from the term metabolic cocktail. We want to be kind of very specific for the specific condition. Of course, I think we would be kind of evolving into that ultimately. Sir, the initial thing is fine. Like afterwards, continuing would be kind of tailor-made depending on the diagnosis. We do not have to have a molecular testing. Even with the biochemical testing, we would be able to kind of start on appropriate. Say, for example, if it is MME, B12, if it is propionic, it should be biotin. If it is MSUD, thiamine. So it can be kind of tailor-made depending on the initial investigation. We do not have to wait for molecular. That's what I try to convey across.
Thank you so much. Thank you so much, ma'am, for that insightful time. Now we have our ever dynamic, energetic, and young NNF secretary, Dr. Prashant Gowda, for a talk on influenza and its vaccination. This is going to be like a rapid fire. Over to you, sir.
So he's telling me don't take much time. Anyway, good evening all. So this is a sponsored talk. So that is the disclaimer what I would like to do. Yeah. It's not working. Yeah. Nothing, just change. It's not working. Yeah, it's okay. So, second, how to go back? Which way it's going? Yeah, so it's on influenza. Prevent what can be prevented. We are very much aware of this particular line because we are going through pandemic. The pandemic which we have heard in last 100 years is influenza, and now to that list, coronavirus infection has been added. And we know how important it is that vaccines can have a major role in preventing flu and influenza. It's stuck. Okay. So basically, whatever we can prevent by vaccination, we need to do so. And flu is something which has got that thing of vaccines and which has made a huge impact after the vaccines have come for flu. And we know how the flu spreads from the animal host to human host and human to human. So among this, we have type A and type B, which we have, which can cause epidemic and pandemic is a type A one.
So type B1, known to infect only humans and seals. And they have different varieties of strains. And every year to this list, it keeps getting updated. And from trivalent to now we have quadrivalent. And we are trying to cover based on the region which particular strain is common. And every year, that's why we need to take flu vaccination. So basically, flu vaccination is given 6 months, above 6 months of age, anytime it can be taken. Not just we should vaccinate the kids, we need to vaccinate the adults as well. And this is the number of positive cases, what we have seen, Indian epidemiology. This is how we have seen the number of serotypes. So this is the study which has been done on the type of which strain types. So 42.3% is type B. This is again, the study shows that India has high positive cases of influenza B, 37.8% as compared to the Asian countries like China, Philippines, Malaysia. So we need to choose tetravalent vaccine because best benefits influenza epidemiology, offers broader influenza protection, and has got good safety and immunogenicity. And based on our clinical practice, we have seen that following the vaccination, we have seen very minimal side effects in with the flu vaccination. And this is the history of Spanish flu, which we have seen in last 100 years. Next, seasonal flu versus influenza pandemic. And the corona is almost behaves in a similar way. Requisites during this time, as we know that we are going through this phase of corona pandemic, it is important that flu vaccination needs to be taken because the symptoms, clinical symptoms and signs are similar. And if there is a co-infection with flu and corona infection, the mortality and morbidity will be higher. And that's the reason why WHO, CDC, and all the health bodies are recommending flu vaccination for both kids and the adults. And that doesn't mean that it's going to protect, as it has got a cross protection against corona, no. But we are trying to reduce the already endemic and as a potential to become pandemic flu infection by giving vaccination. So that's why it is recommended at this juncture. And the influenza virus, this is the basic structure. H1N1 or H1N5 based on mutation what we see in new neuraminidase and the hemagglutinin proteins on the surface protein. Signs and symptoms we are very much aware, and this is what we see flu-like symptoms, which is very common. And with the intervention by vaccination and preventive strategy like cough etiquette, we can reduce and mask person-to-person contact. With adequate distance maintaining, we can reduce the pandemic outbreak, and that is what we have learned with our, what we are going through right now. Influenza, when we take influenza, mortality of influenza, it is around 8 to 10% as compared to 1 to 2% of corona. So any infection for that matter, if the hygiene part, health education and vaccinations is done at appropriate time, health education, health awareness is given for the health professionals and for the public, we can reduce the mortality and morbidity. So influenza is highly contagious. That is what we have seen, but it can be prevented with effective vaccination. So as a practicing pediatricians and neonatologist, we recommend all age group who are above 6 months to take flu vaccine. The first shots when they are taking, we recommend 2 doses with 1 month apart. Subsequently, yearly vaccines they need to take. And it is not just the kids, even it is recommended for the adults and adolescents, the entire age group beyond 6 months of age. So thank you very much. We will be having our GBM meet at 5:30 in All Hay. Physically, whoever have come to the venue, they can come and attend the GBM meet. This is only for NNF Karnataka state members only, not for outside Karnataka members. So thank you very much.
One country that switched from PC. So, as I said several times, when a country goes and uses vaccine A and decides to go to vaccine B, which is more expensive, there must be a reason for that. But we have the data. And in some countries, it's based on their frustration. Belgium has a frustration that they tried PCV10 and went to PCV13. And some other countries have decided just to go to PCV13 because they found out that it's not that much of a difference of a cost, and they could afford to go to PCV13. But as I always state, at the moment, there was no one country that switched from PCV13 to PCV10 based on quality. It was always the price. And the country that switched from PCV10 to PCV13, it was based on quality, even if it was more expensive.
Influenza vaccination is important not only for children, but also adults during the current pandemic. The impact of influenza is not restricted to children only. It can affect all age groups. Children have high levels of physical contact with parents, caregivers, and others, hence spread the virus easily, which makes even adults vulnerable. People with underlying diseases like asthma and diabetes are at a high risk of influenza-associated complications. Influenza viruses have been detected in about 50% of asthma exacerbations in adults. Diabetics are 6 times more likely to be hospitalized with flu-related complications. In fact, they are almost 3 times more prone to death with influenza. Vaccination of children as well as adults reduces vulnerability of the entire family against influenza. Influenza vaccine offers benefits to both children and adults as it reduces the risk of transmission to vulnerable groups. Influenza vaccine in children and adults reduces 74% PICU admission, 40% older adults hospitalizations, 82% ICU admission, 59 to 78% of asthma attacks, and absenteeism in working adults. Adults often neglect vaccination as they are unaware of the threat of vaccine-preventable illness, or they believe that a healthy person does not need vaccination. Pediatrician plays an important role in educating the family, keeping the entire family safe. CDC recommends flu vaccination as it not only reduces the overall impact of respiratory illnesses on the population, but also lessen the resulting burden on the healthcare system during the COVID-19 pandemic. Vaccinate today, before the onset of monsoon, and protect everyone from influenza before the onset of monsoon. Choose Flu Quadri, the WHO pre-qualified influenza vaccine available in India.
कुछ नहीं भाई सब उधर ही है
ಎಲ್ಲ ಅಲ್ಲಿರೋದು
बंद करेंगे सब ले वो सचिन पेनड्राइव में कॉपी कर लेता है भाई वो सर पेनड्राइव किधर है पेनड्राइव आपके पास है क्या पेनड्राइव ले गए साथ में पेनड्राइव
सब वैसे देके भेज दिया
चलो भाई चलो आ जाओ लेके इसको दिया पेनड्राइव